Okay, so I told you about these hyperacute, acute, chronic, and the graft versus host disease. And I also told you about the timelines that you must remember in order to diagnose a type of reactions. First, we talked about these hyperacute reactions, which occur within a minute of the, after you connect your organ with the host body. Then the acute, which occurs within 6 months, weeks to 6 months. Then the chronic, which happened after the 6 months and up to the years. And graft versus host disease, it varies in timeline. Okay, I told you about the symptoms that you're going to face in the graft versus host disease in the patients, and that would be your skin symptoms, which includes a rash over the skin inflammation. Then the liver symptoms, which includes LFT raised, and the jaundice, the hepatosplenomegaly, and the hepatitis mainly. Okay, then the GI symptoms I told you about, these diarrhea, weight loss, nausea, vomiting that you will get. And I also told you that if it is a liver transplant, not the bone marrow transplant, then you won't get the liver symptoms. You will get just the skin symptoms and the GI symptoms. Okay, and with these things in the mind, let's talk about the immunosuppressive agents. Before we start the immunosuppressive agents, you need to know the pathway of the activation of your T lymphocytes or the B lymphocytes. Okay, so what happens when a antigen is presented to the T cell receptors? Ultimately, the T cell receptors will activate this calcineurin, which is a protein that activates the NFAT. Okay, and this NFAT finally goes to your liver and activates the NF-kappa B, as you can see here. And ultimately, this NF-kappa B gonna release your inflammatory cytokines, and it is mainly the interleukin-2 that I told you about, that causes the proliferation of all of these cells, B lymphocytes, T lymphocytes, macrophages, NK cells. Okay, finally, this interleukin-2 will bind to the receptors on these T lymphocytes or the B lymphocytes, the interleukin-2 receptors. Remember the interleukin-2 receptor deficiency, what it will lead to? Anyone? Interleukin-2 receptor deficiency? Yeah, exactly, skip. Okay, so after binding to the interleukin-2 receptor, it activates this mTOR protein, which is a target of rapamycin. Okay, and it will lead to the proliferation of further genes. Okay, and finally, the synthesis of the purine and the pyrimidines will occur that lead to the DNA replication, and that's how your cells will replicate, will divide and increase their number, and that's how our immune response is generated against the grafted organ, right? So every drug that you will study will inhibit one of these reactions or the pathways, right? And first comes the drug, the cyclosporins or the tacrolimus drug. Okay, cyclosporins and the tacrolimus drug with both inhibits the calcineurin. You should know the name about this FK binding protein to which this tacrolimus bind and ultimately inhibits the calcineurin, and as a result your T cell can never be activated because it requires NF-kappa before the activation, right? So this process inhibits here. Then comes the glucocorticoids. You already know these are the inhibitors of your NF-kappa Bs and inflammatory cytokines. Okay, then comes two drugs, the daclizumab and the basiliximab. Okay, and they inhibit these interleukin-2 receptors. Okay, similar to the tacrolimus, there comes a sirolimus drug, which actually inhibits the target of rapamycin. Okay, then I have already told you about this mycophenolate drug, which inhibits the IMPT hydrogenase, and this enzyme converts the IMP into the guanosine. Remember, IMPT hydrogenase. So it is inhibited by the mycophenolate. Then comes the azathioprine, and it is a prodrug of the 6-merceptopurine. 6-merceptopurine is the activated form of the azathioprine, and they inhibits the PRPP aminotransferase, which converts a PRPP into the IMP. Okay, so let's study one by one these drugs. So each one of these drugs ultimately blocks the activation or the proliferation of your lymphocytes. Okay, and these drugs should be given to every patient who is receiving an organ transplant in order to suppress the immunity, of course, right? So first comes the cyclosporin drug. Like I told you, these are the inhibitor of the calcineurin. Okay, and calcineurin ultimately inhibits the transcription of the interleukin-2. Like I told you, they inhibits the NF-kappa B and inhibits the transcription of the interleukin-2. Okay, where you will use them, of course, the psoriasis, rheumatoid arthritis, or of course, the organ transplant. You should remember the toxicity of these drugs, the side effects, and the most important one is the nephrotoxicity. And how you will diagnose a nephrotoxicity by, by looking at the lab reports, you will find the increased creatinine level. Okay, the patient might complain of the flank pains. Okay, and maybe the oliguria also. The patient could also get the hypertension, hyperlipidemia, neurotoxicity, and most importantly, the gingival hyperplasia and the hirsutism. These are three important things: the nephrotoxicity, gingival hyperplasia, and the hirsutism. Okay, most important. And then for the nephrotoxicity treatment, you can give the patient verapamil or the diltiazem, because these drugs are actually a P450 inhibitors, and these drugs, these cyclosporin, metabolize through the P450. So ultimately, if you inhibit the P450, you will decrease the dose of this cyclosporin. So, if you decrease the dose of this cyclosporin, you will get the less toxicity of the drug. Okay. And yeah, then comes the tacrolimus drug, which binds to the FK binding protein, okay, or the FK506 binding protein, FKBP, okay, and similar to the cyclosporin, they inhibits the calcineurin and ultimately prevent the transcription of the interleukin-2. Okay, the side effects are similar to that of cyclosporin, except they do not have the gingival hyperplasia or the hirsutism. Okay, so you will get the nephrotoxicity, you will get the increased risk of diabetes, but no gingival hyperplasia or hirsutism. Okay, like I told you, all of these drugs are highly nephrotoxic. And if you give them along with the P450 inhibitors, then you must decrease the dose of these drugs. Otherwise, you will get the toxicity. Okay. Then comes our drugs, sirolimus. Like I told you, these are the inhibitor of a target of rapamycin, which is mTOR. Okay. And just like the tacrolimus, they also, work by binding to the FK binding protein, and ultimately they inhibit the response of this interleukin-2. So both of these drugs inhibit the transcription or the formation of the interleukin-2, and this sirolimus inhibit the response of this interleukin-2. Okay, and you mainly use this drug for the kidney transplant. You cannot use these drugs for the kidney transplant because they are nephrotoxic. So in case of kidney transplant, what drug you use? You will use the sirolimus. Okay. And one of the side effects of this drug is the pancytopenia and the insulin resistance that you must remember. Then comes a drug, basiliximab, which inhibits the receptor for the interleukin-2. Okay, and MAB, that means it is a monoclonal antibody. Okay. Then comes a drug azathioprine, and its activated form is 6-merceptopurine. And like I told you already in the biochemistry section, they inhibits the PRPP aminotransferase, which converts a PRPP into the IMP. So ultimately, they're inhibiting the nucleotide synthesis, or more specifically, purine synthesis. Okay. So you use these drugs for the rheumatoid arthritis, glomerulonephritis, other autoimmune conditions. And one of the side effects of the drug is the pancytopenia, because they're preventing the synthesis of DNA or the RNA inside the cells. So you will get the pancytopenia. And one of the most important things that you must remember is that they inhibit both the salvage pathway as well as the de novo synthesis, because you know that this PRPP aminotransferase enzyme is actually required for both the de novo as well as the salvage pathway. Remember the HGPRT, APRT, and the PRPP. So ultimately, you are inhibiting both the de novo synthesis and the salvage pathway. And you must know that the lymphocytes, when they're replicating, they're dependent mainly on the de novo synthesis, and rest your neutrophils or other cells, they're dependent on both de novo and the salvage pathway. So by giving the azathioprine, you are inhibiting both pathways. That means you will, losing your all cells, neutrophils, lymphocytes, and RBCs and other cells. So you will get the pancytopenia. And like I told you, it is these drugs are activated by the HGPRT enzyme and metabolized by the xanthine oxidase. And if you give the patient xanthine oxidase inhibitor like allopurinol or the febuxostat, what you will get the toxicity of this azathioprine. Okay. Then comes the mycophenolate, and it inhibits the enzyme that converts the IMP into the GMP, which is the IMP dehydrogenase. So ultimately, you are just inhibiting the de novo purine synthesis, not the salvage pathway. salvage pathway could still be activated. And like I told you, that lymphocytes are mainly dependent upon the de novo synthesis only while they are replicating. While other cells like neutrophils and RBCs, they can use the salvage pathway also. So in case of mycophenolate, you will get just the mainly the lymphopenia, okay? Mainly the lymphopenia, not just the pancytopenia is not the thing here. You will mention it and you will say that it's just the lymphopenia you will get in the mycophenolate toxicity, okay? And of course, if you get the immunosuppression, what you will get is a CMV related infection, which is pneumonia. And you will see whenever they want to give you a case of cytomegalovirus pneumonia, it must be a patient who is on the immunosuppressive drugs, okay, or the patient who is HIV. But most important, they will give you a history of transplant, of an organ transplant, whenever they want to give you a case of this CMV infection. Okay, then comes the glucocorticoids, and they basically inhibits the NF-kappa B, suppressing both the B as well as the T cell response. And like I told you, these glucocorticoids are actually responsible for the apoptosis of the lymphocytes, and they can also cause the neutrophilia. Okay, so neutrophilia and apoptosis of T cells, lymphopenia and neutrophilia you will get. You must remember the symptoms or the toxicity symptoms of these glucocorticoids. So you will get the Cushing syndrome. Okay, you will get the osteoporosis that can lead to the fractures at very early age. You will get the hyperglycemia, of course, that increases the glucose level in your body. Okay, and ultimately the diabetes, of course. You will get the amenorrhea. In the females, you will get the adrenocortical atrophy, because if you give the patient external glucocorticoids, then your internal glucocorticoid will be suppressed, and you will get the atrophy of the adrenal glands. You will get the peptic ulcers, because by inhibiting the the prostaglandins, what you will get the loss of that. Yeah, someone is saying something. No, because if you lost the prostaglandins, so what you will get the peptic ulcers. You can also get the cataracts because of these glucocorticoids. Very important thing, cataracts. And you will get the avascular necrosis of the femoral head. Remember one more disease in the biochemistry section I told you that leads to the avascular necrosis of the femoral head. Anyone remember?
It was a disease, Gaucher disease.
Yeah, exactly. The Gaucher disease. You will get the pancytopenia, hepatosplenomegaly, multiple pain in your body, and ultimately the avascular necrosis.
Yes.
Okay, so remember this thing. In the musculoskeletal chapter, you will study about this avascular necrosis, and there they will list all the causes that lead to the avascular necrosis, and one of them are the glucocorticoids and the Gaucher's disease. Okay. Then, like I told you, they causes the demigration of the WBCs, especially the neutrophils from the wall of the blood vessels, and as a result, you will get the neutrophilia, but you will get the lymphopenia also. Okay, and whenever the patients on the glucocorticoids undergoing any kind of surgery, or they will get the infection, then you must increase the dose of your glucocorticoids. Otherwise, what they will get is a adrenal insufficiency or the crisis that leads to the death even. So, they can test you on this by giving a patient who was on the glucocorticoids, and suddenly while operating in the surgery room, he died, and they can ask you what was the cause of the death. So it would be the adrenal crisis. Okay, so yeah, adipose issues, you will get the lipolysis, central fat storage that lead to the Cushing syndrome. In the adrenal cortex, you will get the atrophy. Bone, you will get osteoporosis. In the immune system, you will get the suppression. In the liver, you will get the increased gluconeogenesis that can lead to the diabetes. In the skeletal muscles, you will also get the atrophy. The muscle wasting occur in case of glucocorticoids, and that is one of a symptom of your the Cushing syndrome. In the skin, you will get the thinning, you will get the striae, which are a symptom of your Cushing syndrome also. Okay, any doubt?
Sir, can you repeat from the death case?
Okay, so if the patient is on the glucocorticoids therapy, like I told you, he will have this adrenocortical atrophy. Now, if you are having the, if you have a normal adrenal gland, then what happened during the stressful conditions, the synthesis of your cortisol would be increased, right? Remember? Whenever you encounter any infection, whenever you're having the stress, whenever you're in the
Can you
surgery.
just
Yeah.
Mr. Bhanu Chaudhary,
Yeah.
can you just stop for a while? We are not listening properly. Your voice is being cut and it is quite incomprehensible for us to understand.
Oh, okay. Just a second.
I'm still not able to comprehend what are you saying. Kindly
Okay,
just
let me repeat it again, okay, for you. So what happens is when the
can you
patient
hear
is,
me?
yeah,
Can you please just type in the chat box? What are you saying?
okay, let me just type it in the chat box for you. Just wait for a second.
Cannot hear anything.
Yeah, I'm typing it in chat box, okay? Or should I type it later?
Your
Okay.
voice is clear.
Okay, sure. I will type that later, okay? So
Yeah, I
just know
can
in
also
case,
hear you.
yeah. Okay,
Yeah.
so in case of adrenal insufficiency, what's gonna happen is if you get the infection or you're in the surgery room, then you need to increase the dose of the glucocorticoids. Otherwise, you're gonna
Okay.
have this adrenal crisis, okay? That can lead to the death. Just know for now. I will type that later in the chat box if you want, okay? And you should know one more fact about the cyclosporins, that they decrease the uric acid excretion. Of course, that makes sense because you will get the nephrotoxicity. You will get the dysfunction of your kidneys, right? So because of this dysfunctional kidneys, you will get the high uric acid in your body and that can lead to the gout. So note down the fact also. They can ask you the question over this. Okay.
Sir, can you explain that diltiazem with nephrotoxicity?
Yeah. If the patient is on the cyclosporin therapy, okay, like I told you that it is metabolized by this P450 enzyme. So if you give the patient diltiazem, remember the diltiazem vasodilator, what it does, it will vasodilate the renal blood vessels. Okay, that is the one thing. And second thing, this diltiazem is actually also a P450 inhibitor. So two things are happening. One is the vasodilation of the renal vessels, and second is the P450 inhibition. So if you get the P450 inhibition, you can easily lower the dose of these cyclosporins, right? And if you lower the dose of cyclosporins, you will get a less nephrotoxicity. Okay. And second thing, you're increasing the the blood in the kidneys, right? So you're actually also doing the loss in the I mean, that is kind of a beneficial thing, right? Two things are happening. First is a vasodilation and second is a P450 inhibition. And both of these things are very beneficial for your kidneys. But if you do not lower the dose, then you will also get the nephrotoxicity, of course. You need to lower the dose if you're giving the patient P450 inhibitors. Okay, so two things with the calcium channel blockers, diltiazem. First is the vasodilation, second is the P450 inhibition. That is kind of a renal protective. Okay.
Okay, sir.
Any doubt?
Yes.
Yeah. So now we will talk about the bone marrow stimulation drugs. First is the erythropoietin, EPO analog, erythropoietin alpha, and that you will use in case of anemias to boost up your RBC production. Second is the colonal stimulating factors, CSF. They are GM-CSF and the GCSF. The GCF and the GCSF are the someone knows the name, the granulocyte colony stimulating factor, and for the GM-CSF it is name. I've told you about this. Granulocyte monocyte colony stimulating factor. Okay, so GCSF and GM-CSF. Filgrastim for the GCSF, circumstim for the GM-CSF, and where you will use these drugs for the leukopenia. Okay, whenever you have this neutropenia and the lymphopenia or the monocyte and lower monocyte counts. Then comes a thrombopoietin drug, okay, which is the romiplastim. I never encountered any question on the name of these drugs. They will just tell you about the thrombopoietin or the erythropoietin or the CSFs, but never the name, okay? So thrombopoietin you will use in case of thrombocytopenia because they are the platelet stimulators. Then you must remember the name of this interleukin-2 agents, which are aldesleukin, okay? And you will use these drugs in the renal cell carcinoma or the metastatic melanoma. Then I have already told you about this and these interferons. The interferon gamma especially used for the granulomatous diseases, okay, because it help in the induction of the granuloma. Okay, then comes the interferon alpha. You can remember it by the mnemonic ABC. Okay, alpha for the hepatitis B, hepatitis C, and the renal cell carcinoma. Okay, then interferon B for the multiple sclerosis. And there's one more drug which is an immunomodulator, and it is the imiquimod. Okay, what does this imiquimod do? It will inhibit the synthesis of your blood vessels, the formation of the blood vessels, which is the angiogenesis. Second thing, it will activate the antigen presenting cells. It will increase the NF kappa B in them so that more cytokines could be produced. And second thing, the third thing, they will directly kill the tumor cells or the virally infected cells. So basically decreasing the number of viral infected cells or the tumor cells. So please remember the name imiquimod. It will activate the toll-like receptor so that the NF kappa B could be activated and inhibiting the angiogenesis and directly killing the tumor or the virally infected cells. Okay. So you can use this drug for the human papilloma virus, and anogenital warts. You can use for the basal cell carcinoma. You can use them for the actinic keratosis. Any doubt? I think there's a points to remember, nothing to understand much. Then comes the therapeutic antibodies, and one of the most important thing that you should remember about the antibodies that they do not metabolize. Okay, they do not metabolize by your liver or by your kidneys. So in case of any liver failure or the kidney failure, you do not have to lower the dose of these drugs. The most important thing, okay, you will give them in the same amount as in the normal person. And you should know for the clearance, they just get endocytosis in the cells, in the targeted cells. Okay, so for the drug clearance, it will happen by the endocytosis in the cells, and they do not clear by the liver or the kidneys. Okay, very important thing. Second thing, all of the antibodies are mostly the humanized antibodies, and you should remember the this naming system of them, because every monoclonal antibody is written as the map after the name. Okay, and if they are the receptor molecules, then it will be named sept after their name. Okay, like etanercept, if you remember. Okay, and if they are that tyrosine kinase inhibitor, then we'll have this NIB name, okay, in their name. And if they are humanized molecular antibody, then they have this zoo in their name. Okay, 2-3 points that you must remember naming them. So first drug is your alemtuzumab, which is a CD52 inhibitor. I've never encountered any question over it, so you can just skip that thing. But this bevacizumab is important. It is a humanized because zoo molecular antibody, and it is against the vascular endothelial growth factors which are involved in the angiogenesis. So ultimately, whenever you want to stop a tumor growth, because you know that all the tumors require the blood vessels for their nutrition, so you can use these drugs. And these are the VEGF inhibitors. And plus you can also use them for the eye conditions like diabetes mellitus, the diabetic retinopathy, okay, or macular edema also, okay, neovascular macular degeneration, the diabetic retinopathy or the macular edema, you can use these drugs for, okay. Then comes the rituximab. I've already told you the function of this drug. It is a CD20 inhibitor. And so you can use them for any disorder involving the B lymphocytes. For example, the B cell non-Hodgkin lymphoma, the chronic the chronic lymphocytic leukemia, the rheumatoid arthritis, multiple sclerosis, okay. But you should know because B cells are very much required to fight the virus infections also some. And in case if you give the patient rituximab, you will get the activation of the JC virus, very important. Then comes a trastuzumab, which are the HER2 new antibodies. antibodies against the HER2 new receptors, and these are the receptors involved in the breast cancer and sometimes as well as the gastric cancers. Okay, so lysis happened through the ADCC, antibody dependent cell toxicity. Okay, so trastuzumab for the breast cancer. So if they ask you what kind of antibody you can give to a patient on the patient of breast cancer, what you will answer? The trastuzumab, the monoclonal antibodies. Then comes the adalimumab and the infliximab, and these are the soluble TNF alpha inhibitors. Okay, soluble TNF alpha. And then there is this drug which is the etanercept, and it is a decoy receptor. So that what happens is TNF alpha will bind to this drug, not to their original receptors, and as a result, this TNF alpha will be inhibited. So these are the antibodies, and these are the receptors for the TNF. Okay. So you will use these drugs mainly for the rheumatoid arthritis and also for the inflammatory bowel diseases and sometimes the seronegative spondyloarthritic diseases like ankylosing spondylitis or the psoriasis. Okay. Then comes the eculizumab, which is a complement C5 inhibitor, and you use this drug for the paroxysmal nocturnal hemoglobinuria because I told you that in this disease, what's going to happen is the activation of complements against the RBCs or the lymphocytes or the neutrophils. Okay, so we'll use this drug eculizumab for the complement C5. Can you skip that name? Never encountered any question over it. The natalizumab is alpha 4 integrin inhibitor. Never encountered any question over these drugs. Then comes the upsiximab, which is very important. We will say that later in the hematology section. These are the platelet glycoprotein 2B3A inhibitors, and you use these drugs mainly, in the percutaneous coronary intervention. Very important thing. You will always use these drugs in the percutaneous coronary interventions for the myocardial function. Then comes a denosumab, which is a rank ligand inhibitors, and you use this drug for the osteoporosis treatment because they inhibit the osteoclast. You will study later in the musculoskeletal part that rank ligand is very important for the activation of the osteoclast cells. So if you inhibit the rank ligand, you won't get the activation of osteoclast, and so you will stop the osteoporosis. Then comes the omalizumab, which you will study that in the respiratory chapter, and these are the antibodies against the IgE antibody. Okay, so you will use these drugs for the asthma. Then the palivizumab, the viral against the virus drug, and you can remember this by this V in the name, palivizumab for the virus, and it is a respiratory syncytial virus. They have this F protein in them, and these drugs are directed against this F protein. Okay, and F protein की full form है, they are fusion proteins which causes a cell fusion. So in case of respiratory syncytial virus, what you will get are the the multinucleate giant cells, which are the epithelial cells in your body, in the respiratory epithelium. So you can direct this drug against the F proteins. Okay, and you can also remember two more names, which is a mepolizumab or the bernalizumab, the interleukin 5 inhibitors. Again, remember what the interleukin 5, what is the function of this interleukin 5? Anyone remember? Two functions.
Eosinophil and IgA.
Exactly. So you will use these drugs for the asthma because they're inhibiting the production of eosinophils. Okay. So any doubt on this table? Yes, you need to remember the complete table. You will encounter these later drugs, again, later in the chapters. So you will have a better understanding of these drugs again. But yeah, you should remember this table for the ease. Okay. It's easy, not that much hard when you study about this drugs later. You will know it was easy, very much easy. Okay. So we have finished our immunology section now, and we're going to start the microbiology now. Let me open the slide for it. Okay, then the microbiology, and first you need to study about the structure of the bacterial cell. Okay, so for the outermost structure, you will have this cilia and the flagellas, of course. Flagellas are made up of protein, which helps in the motility of the cell. It will help the cell from moving from one place to other place. Okay, then comes the fibria, the fimbria or the pillars, which help in attachment of the bacterial cell. So pillars or the fimbria for the attachment and flagella for going places. Okay, so whenever a question stem asks you how this is E. coli, able to cause the urinary tract disease, so it is by the pillars or the fimbria, because it will help them attaching your urinary tract. Okay, so the flagellum role and the pillars and the fimbria role. Okay, then comes the spores, which basically protect the cell in very harshful conditions. Okay, and they are made up of this keratin-like coat, the dipicolinic acid, the peptidoglycan, very important, and the DNA. Please remember these four names. These are very important: the keratin coat, the dipicolinic acid, the peptidoglycan, and the DNA. They basically spore, help the cell surviving the very extreme or the harsh environments. They can easily resist the dehydration, easily resist the heat and the chemical. They can reach to a temperature of 121 degrees centigrade, and which is a temperature you generally used in the autoclave machine. Okay, and the STEM might ask you a question over this: what happens if the autoclave might be might become malfunction and started working on 110 degrees centigrade? So what kind of infections you will get? So you will get the infection from the spore bacteria, like your bacillus or the clostridium. You can remember the name, the spore forming bacteria, the two that I must remember, the bacillus and the clostridium, very important. Okay, so spores help the cell surviving the extreme or the harmful conditions. Then comes the cell capsule, which are basically made up of the polysaccharides. Not every cell has it, of course. Some capsulated bacteria are there, and I've already listed the names: the Klebsiella, the Pseudomonas, the Streptococcus pneumoniae, Haemophilus influenza, Neisseria species. Okay, and there is one more test that you will do for the capsule or related organisms, and that is a Q-lung reaction. You will study that later in the main in the later pages also. The Q-lung reaction, you can remember, you will use for the capsule. And what does this capsule do? It will protect the cell from the action of phagocytic cells, and that's why you need the IgG antibodies and the complements against the capsule. And like I told you, that IgGs are very important in fighting the bloodstream infections, especially the capsulated organisms, because it can only be destroyed when the IgG or the complements bind to the capsule of the bacteria. Okay, then some bacteria produces this slime layer, which are the loose network of these polysaccharides, and you call this as a biofilm formation. Okay, some bacteria can do this. They will form the biofilm, which are some loose polysaccharides around them, and they will help surviving the colony of the bacteria completely. No drug can reach to the bacteria. After that, no antibody, no cell can reach to the bacteria after forming the slime layer. Okay, and any organism which are invading your cell, which are invading your body by through some kind of some kind of a material like catheters, or the foreign surfaces, and they always form these slime layers. I will tell you the name of these organisms later in the pages also. Then comes the outer membrane, of course, and this outer membrane is present only in the gram-negative bacteria, not in the gram-positives. And they contains these endotoxins, which are the lipopolysaccharides or the lipooligosaccharides. You should remember the name. Okay, and these are these endotoxins which are responsible for the shock by these gram-negative bacteria. The sepsis and the shock are caused by these endotoxins. Okay, and you should also remember some kind of proteins which are the outer membrane proteins, and they're especially found in the Neisseria. Remember the use of these outer membrane proteins in the vaccine? Anyone? The role of outer to
T-cell mediated
in what kind of vaccine?
and subunit conjugate vaccine.
Exactly. You will use these outer membrane proteins for the subunit or the conjugate vaccines. Okay, like I told you that they are only in the gram-negative bacterias, and the endotoxins are basically your lipid A. Okay, and which are a part of this LPS. Okay, LPS is lipid A, the antigen O. Okay, and lipid A actually induces the formation of this TNF alpha and the interleukin 1 that causes the shock. So LPS. Okay, so also your outer membrane has these porine proteins which help transferring some molecules inside and outside of the cells. The penicillin drugs can gain access to these porins to enter the cell. Okay. Then comes the space known as the periplasmic space, and it is only present in the gram-negative bacteria, not for the gram-positive bacteria. And you should know that the location of the beta-lactamases is in the periplasmic space. Very important. The location of beta-lactamases are the periplasmic space. Then comes the cell wall, which are made up of this sugar backbone, and they basically help maintaining the shape of the cell. Okay, they provide them the rigid support and protect them from the action of these osmolytic agents, from the hyposmolarity or the hyperosmolarity. Okay, so the cell wall function, and the penicillin drugs actually destroy the cell wall of the bacterial cell so that the water can easily rush inside the cell in the hypotonic or the hypertonic environment, and cell can be easily destroyed. So you can remember the function of the penicillins, the destruction of the cell wall that can lead to the cell swelling and death. Then finally comes the cytoplasmic membrane, which is the innermost membrane that you can see. This is your cytoplasmic membrane. Okay, and you should also remember the cell wall is very well developed in the gram-positive bacteria, but not very well developed in the gram-negative bacteria. Okay, and because of this cell wall, the gram-positive bacteria are gram-positive and gram-negative bacteria are gram-negative. Okay, because the cell wall actually resisted the decoloration of the gram staining. Okay. Then comes the cytoplasmic membrane, which is the innermost layer. And you should know the location of the oxidative phosphorylation or the electron transport system in the bacterial cell. It is your inner cytoplasmic membrane. Okay. And you should know for the gram-positive, these are the lipoteichoic acids which are responsible for the sepsis and shock. Like in gram-negative, these are the lipid A of the endotoxins which are responsible for the TNF alpha, interleukin 1 and shock. In case of gram-positives, these are the lipoteichoic acids. Okay, and yeah, that's it about the cytoplasmic membranes. And you should know what are the peptidoglycans. They are actually made up of the N-acetyl glucosamines and the N-acetyl muramic acid. NAM-NAG units are made the backbone, and finally the N-acetyl muramic acid get cross-links. So these are the N-acetyl muramic acids that get cross-links. Okay. So peptidoglycans can, the cross-linking of the peptidoglycan always occur on the NAM. And the backbone consists of these peptidoglycans is actually made up of this NAM and the NAC proteins. Okay. Any doubt in the structure of bacteria?
There is a slim layer formation, and which is written. It is mediated adherence to the surface plays role in
Yeah.
biofilm formations, and it is
Yeah.
something example given is indwelling catheter. So I
Yeah.
couldn't understand indwelling catheter how it works like.
Not just the indwelling catheter, but any foreign body that enters in your body. Okay, like a catheter, or might be a transplant, or valve transplant, might be a bone transplant, might be a shunt in your body. So any foreign surface when enters in your body, it would be coated by these bacteria, which produces a slime layer. And once these bacteria form this slime layer around them, no drug, no antibody, no cell can reach to the bacteria to kill them. Okay, and that's how these bacteria actually survive on the foreign surfaces. And the only way to treat the condition is to remove the foreign body. Okay.
Okay, thank you.
Yeah. You will study that later in the pages, of course, about this slime layer. Okay. So wait till then. Then comes the type of stainings that you will use to stain different organisms. First is the gram stain, and they can ask you what kind of agents you will use in the gram stain. That is the crystal violet, the iodine, the acetone wash, and of course, finally the safranin to stain the gram-negative organisms. Okay. So crystal violet, iodine, acetone wash, and finally the safranin. So those who retain the the dye color, they become very violet, and these are the gram positives because they resist the decoloration of the acetone. Actually use the acetone for the decoloration. Okay, so those organisms that resist the decoloration are your gram positive, and that is because of the thick peptidoglycan layer in them. Okay, and the bacteria which leads to a decoloration, which and these are the gram negative organisms, and you will stain them pink with the safranin. So whenever you look in the microscope, if you are seeing a pink organism, this must be a gram negative. If you are seeing any bluish violet agent, this must be your gram positive organisms. Okay, and then you should know what organisms cannot be stained by the gram staining. These are the Treponema leptospira, and because of their very very small size, so they are very thin to visualize in the microscope, so they cannot be stained with the gram staining. Then comes your mycobacteria, because mycobacteria has a specialized type of cell wall which is made up of this mycolic acid, and so you cannot stain them with the gram staining. Okay, then comes the mycoplasma or the ureaplasma. They do not have any cell wall, so if they do not have any cell wall, you cannot stain them with the gram staining. Then comes the Legionella, Rickettsia, Chlamydia, Bartonella, Anaplasma, and Arshella. Okay, and because they are intracellular organisms mainly, so you cannot found outside the you cannot find them outside the cell, and if you cannot find them outside the cell, you cannot stain them with the gram staining. And of course, the chlamydia also lacks the peptidoglycans. Okay, and mainly the N-acetylmuramic acid. So no cross-linking will happen in case of chlamydia. Okay, so remember these organisms which cannot be stained by the gram staining. Then comes the Giemsa staining, which you specially use for the intracellular organisms. Whenever you want to visualize the intracellular organisms, you always use the Giemsa staining, which are your Rickettsia, the Chlamydia, the Trypanosoma, the Plasmodium, okay, the Borrelia, Helicobacter pylori, okay, and you might encounter 2 or 3 questions in the NBME over this Helicobacter pylori and this Giemsa staining. Okay, it will stain very yellow. So whenever you have this yellow background and the blackish organisms, this must be your Giemsa staining. Okay. Then comes a pass staining. Like I told you, it is for the glycoproteins, all of the proteins which are rich in the glucose or other sugars. You can stain them with the pass stain. Okay, and especially your Whipple's disease, you will use that stain. Okay, Trephorama whippleyi. Okay, and you can also use this pass staining for the Cryptococcus because this has very thick polysaccharide capsule, and because of this polysaccharide, they are rich in the sugars. So you can also stain the Cryptococcus neoformans with this pass staining. Okay. Then comes a Zedin staining, and of course, you know that Zedin staining is used for the acid-fast bacteria, which are your mycobacteria, and the nocardia also. And you should know the name of the protozoas which are Zedin positive, and these are a Cryptosporidium oocytes. Okay, Cryptosporidium. In your GI tract, you will find it. Okay. And the other stain that you can use is the auramine rhodamine stain. Sometimes the examiner won't give you this Zedin staining, but they will give you this auramine rhodamine staining. So do not confuse between these two. Okay. Then comes the India staining, which is usually used for the Cryptococcus neoformans. Okay, you will have this blackish background, and then the the whitish or the some kind like that whitish capsule of the Cryptococcus neoformans. And the musicarmine staining is very important. You can also use the musicarmine staining, and it is the special stain for the for this Cryptococcus neoformans capsule. Musicarmine staining is very important stain for the capsule of the Cryptococcus neoformans. Then comes the silver staining that you use mainly for the fungi. The Legionella, very important. The Legionella, you will stain them with the silver staining. You cannot do the gram staining on the Legionella because it is mainly intracellular organism. Okay, and so you use the silver staining instead. And in the H. pylori, you can also use the silver staining, very important fungus, Legionella, and the Helicobacter pylori. Then comes the fluorescent antibody staining that you use mainly for your, the syphilis. Okay, And you can also use them for the Giardia, Cryptosporidium, and the Pneumocystis cerevisiae. And you should remember the unique cell walls of different bacteria. The mycobacteria, like I told you, are rich in the mycolic acids. Okay. And the mycoplasma, they do not have any cell wall, of course. Chlamydia, they do not have the muramic acid in them. Okay. Like I told you, the peptoglycan layer is made up of N-acetylglucosamine and N-acetylglutamic acid. So chlamydia actually lack these N-acetylglutamic acid. So no cross-linking can happen. And as you guys already know that the penicillin drugs actually inhibit this cross-linking, right? But in chlamydia, there is no cross-linking happening in the first place. So the chlamydia has this internal resistance against the penicillin drugs. Okay, any doubt?
No.
Okay, then comes the type of growth medias and their properties, of course. So first one is the selective media, in which you inhibit the growth of every other non-essential organism, and you grow any selected organism on them. And one of the example is the Thayer Martin agar, okay, which are rich in the antibiotics that kill every other every other non-specific type of organisms and causes us selective growth of only the Neisseria species. Okay, so very important name, the Thayer Martin agar. You will use them for the Neisseria species only, and this is your selective media. Okay, and not just the Thayer Martin strain, there are other selective media also. Okay, then comes the indicator or the differential medias, which help differentiating between the two type of colonies. For example, the lactose fermenting bacteria and the non-lactose fermenting bacteria. And the example is the McConkey agar. McConkey agar help differentiating the lactose fermenting bacteria from the non-lactose fermenting bacteria. Okay, and those who are lactose fermenting bacteria, they will lead to a change in the color to the pink. So if you get a pink agar, it will be lactose fermenting bacteria. And if you do not get the pink agar, there will be no lactose fermenting bacteria. And you should note that the blood agar, as you will study later, they can be, you can be easily differentiate the species into alpha hemolytic, beta hemolytic, and gamma hemolytic organisms of the streptococci. So blood agar can also be used as a differential media. Okay. Then you should remember the name of differential medias or some specific medias that you use for different organisms. For the Haemophilus influenza, you use mainly the chocolate agar, okay, which you can make by heating the blood agar also. Okay, so the chocolate agar made by heating the blood agar, and it is rich in factor 5, which is the NAD, and factor 10, which is the hematin. Very important thing. Haemophilus influenza requires these two factors to growth. For the growth, okay, and these two factors can be formed by the lysis of the RBCs, and that's why you heat the blood agar so that the lysis of the RBCs can happen, and after the lysis, this NAD and hematin can be easily released from the cell. Very important. Okay, then comes a Neisseria gonorrhea. Like I told you, Neisseria species, they require this Thayer Martin agar. Okay, you will inhibit the growth of other species like of the bacteria. Like for the gram-positive organism, you use the vancomycin to kill every gram-positive organism. For the gram-negative, you use mainly the trimethoprim that kill every other gram-negative organism except the Neisseria. You use the colistin also for the gram-negative bacteria to kill them. And for the fungus growth, you will use a nystatin to kill them. Okay, so ultimately, you're allowing the growth of only the Neisseria species and killing the every other species by giving antibiotics. Okay, then comes the Bordetella pertussis, and you use this Regan low medium for the Bordetella pertussis or the Bordet agar. So the Bordet agar or the Regan low medium, and you should know that this Bordet agar contains the potato extract. They can ask you this, and Regan low medium is made up of the charcoal, the blood agar, and some antibiotics in it. Okay, so you can say that this Regan low medium is an example of selective media. Okay, then the diphtheria, the Clostridium diphtheria, sorry, the Corynebacterium diphtheria, and you use the telluride agar or the Loeffler's medium for that. Very important, Loeffler's medium or the telluride agar. for the current bacterium diphtheria. For the Mycobacterium tuberculosis, you use the algae media, which is the Lowenstein-Jensen medium. Very important. And you can also use the rapid automated growth cultures. Two things: the rapid automated growth cultures and the algae media for the tuberculosis. Then comes the mycoplasma. Yeah, someone is asking. Any doubt? Okay, so the Mycoplasma pneumoniae, and you use the Eden agar. And you should remember, the guys, that for the growth of mycoplasma, you require the cholesterol. Mycoplasma is require the cholesterol for their growth. So in the Eden agar, you uses mainly the cholesterol. Very important. Then for the lactose fermenting bacteria,
Can you please mute your?
okay, so I muted her. Now the McConkey agar, that is an example of differential media, like I told you, and it will help differentiating the lactose fermenting bacteria from the non-lactose fermenting bacteria. And especially for the E. coli, you can use the EMB agar, which is eosin methylene blue. Okay, and the colonies of the E. coli will form a green color shin in these agar, and other lactose fermenting bacteria will form the black or the blue colonies. Okay, so black blue for the other species, and for the E. coli it is green color. So yeah, EMB can also be used as a differential media. Okay, then comes the Brucella, Francisella, Legionella, and Pasteurella, and you use the charcoal yeast extract, which is CYE agar for them. And you should know that it is buffered with the cysteine and the iron, because the growth of these organisms requires some cysteine and iron. Very important thing, you require cysteine and iron for them. Examiners can ask you questions over these. What other substances you will use in this agar? And this is your cysteine and iron. Then comes a fungi, and for every fungi you will use a separate agar to culture them. Okay, any doubt? I think it's just a remembering facts, nothing to understand much. Then comes the aerobic species or the aerobic organisms, which uses the O2 dependent system to generate the ATP. Of course, you require the oxygen to form the ATP, and these are the aerobes. And examples include the nocardia, mycobacterium tuberculosis, and the Pseudomonas aeruginosa. Like the Mycobacterium tuberculosis will die in the anaerobic conditions, and this is the cause of this caseous necrosis in case of TB. In the TB, you remember, you get the caseous necrosis, and that happens because of this anaerobic conditions generated in the granuloma. Okay, and of course the body teleportosis is also an anaerobe. Okay, and all of these anaerobes are actually catalase positive organisms. Okay, an easy way to remember, all of these anaerobes are the catalase positive organisms. Okay, and that is the reason why the Mycobacterium tuberculosis is always, whenever the reactivation of this TB occurs, it always affects your apex of the lung, because it is highly rich in the oxygen. Okay, you have this very very low VQ mismatch here, and that's why that TB affects this area. Okay, any doubt?
No, sir.
Okay, then comes a list of anaerobes. Only 2-3 anaerobes exist. You can remember them by the mnemonic ABC, which is the actinomyces, the bacteroides, and the clostridium. And one more, the F, the fusobacterium. So ABC you can remember by the mnemonic actinomyces, bacteroides, clostridium, and again one, fusobacterium. We should know that the fusobacterium is mainly involved in the lung abscesses. All of these anaerobes can cause the abscess. So whenever you heard the word abscess, you will always think about the anaerobes, anaerobic bacteria. Okay, and the lung abscess is mainly caused by the fusobacterium or the Peptostreptococcus. These two very important names. Whenever you get a aspirational pneumonia or might be the lung abscess, The two bacteria that you will isolate are the Peptostreptococcus or the Fusobacterium. And whenever you isolate these bacteria, you should know that it is always going to be a case of your aspirational pneumonia or the lung abscess caused by this aspiration, because they're found in your mouth. Okay. Then comes the Actinomyces israeli. You will study that later in the my microbiology, and you will see that they causes the dental abscess or the gums abscess. Actinomyces also found in your oral cavity, and it causes the dental or the gums abscess. It can also lead to the lung abscess, of course, if you aspire these bacteria. Okay. Then comes the bacteroids, which are the most common cause of your abdominal abscess. Whenever a question stems ask you about the cause of the abscess or what organisms most probably causing the abdominal abscess, the answer would be your bacteroids. Then comes the Clostridium species. All these tetani, the difficult you will study in the botulinism. These are the Clostridium. So ABC mnemonic you can remember, and you should know that they all lack this catalase enzyme. Okay. And the antibiotics names, please remember only these 3-4 antibiotics can kill the anaerobes. This includes the piperacillin tazobactam, okay, the clindamycin, and the metronidazole. Okay, these three and one more, imiperam, meroperam, can also kill these bacteria. So 4 drugs: the piperacillin, the clindamycin, the metronidazole, and your and these are. I'm sorry, I forgot the name of the antibiotics again. Imiperam and the meropenem drugs. Okay. And you should know the fact about these aminoglycosides because they requires the oxygen in order to enter the bacterial cell, and that's why aminoglycosides are not capable of killing the anaerobes because they require the oxygen for their function, of course. And yeah, they're generally very foul smelling. So whenever you get a lung abscess or abscess anywhere inside your body, it is very foul smelling. Whenever you get a dental or the gum abscess, it is very foul smelling. Okay, so yeah, you can remember as a buzzword. Okay, that's about the anaerobic bacteria, the names, where they found, and what disease they can cause. Then comes the facultative anaerobes, which mainly uses the oxygen, but they can shift their respiration to the anaerobic respiration and whenever the oxygen is not available. And these are the streptococcus and the staphylococcus. And of course, every enteric gram-negative organism that includes your E. coli, the enterococci, the Klebsiella. These are all the facultative anaerobes. Then comes the intracellular bacteria. First, the obligate intracellular, which mainly rely on the host ATP for their function. And these are the Rickettsia, Chlamydia, and that is the reason why you cannot stain these bacteria with the gram staining. Okay, Coxiella is also an example of these bacteria. Then comes the facultative intracellular, which can live inside the body of the cell or maybe outside the cell. And these include the Salmonella, Neisseria, Listeria, Brucella, Francisella, Legionella, Mycobacteria, Yersinia pestis. Okay, if you write these names again and again, you will eventually remember them. No easy way to learn them. Then comes the encapsulated bacteria or the bacteria that have capsule, and you can remember them by the mnemonic. Some bacteria has pretty nice capsule, and these are the streptococcus. You can write them down. The streptococcus, the pseudomonas, the Haemophilus influenza, Neisseria, E. coli, Salmonella, Klebsiella, the group B streptococci, of course. Okay. And you should know the function of the capsule. Like I told you, it is rich in the polysaccharides. It is a polysaccharide capsule. And they have basically this antiphagocytic function. Okay. So capsule for the antiphagocytic function. And that's why you require the antibodies and the complements to kill the encapsulated bacteria. Okay. And remember the fact I told you about the spleen. Whenever you lost the spleen, whenever you get the asplenia, you will always, vaccinate the patient for the 3 species of the bacteria. And most important one is the Streptococcus pneumoniae. Second most important, Haemophilus influenza. And third most important, your Neisseria meningitidis. Okay. And then you should know about the conjugate vaccines, which contains a polysaccharide capsule as well as one protein conjugate, which could be from the diphtheria, could be from the tetanus, or could be from the OMP of the Neisseria. Okay. And yes, that's about it. And you should know what are the conjugate vaccines and what are the polysaccharide vaccines. PPSV23 is a polysaccharide vaccine. Okay, and PCV13 is a conjugate vaccine. So this PPSV23 initiate only the IgM response, and this IgM response mainly, and this PCV13 initiate both the humoral as well as the cell-mediated immunity. Okay, like I told you, two type of cell activation could be there, either the thymic dependent activation or the thymic independent activation. So thymic independent activation occurs in the PPSV23 and thymic dependent activation occurs in the PCV13. I hope you remember the fact. Then comes a list of all the urease producing organisms. Proteus, you know, are the urease producing organism, and other UTI causing organisms like Klebsiella. Okay, and your Streptococcus saprophyticus is also urease positive organisms. And similarly, your Streptococcus epidermidis is also an example of urease positive organism. Urea plasma, Helicobacter pylori, Nocardia, these are the example of urease positive organisms. What the urease enzyme do? They basically hydrolyzes the urea to releases the ammonia, and as a result, the pH would be increased because ammonia is basic, right? So they hydrolyzes the urea and releases the ammonia. And of course, a urea blood test you can do to diagnose these bacteria. Okay. And yes. Then comes the magnesium ammonium phosphate stones, which are formed by one of these urea producing organism. And the most commonly it is the Proteus. But you should also know that Klebsiella and Staphylococcus saprophyticus can also cause the stones, just like the kidneys. Sorry, just like the this Proteus. Okay, so Proteus, Klebsiella, and Saprophyticus for the kidney stones, and all of these three organisms are the urease producing organisms. Any doubt?
Sir, can you repeat that?
Okay, you will study actually later in the renal part also that this Proteus, this Klebsiella, and the Staphylococcus saprophyticus. Okay, these three organisms causes a UTI and then causes the kidney stones. Okay, struvite stone. You must have heard this term, struvite stone, or the ammonium magnesium phosphate stones. All of these three organisms can form this stone, and all of these three organisms are actually secrete this urease enzyme. Okay, so you can easily remember the name of these organisms. You know where to find them. Then the similar to the Staphylococcus, you have Staphylococcus, which is the Staphylococcus epidermidis. It is also urease rich organism. And you have this urea plasma, the Cryptococcus H. pylori, and the Nocardia as the urease productive organisms. Okay, you will study that later also. Okay, so then comes the catalase positive organisms. Actually, I had a mnemonic to remember the catalase positive organisms. Let me open my file. I will show you. Just wait a second. Okay, so you can remember the catalase positive organisms by this mnemonic that cat eat places to break hairs. So C for the catalase positive, N for the nocardia, P for the Pseudomonas, L for the Listeria, A for the Aspergillus, C for the Candida, E for the E. coli, S for the Staphylococcus, and S for the Serratia, B for the Burkholderia. So you can remember all of the catalase positive organisms by this mnemonic. That cat need places to break hairs, okay? So let's come back to the catalase positive organisms again. So can you guys tell me the function of this catalase enzyme? Anyone? What does this enzyme do, the catalase enzyme?
Was infection in CGD patients.
Okay,
It will break down
but
the hydrogen peroxide produced by the bacterium so that the host body cannot use it to kill the bacterium.
exactly. And that's why in the chronic gallbladder disease, you will get only the infection of these catalase positive organisms, not the catalase negative, because they will generate the H2O2, whichever body, whichever cells can easily use to form the hypochlorite HOCl, which can easily kill the bacterial cells, but not the catalase positive organism. And that's why you will get the recurrent infections from these bacteria. You know the mnemonic, you can remember the name of these bacteria easily now. Then comes the pigment producing bacteria, very important. They will give you some kind of a wound infection, and they will give you the color of the infection, of that wound. And they will ask you what organism can cause it. Okay. So you should, if you remember what organisms forms what type of pigment, what color of pigment, you can easily remember the name of the organism. Then first is your Actinomyces israeli. Whenever a wound infection occurs by this Actinomyces israeli, you will get the yellow color. Okay. And you will study that later about this organism, about this Actinomyces israeli later. Okay, they produce the yellow sulfur granules. Okay, which you will see in the oral cavity. Okay. Then comes a Staphylococcus aureus forming the yellow pigment. So remember the impetigo caused by the Staph aureus. It is always yellow in the color, and that yellow is because of this yellow pigment formed by the Staph aureus. The Pseudomonas aeruginosa, they have these two pigments, the pyocyanin and the pyoverdin, which forms the blue-green pigment. So whenever an infection with the Pseudomonas occurs, it is, the sputum color would be green in that case. And it is because of the pyocyanin and pyoverdin. Remember what other pigment can cause this green color?
Myeloperoxidase.
Myeloperoxidase. Please remember, other than the Pseudomonas aeruginosa, if you get an infection, get a pneumonia, the sputum would be green, and that is because of the myeloperoxidase. Okay, then comes the Serratia marcinens, which forms the red pigment. Okay, so yellow for the Actinomyces israeli and the Staph aureus, blue-green for the Pseudomonas, and red for the Serratia. Then comes the biofilm production. Like I told you, biofilm is actually a polysaccharides, loose polysaccharides, which these bacteria, including Staph epidermidis, Redans bacteria, Pseudomonas aeruginosa, and Haemophilus influenza. These bacteria form the biofilms. Okay. Now, what does these biofilms do? Actually, they form a coating around the colony of these bacteria, so that no drug, no any cell, no antibody can pass through this capsule or this film and can kill the bacterial cells. Okay. And I should, as I written here, the foreign bodies quickly become coated by the fibrin and the fibronectin. Please remember these protein names. Whenever you introduce a foreign body inside the inside your body, it will be quickly coated by the fibrin and the fibronectin, and then the bacteria can bind to this fibrin and the fibronectin. After binding, these bacteria will produces the biofilm. Okay, which is a loose polysaccharide matrix that encases the bacteria. Okay, so it functions as a barrier to the antibiotic penetrations and inhibits the host defenses, even the T lymphocytes activations. So what is the definitive treatment for such kind of bacteria, for such kind of biofilm production? And that would be to remove the foreign body as soon as possible. Okay. And that is the reason why only Staph epidermidis causes infection in your body in case of any foreign body implantation, like any heart valve, or maybe a bone replacement, or maybe a catheter. Okay. So any prosthetic device that includes a heart valve or the bone replacement or the shunt or the catheter, what you will get is a blood stream infection from the staph epidermidis. If they ask you the reason, then you will give the reason. It is because of the biofilm production. Okay, then comes the Redans bacteria, which includes the Streptococcus mutans and sanguinis. They causes the dental plaques and can also cause the infective endocarditis. You will study that later. Then the Pseudomonas aeruginosa, those who uses a contact lens, they can get the infection from the Pseudomonas aeruginosa because it can easily coat the contact lenses and can cause the eye infection. And the patients with the cystic fibrosis, they can get the Pseudomonas aeruginosa infection. And those who on the ventilator, they can get the ventilator associated pneumonia because of the Pseudomonas aeruginosa. And why? Because of their capability of forming the biofilm. Okay. Haemophilus influenza similarly can cause the otitis media. Okay. Any doubt in the biofilm now?
No.
Please remember they are the polysaccharide, loose polysaccharides, which protect the bacteria from any antibiotic, any antibody, or the cells. Then comes the spore-forming bacteria. Only two you should remember: the Clostridium species and the Bacillus species. Okay, the Bacillus species includes the Bacillus anthracis and Bacillus cereus. The Clostridium species includes the Clostridium botulinum, Clostridium difficile, Clostridium perfringens, and Clostridium tetani. Okay, you should know that these spores can resist a temperature of 121 degrees centigrade for 15 minutes. And that is a temperature you use for the autoclave to kill the spores. So in case of autoclave malfunction, if they're operating less than 120 degrees centigrade temperature, you can get an infection from these spore-forming bacteria. They will ask you this. Okay, and you should know what these spores consist of. They consist of the dipicolinic acid, the keratin, the DNA, and one more thing. And the peptidoglycan, of course. The peptidoglycan, the DNA, the keratin, and the dipicolinic acid. Very important. Okay. Then comes the different virulence factors for the bacteria. First is the protein A. Like I already told you in the immunology section, when I was talking about the antibody structures, I told you that the protein A actually bound to the Fc region of the antibodies, remember, so that the opsonization of the bacteria can never be happened. Okay, and this protein A is produced by the Staphylococcus aureus, and that is the reason why the Staph aureus can gain access to your bloodstream. Okay, because in the bloodstream it releases the protein A that binds to the Fc region of the antibodies, so that antibodies cannot opsonize these bacteria, because you require the Fc region to be free in order to opsonize the bacteria, right? Second come the IgA proteases. As the name suggests, they degrade the IgA antibodies, and because the IgA antibodies protects your mucosal tracts, your GI tract, and your respiratory tract. So whenever any bacteria needs to infect your respiratory tract or your GI tract, it need to have this IgA proteases in order to colonize, in order to attach to your mucosa. And these organisms includes a Streptococcus pneumoniae, which causes the pneumonia, Haemophilus influenza, which can also cause the pneumonia, Neisseria, which first colonize your nares and finally enters your bloodstream, then reaches to your brain to cause the meningitis. Okay, so all of these three bacteria require the IgA proteases in order to colonize the mucosal tracts. Okay. And then finally comes the M protein, which is an antiphagocytic protein for the Streptococcus pyogenes or the group A Streptococci. And you should know that this M protein actually shares some kind of a molecular mimicry with the proteins found on the cardiac myocytes. And it is because of these M proteins you get the rheumatic fever when you get the Streptococcus pyogenes sore throat. Okay, so it is in the sore throat only. So please remember the function of the M protein. It is an antiphagocytic protein that shares a molecular mimicry with the cardiomyocytes, and that can lead to the endocarditis. Sorry, the rheumatic fever in case of the Streptococcus pyogenes infection. Okay, and yeah, that would be it. And remember the function of capsules. In order to enter in your blood, you require the capsule. But Staphylococcus aureus do not have the capsule. Still, it invades your blood because it has this protein A, which is antiphagocytic, right? And similarly, the Streptococcus pyogenes can gain access to your blood. Why? Because it has this M protein, which is again the antiphagocytic. And this Streptococcus pneumoniae, Haemophilus influenza, Neisseria, they have the capsule to enter your bloodstream. So you require any of the mechanism, to gain access to the bloodstream, right? Then comes this diagram, this graph actually, which shows the number of bacteria and the time and the phases of the bacterial growth. First is the lag phase, and the number of bacteria will remain same in this lag phase. If you inoculated 10 to the power 4 bacteria, after the lag phase, it will remain only 10 to the power 4. In the growth phase, you should know that the exponential growth always happen. 2 become 4, 4 become 8, 8 become 16, 16 become 32. So after the growth phase, the lag exponential can be happen and it will become, 8 to the power 10, 8 into 10 to the power 4, or might be any other number. Then becomes the stationary phase, where the population again remains the same, and finally comes the death phase, when the nutrients become very deficient, so that the death of the bacteria cell is starting to happen, and they will decrease very exponentially. And you should know that every antibiotic work in this growth phase, or this growth phase is also known as the log phase. Every antibiotic that you know will work in the growth phase, because that is the time when the bacterial cells are replicating and they're using the nutrients, they're using the nucleotides, they're forming their cell walls, and that's why these antibiotics are affected only your growth phase. Any doubt?
No doubt.
Okay, thank you. Then we will study the bacterial genetics. I think we should take a short break. Okay.
Okay.
Thank you. Okay, so now you need to know how different bacteria actually acquire certain genes or they divide. Okay, first is basically the transformation. Transformation is a process in which a naked DNA is uptaken by the recipient cells or the bacterial cells. Okay, and finally this DNA would be incorporated into the chromosome of the bacteria, or the DNA of the bacteria. Sorry, not the chromosome, but the DNA of the bacteria, and as a result, the bacterial cell will acquire the gene which was circulating here. Okay, and in order to acquire these DNA inside the cell, the bacterial cell needs to be competent, which means it should be able to let the entry of this DNA inside it. Okay, and yeah, so this is a process when the naked cell, or when the naked DNA just entered the cell of the bacteria, and finally it will enters into the donor DNA, in the recipient DNA, and then it can express and forms the products to which the genes are for. Okay, and you should know, if you put the DNases in the surrounding, what's going to happen? They will destroy the DNA, and as a result, this process would be inhibited. So whenever a question stems would describe you a process in which a transformation of one kind of a cell was happening, for example, the acquirance of these antibiotic resistant genes by the bacterial cells, and then you suddenly put the DNases in the environment, and what you will see that no antibiotic resistance is happening now, right? And that's how you know that this must be the transformation process, because when the DNA is in the environment freely, it can be easily digested by the DNases, so that this processes could be inhibited. And you should know, by this transformation process, the Staphylococcus pneumoniae, Haemophilus influenza, and Neisseria acquired their polysaccharide capsule, which is the most important thing for these bacteria in order to survive inside the human body. Okay, I hope you understand this process. And you should know that non-virulent strain of the Streptococcus pneumoniae, they do not have the capsule, but the virulent strains have these capsules because they require the inhibition of the phagocytosis in order to cause any disease inside the body. Okay, and DNases will disrupt this process. Any doubt? Then comes the conjugation, which is a process by which certain genes from the plasmid or certain genes from the DNA could be transferred to the other cells, other bacterial cell, and that is done by the sex pilus formation. And this pilus will protect the DNA from the DNase's actions. So if they describe you a process of acquirance of any antibiotic resistant gene by the bacterial cell, and they tell you that after adding of the DNases, this process couldn't be inhibited, that means they're talking about this conjugation process, not the transformation process, because after adding the DNases, this process would be inhibited but not the conjugation. Okay, very important. And yeah, so two type of conjugations could be there, either the F positive F negative, or either the high frequency positive and the F negative. What happens in this process is your plasmid will get transferred into the other cell, and as a result, the characters of this plasmid will be transferred into this cell. Okay, and you should know that the cell who has this plasmid, who have the gene for the formation of the sex pilus, these are the F positive cells. Okay, and the other cells who do not have the plasmid, who do not have the genes for this for the formation of this sex pilus, they terms as the F negative cell. In the high frequency positive and F negative conjugation, what gonna happen? This plasmid actually incorporated into the bacterial DNA, and as a result, some part of the DNA and some part of the plasmid would be transferred to the other cell. And of course, this is done by the formation of the sex plus again. Okay, so in the high frequency conjugation, what gonna happen? Transfer of the plasmid as well as the bacterial DNA will happen. But in case of F positive, F negative conjugation, only the transfer of these plasmid genes will occur. Okay, and you should know, after the conjugation process, the F negative cell will become the F positive cell, as you can see. But in case of the high frequency conjugation, the F negative cell will remain the F negative cell, but it will acquire some new genes which are present in the bacterial DNA. Okay, so this is the conjugation. Then comes the transduction process, which is the process of transfer of the DNA or the genes from one bacterial cell to other bacterial cell with the help of the bacteriophages, which are the viruses that infects the bacterial cell. Okay, so what's going to happen when two type of transduction could be there? One is the generalized and one is the specialized. In the generalized transduction, what's going to happen when a bacteriophage infects a bacterial cell? It will destroy the bacterial DNA and uses the machinery of this bacterial cell to forms the new proteins of the viruses, their capsule, their DNA, their RNA. And ultimately, what's going to happen, because these fragments of the DNA were circulating inside the bacterial cell during the process of packaging of the virus, sometimes what's going to happen, this DNA of the bacteria would be packed in the bacteriophage instead of their real genetic material. And next time when these bacteriophages, which were packed by this bacterial DNA, infects the other bacterial cell, they will transfer the bacterial DNA instead of their real genome. Okay, and as a result, that the transfer of genes of this bacteria would be happen to the next bacteria. Okay, as you can see here, this is a bacteriophage infected the bacterial cell. It will lyse the DNA of the bacteria, and during the packaging process, some of the bacterial DNA will be incorporated in the bacteriophage. And next time when this bacteriophage, after the lysis of the cell, infects the new cell, they will transfer the genetic material of that bacteria, of the lysed one, to the new bacteria. Okay, and that's how this new bacteria will acquire some of the capabilities of this bacteria. Okay, and it could be antibiotic resistant gene or could be a virulence genes. Okay, which forms the virulency of the bacteria. Okay, then comes the specialized transduction. Now in this process, what's going to happen, instead of cleaving the DNA of the bacteria, this viral DNA will incorporate itself into the bacterial genome. Okay, and as a result, this bacterial cell will acquire new capabilities. It will acquire new toxins. It will acquire new resistance to the antibiotics. Okay, and this happen in the favorable conditions only. Whenever the conditions become unfavorable, okay, whenever the condition threaten the the cell survival, what's going to happen? The genes in this bacteriophage will become activate, and similar to this process, it will lead to the cleaving of the bacterial DNA. And similar to this process, during the packaging, some of the bacterial DNA will be incorporated within this bacteriophage. And next time when this bacteriophage infects the other bacterial cell, the DNA of the previous bacteria could be incorporated in the new bacteria. And you should know that this is a process of how some of the bacteria acquire new toxins. For example, the Streptococcus pyogenes, they acquire this erythrogenic toxin, which causes that this so I'm sorry, I forgot the name. Just a second. This toxic shock syndrome like toxin, remember? That's how this Streptococcus pyogenes acquire this toxic shock syndrome like toxin. And the botulinum toxin, of the Clostridium botulinum, it is formed by the transduction process. Similarly, the cholera toxin, the diphtheria toxin, and the Zika toxin. All of these toxins are formed by the transduction process. Okay, and it is a Shigella, not the E. coli, but the Shigella toxin. Okay, you will study that both the E. coli and the Zika toxin are of same thing. They perform the same function. So it is the Shigella toxin which is formed by the process of transduction. So please remember this name by the mnemonic A, B, C, Ds, or I will tell you another easy way to remember these toxins of the bacteria in the later pages. So any doubt up to transaction?
What's the difference between this generalized and specialized?
What's the
difference?
Okay, the difference in the generalized transduction, the bacteriophage is lysing the bacterial cell directly. But in this case, when the conditions are favorable for the bacterial survival, what's going to happen? This bacteriophage will incorporate their genetic material in the bacterial DNA rather than lysing it. Okay. And when the conditions become unfavorable for the bacterial survival, certain genes in these bacteriophages will become activate and they will cleave the bacterial DNA, similar to this process, the generalized transduction. So in a specialized one, you are actually incorporating the genetic material of the bacteriophage in the bacterial cell. But in this generalized transduction, you are just cleaving the DNA of the bacterial cell. You are destroying the cell completely. Okay.
Okay, thank you.
And remember the toxin name, please, very important. They will ask you. Then comes the transposition, and you should know about some transposon proteins. Okay, transposons are basically specialized segment of the DNA, which could, which are somewhat like a jumping DNA sequences. They can jump from plasmids to the bacterial DNA. They can jump from the bacterial DNA to the plasmid within the same cell, not the cross cells, but within the same cells. They can jump from plasmid to the bacterial DNA or from the bacterial DNA to the plasmids. Now, similar to the process of this conjugation, as you can see, similar to the process of this conjugation, when the transposons enters the plasmid or the bacterial cell, they can be easily transferred from one cell to another cell. Okay, very important. As you can see, the transposons are basically specialized segment of DNA which can copy and excise itself and then insert into the same DNA molecule or the unrelated DNA, either the plasmid or the chromosome of the bacteria. Okay, and it is very essential for the creation of this multiple attack resistance. Okay, and after the transposons insert itself in the bacterial chromosome, they will get transferred to the other bacteria by the conjugation process. Very important, and that's why this transposition process is not inhibited by the DNases. So the only process with the DNases inhibits is the transduction. Okay, please remember, very important. Then comes a difference between the exotoxins and the endotoxins. You should know that the exotoxins are present both in the gram-positive cells as well as the gram-negative cells. When the endotoxins, like I already told you, they are found only in the gram-negative cells. Okay, exotoxins are basically toxins which are secreted from the cell. For example, the Clostridium tetani, the botulism toxin, remember, the toxic shock syndrome toxin, they are all secreted from the cell, right? And these exotoxins are easily secreted from the cell, like I told you. And endotoxins cannot be secreted from the cell. Endotoxin will only become active when the cell lysis occur. When the cell will die, they will release these endotoxins. Okay, live cell can only release the exotoxins, while dead cell can release the endotoxin. Okay, and every exotoxin that just a second, guys, my laptop battery is down. Let me connect the charger. Okay, so the exotoxins are made up of polypeptides, which are proteins. And remember, because these are proteins, you can easily make the vaccines against them. Okay, you can easily make the vaccines against them because they are proteins. But these endotoxins are basically polysaccharides. Okay, lipopolysaccharides, I must say, and they have these components like lipid A, lipid O, that you will study later in the next page. Okay, and they're only released when the cell will be lysed by the immunity of the host. Okay, then where is the location of the genes for the exotoxin? It could be either in the plasmid or they could be bacteriophage coded, like I told you here. All the toxic shock syndrome like toxin, the botulism toxin, the cholera toxin, the diphtheria toxin, the Zika toxin, they are all the exotoxins, and they are coded by the bacteriophages by the process of transduction, right? So the location of gene either in the plasmid DNA or in the bacteriophagic DNA. Okay, but in the endotoxins, they are only present in the bacterial DNA or the bacterial chromosome. Okay. Adverse effects, you should know that very high dose of these toxins are required in order to cause any infection or any symptom in the host, but very small dose of these endotoxins are required to cause the symptoms. The effects will be depend on what type of toxin it is. If it is a neurotoxin, it can lead to a paralysis or the spasms. If it is the GI toxin, it can cause a food poisoning or the diarrhea. So different exotoxins have different functions and different effects. But every endotoxin will gonna cause one thing, and that is the fever, shock, and DIC, ultimately the sepsis. Okay, and why sepsis? Because of this lipid A in the LPS, which causes a sepsis by activation of the toll-like receptors. Remember, I told you about these toll-like receptors, which are CD14. Okay, and once they get activated, they will activate the other cells. And finally, the release of this TNF alpha, interleukin 1, and interleukin 6 will happen. That leads to the shock and fever, the sepsis ultimately, right? Then comes the antigenicity. They are they induces very high titer of the antibodies because they are polypeptides. So there will be a processed by the thymic dependent activation. Remember, thymic dependent antigenic presentation will be happen in case of exotoxins, but in case of endotoxins, they are very poorly antigenic. Only thymic independent activation would be occur. Okay, these toxides can be used as a vaccines because they are proteins. And in case of exotoxins, no vaccines are available. Okay, because they are very poorly antigenic. They won't induce any immune response. Heat stability, let's talk about it. Exotoxins are heat labile. They would be rapidly destroyed by the heat, except for the E. coli and Staphylococcus aureus toxin. Enterotoxin of the E. coli and enterotoxin of the Staphylococcus, which causes the food poisoning. You should know that they are heat resistant. Okay, so in order to prevent the food poisoning by this Staphylococcus aureus, you need to store your food at very low temperature in the fridge or the refrigerators. Okay, by heating the food that is contaminated by the Staphylococcus aureus toxins, you cannot eliminate the toxins. Okay, you will get the food poisoning even if you heat the food. So in order to protect yourself from the food poisoning by this Staphylococcus aureus, you need to refrigerate your food instead of heating it. The endotoxins, which are very stable and they can resist a temperature of to 100 degrees centigrade for 1 hour. Then the diseases and their examples, the tetanus, botulinum, diphtheria, cholera, as you all know, they all could be caused by the exotoxins. And the sepsis is caused by the endotoxins. Okay. This is it. As you can see, the exotoxins will be only released when the cell will be lysed. Because what is the location of these endotoxins, guys? The location of endotoxins.
Bacterial DNA.
The location of toxins, not where the
Outer
recipe.
membrane protein.
Yeah,
Outer
exactly. Outer
membrane.
membrane proteins. Yes, these are the outer membrane proteins. No, not the proteins, but the outer membrane present. No? Polysaccharides in the outer membrane. Okay. So they will be released when the cell will be lysed by the immunity. Then comes the different type of toxins. Okay. Different type of exotoxins. Okay. And first are the toxins which inhibits the protein synthesis. And these two will function as same. Okay, and their later two will function as the same. So the Corynebacterium diphtheria and the Pseudomonas has these diphtheria toxin and the exotoxin A, and they both inhibit the elongation factor 2 by the ADP ribosylation of this elongation factor 2, and as a result, the synthesis of protein in the host cell would be inhibited, and what you will get is the cell death, apoptosis, or the necrosis. The Corynebacterium diphtheria will cause the pseudomembrane in your mouth, okay, and the sore throat, of course, and you will get a severe lymphadenopathy in the center of your neck, which is known as the bull's neck lymphadenopathy. Okay, the Corynebacterium diphtheria. Pseudomonas, as you all know, can cause various diseases, including the diabetic foot infection, the pneumonia, the skin infections, and many others. Okay, and one of the cause is the elongation factor 2. Okay, then comes a Shigella species and the enterohemorrhagic E. coli. They have they both have the same kind of toxin. Shigella has this Shiga toxin, and E. coli, enterohemorrhagic E. coli, or the EHEC, has this Shiga-like toxin. They both inhibits the synthesis of your proteins by inactivating the 60S subunit of the ribosome. So Corynebacterium diphtheria and Pseudomonas aeruginosa inhibits elongation factor 2 and leads to the inhibition of the protein synthesis. But the Shiga toxin and Shiga-like toxin inhibits the 60S subunit of the ribosome, inhibiting the protein synthesis. Okay, the Shiga toxin or the Shiga species causing the GI mucosal damage, and you must know that it is not the Shiga toxin which is responsible for the virulency of the Shigella species. It is actually the fact that they can invade your GI cells, and there are some antigen presenting cells in your GI tract. I'm forgetting the name, I'm sorry, but it is the fact that they can invade the GI cells, and that is the cause of the toxicity of this Shigella species, because it has been shown that the Shigella species who lack these toxins are also capable of causing this GI mucosal damage. Okay, the dysentery. Okay, then one disease that you must remember is the hemolytic uremic syndrome, which could be caused by the Shiga toxin or the Shiga-like toxin, and it could lead to the damage to your blood vessels, causing multiple small thrombi in your blood vessels, specifically affecting your kidneys. So you will get a renal failure and diarrhea. So whenever you encounter a children or an infant having an episode of bloody diarrhea, and then he get this renal failure or the flank pain or this hypertension, you will always think about the hemolytic uremic syndrome. And it is a specific serotype of the EHEC that contains this type of toxin. It is a 0157H7. Step 1 gonna ask you this fact: what serotype of the EHEC contains this toxin and can cause the hemolytic uremic syndrome? It is 0157H7 strain. Okay, and you should know that EHEC do not invade the enterocytes of the human, unlike the Shigella, of course. And so that in the enterohemorrhagic E. coli, the main cause of the infection is this toxin. But in case of Shigella, the main cause of the disease or the infection is the fact that they can invade the enterocytes. Okay, any doubt? Any doubt?
Okay.
Okay, then comes the toxins which can increase the secretion of the fluids. Okay, they can cause the diarrhea. For example, they can cause the edema also, right? So the diarrhea causing, first is your enterotoxigenic E. coli, which can cause a traveler's diarrhea. Okay, they had these two type of toxins, the heat labile toxin, like I told you, and because every exotoxin is the heat labile toxin. But I also told you that only two exotoxins are heat stable, and one of them is in the E. coli, and one of them is in the Staphylococcus aureus, right? So this is the heat stable toxin of the E. coli. Okay, so let's talk about the heat labile toxin. It activates the CAMP. Okay, and after activating the camp, you will get the strong secretion of the chloride ions in the GI lumen, and as a result, the water will follow the chloride ions, and you will get the watery diarrhea because of it, because of activation of the cyclic AMP. And how you will get the cyclic AMP from ATP? By activating the adenyl cyclase enzyme. Very important. Okay, you will activate the these toxins will activate the adenyl cyclase. You will increase the CAMP that lead to the secretion of chlorine and the water in the gut, and as a result, you will get the diarrhea. Okay. Then comes the heat stable toxin. They actually overly activates the cyclic GMP, and as a result, the absorption of these chlorine ions will be inhibited. And as a result, the absorption of the water will also inhibited, and you will get the diarrhea. So in case of heat labile toxin, you are secreting the chlorine. In case of heat stable toxin, you are inhibiting the absorption of the chlorine, and you will get the diarrhea in both the cases. Okay. Similar to the E. coli, you have this Vibrio cholerae, which has this cholera toxin, which works similar to this cyclic AMP toxin, the heat labile toxin of the E. coli, and the cholera toxin work in the same way. They both activate the cyclic AMP, both secrete the chlorine ions in the gut. Water will follow the chlorine ion, and you will get the diarrhea. Then comes the Bacillus anthracis, which actually has this anthrax toxin. This anthrax toxin actually mimics the this cyclic AMP thing, and as a result, you will get the secretion of water. And in the case of Bacillus anthracis, what you will get the edematous borders of the Ishar, if you remember, and you will also study that later in the main micro section, that you will get the Ishkar formation in the Bacillus anthracis, and this Ishar had this very edematous borders, and this anthrax toxin is responsible for this. Okay. So that's about the increased fluid secretion. So you can get the increased fluid secretion either by activating the cyclic AMP, which increases the chlorine ions, water will follow, and then this cyclic GMP that leads to the inhibition of the absorption of chlorine ions. Okay. Then comes a toxin that inhibits the phagocytic ability of your cells, of your immune cells, and this is the Bordetella pertussis, which has this pertussis toxin that actually inhibits the GI inhibitory protein, right? And so that you can get the overactivation of cyclic AMP. This GI actually inhibits the cyclic AMP formation. And if you inhibit the GI, you will get the activation, overactivation of the cyclic AMP, and this is the cause by which your immune cells cannot act against this Bordetella pertussis. Okay, you will get the whooping cough after this pertussis disease, where you will get the cough, and you suddenly get this vomiting, which is also known as a post-tussive vomiting. Okay. Then the toxins which inhibits the release of neurotransmitters, either they can inhibit the release of excitatory neurotransmitters, or they can release the inhibitory neurotransmitters release. Okay. First are your Clostridium tetani, which has this tetanospasmin toxin that cleaves the snare proteins. Snare proteins are soluble NSF proteins. Okay, and these are the proteins for the SNAP receptors. You don't need to remember these facts, just remember that they inhibit the snare proteins. It is just for the extra information if you want to remember it. Soluble NSF receptors or the SNAP receptors. Okay, and they basically, snare receptors are responsible for the release of neurotransmitters from your nerve endings. Okay, and if you cleave the snare proteins, then you're no longer able to secrete the neurotransmitters in the cleft between the synaptic space, remember? So the tetanospasmin actually inhibits the release of this excitatory neurotransmitter, the inhibitory neurotransmitter, okay, which is your GABA and the glycine. Remember the fact that GABA and glycine are the inhibitory neurotransmitters. So basically, after cleaving the snare proteins, you cannot release the GABA and glycine neurotransmitters, and you must know about these Rancho cells, which are kind of inhibitory cells. They inhibit the overcontraction of your muscles. Okay, they inhibit the overcontraction of your muscles. So by inhibiting the GABA and the glycine release, you're actually activating your muscle pathway, the muscle contraction pathway, and what you will get is the paralysis, the spasms and the paralysis. Due to the spasms, you will get this locked jaw. You cannot move your jaw. You cannot move your neck because of this muscle contraction, the torticollis, Okay, you will get a very high arched back. You will get the spasms in your hand, in your muscles, in multiple areas, right? Then you have this Clostridium botulinum, which produces the botulinum toxin and it inhibits the release of acetylcholine, which is a stimulating neurotransmitter, and as a result, you will get the paralysis. Again, the flaccid paralysis, not the spastic. In case of tetanus, you will get the spastic paralysis. In case of botulinum, you will get the flaccid paralysis, which causes the hypotonia. In this case, you are getting the hypertonia. Okay, and in this case, you are getting the hypotonia or the floppy baby. Ultimately, this botulinum toxin will also affect your respiratory muscles. You will get the paralysis of the respiratory muscles and can the death of the patient. Okay. Then you should know about the AB component of these toxin. Every toxin you see having this name A, almost every toxin have these two components. That component A and component B. Component B actually helps the component A entering the cell. And finally, after entering this, component A will become activate and causes the disease that you know here. Then comes the cell lysing proteins, which are of two kinds, the Clostridium perfringens and the Streptococcus pyogenes. The alpha toxin in the Clostridium perfringens can causes the cell lysis because they act as a lecithinase, which is a phospholipase. And that means these are the enzymes which degrades the plasma membrane of the cell. These are the phospholipases. So basically, they degrade the cell membrane or the plasma membranes, causing the cell lysis. And this is the reason why these Clostridium perfringens are actually the hemolytic. They have this positive hemolysis test because they can destroy the membrane of the RBCs, causing the hemolysis. And after degrading the membrane of your muscles, and now you will get this gas gangrene, myonecrosis. You will get the gas gangrene, and you will get the hemolysis because of this phospholipase. Stefan gonna ask you the reason behind this myonecrosis, and this is due to the lecithinase or the phospholipase. Then the streptolysin O, and this is the reason why this Streptococcus pyogenes is actually beta hemolytic, because it has this streptolysin O, which causes the lysis of the RBCs, okay, which contributes to the beta hemolysis part of this Streptococcus pyogenes. Okay, and you should know that the antibodies against this streptolysin O is used as a marker of the previous infection with the Streptococcus pyogenes. What happens when you get the infection from the from this Streptococcus pyogenes? After the infection is over, you will get the antibodies against the streptolysin O, and this is the ASO titer that you use to diagnose the previous infection of Streptococcus pyogenes. Okay. Then comes the super antigens, which are of two types, either the toxic shock syndrome toxin or the toxic shock syndrome like toxin, which is the erythrogenic toxin or the erythrogenic exotoxin A of the Streptococcus pyogenes. What happens is this toxic shock syndrome toxin bind outside the MHC2 and the T cell receptor. Generally, what happens whenever your antigen presenting cells gonna present any antigen to the CD4 cells, they will present the antigen binded to the MHC2, right? But this toxin will bind outside the MHC2 like that. Let me show you this. Let's suppose this is your antigen presenting cell and this is your CD4 cell. Okay, these antigen presenting cell has these these MHC2, and the receptors for this MHC2, the T cell receptors, are found in the CD4 cells. Okay, now generally the antigens normally present here. Okay, generally antigen present here, but in case of super antigens, they will bind like that outside the binding sites, and as a result, you will get the massive release of these interleukin 1, interleukin 6, TNF alpha, interferon gamma, very massive release of these neurotransmitters. And as a result, what you will get is the shock, fever, sepsis, and shock you will get in both of these scenarios. Okay, so the toxic shock syndrome, what you will get is the fever, the shock, the rash. Okay, and in case of Streptococcus pyogenes, you will get the fever, rash, shock, as well as a scarlet fever, where you will get these multiple non-blanching type the blanching type rash all over the body of the patient, and the strawberry tongue, if you remember, very reddish, and these dots all over the tongue, the strawberry tongue you will get in the scarlet fever, and this is because of the reactogenic toxin or the super toxin of this Streptococcus pyogenes. And you should also remember about the heat stable enterotoxin of the of this Staphylococcus aureus, which causes the food poisoning. Okay. This is about all of the exotoxins. Then the easy way to learn about every toxin which is coded by the bacteriophage is by the fact that every species that you study, which works in the same way, which have the exotoxins that works in the same way. One is naturally formed inside the cell and one is coded by the bacteriophages. For example, like diphtheria and the pseudomonas, the toxin of the diphtheria is caused by the bacteriophage and the toxin of the pseudomonas is formed naturally inside it. In the example of the Shigella and the E. coli, the Shigella toxin, which is the Shigella species toxin, it is coded by the bacteriophage and this toxin is naturally found in the EHEC species. In case of E. coli, the heat labile toxin, one which is formed naturally inside the E. coli is in the E. coli itself, and the Vibrio cholera, the cholera toxin, which works in the same way as that of this camp, it is coded by the bacteriophage. So one is always coded by the bacteriophage and one is naturally formed inside the bacterial cell. Similarly, the tetani and the botulinum, the botulinum toxin is coded by the bacteriophage and this tetani is normally formed in the bacterial cell. Then the toxic shock syndrome, like toxin of the Streptococcus pyogenes, is coded by the bacteriophage. Okay, and the toxin for the toxic shock syndrome toxin is naturally formed inside the Staph aureus. Any doubt?
One second. Excuse me.
Yeah.
That enterotoxin by Staph aureus, is that too a super antigen?
Enterotoxin of
Staph aureus.
No, not due to super antigen. It just
That's not a super antigen.
No, not due to super antigen. It's just the Streptococcus pyogenes, the botulinum, the Vibrio cholerae, okay, the Shigella species, and this diphtheria. Okay.
I'm asking about super antigen.
What?
I'm asking about super antigens and that column of Staph aureus along with the toxic shock syndrome. We have written that heat stable enterotoxin. I'm asking about that enterotoxin. Yes,
yeah,
enterotoxin by the Staph aureus. Is that too a super antigen? Because
No,
that's written long.
No. It is not a super antigen. It just they have mentioned this enterotoxin, but it is not a super antigen. Okay, this is another toxin which is found in the Staph aureus. Okay.
Okay.
It is not a super antigen. Only this TSST1 and exotoxin A is the super antigens. Okay, then the function of these endotoxins, like I already mentioned, all endotoxins works in the same way. They have these three components: the lipid A, the O antigen, and the core polysaccharides. And you should know that this O antigen used for the antigen typing. It will determine what type of endotoxin, what kind of species secreted this endotoxin. So with the help of this O antigen, you can type it. The lipid A is the real part which mediates the sepsis and the shock in these endotoxins. Okay, and all of them are the lipopolysaccharides. Okay, and the fact you should remember is they only released upon the cell lysis. Okay, living cells do not release the endotoxins. Okay, and of course, after releasing from the cell, what's gonna happen? They will bind to the toll-like receptors of the macrophages. Okay, or the CD14 receptors of the macrophages, and that lead to the activation of the macrophages. Macrophages will release the interleukin-1, interleukin-6, TNF-alpha that can lead to the fever, hypotension, and the shock. They will also release the nitric oxide. Remember the reaction for the nitric oxide release, the arginine part. Remember?
Arginine will get converted into citrulline.
Exactly. Arginine will be converted into the citrulline and it will release the nitric oxide that can again cause the hypotension. So the macrophages activation will causing the hypotension and the fever. Okay. Second thing is the complement activation. Okay. The complement factor C3A and C5A. And like I told you, these C3A and C5A are responsible for the mast cell degranulation. And plus The C5a is also responsible for the neutrophil chemotaxis. So what you will get is the mast cell degranulation and the inflammation caused by the neutrophils. Okay. Then the tissue factor activation will be occurred, and what you will get is the coagulation cascade. And the activation of the coagulation cascade will lead to the formation of microthrombi all over your blood vessels. And what you will get is a deficiency of, the deficiency of these coagulation pathways or the factors. And what you will get is the DIC, disseminated intravascular coagulation. You will get the bleeding from the IV sites, bleeding from the gums, the mouth, the nose bleedings you will get. Okay, so you understand the function of endotoxin, the three-way activation of the macrophages, activation of the complements, and activation of the tissue factors. Macrophage activation lead to the fever and shock and the inflammation. Complement activation leads to the mast cell degranulation and the neutrophil chemotaxis. And the tissue factor activation leads to the DIC. Any doubt?
No.
Okay, and then we are going to study this flowchart for the gram-positive bacteria. How you can differentiate between different gram-positive bacteria by looking in the microscope. So you should know that every gram-positive bacteria will appear as blue or purple in the microscope. Whenever they give you a slide or a diagram showing these bluish organisms, they must be the gram-positive bacteria. They could be of three shapes, either the cocci, either the bacilli, or either the branching filaments. Okay, the example of bacilli, they could be of two types, either the aerobes or the anaerobes. I already told you three names for the aerobes, sorry, the actinomyces, the clostridium, and the bacteroid species, right? So clostridium, as you can see, they are the gram-positive and they are anaerobes here. Okay, and the acne causing bacteria, which are the Cutibacterium or the Propionibacterium, they are also anaerobic bacteria, and these are gram-positive. These are the bacteria that causes acne. Then comes the aerobic bacteria, the Listeria, the Bacillus, and the Corynebacterium, diphtheria. These three are the aerobic bacilli, aerobic gram-positive bacilli. Okay. Then comes the cocci. Cocci could be of two types, either the Staphylococcus. They all have the name coccus in them. Okay, either the Staphylococcus or the Streptococcus. Whenever you look in the microscope, if you're getting the clusters of the cocci like that, this means it is a Staphylococcus species. And if you're getting these chains of the cocci, this means this must be the Streptococcus. And you should know that every Staphylococcus are always catalase positive. You can remember the mnemonic that I told you. Every the cat need places to bite their hairs, either that, or you should also remember that every Staphylococcus is catalase positive and every Streptococcus is catalase negative. Okay. Then to differentiate between the different Staphylococcus, you do something known as a coagulase test. Okay, if they have this coagulase enzyme, if they're causing the coagulations, that means it is Staphylococcus aureus. If you're getting a negative coagulase, that means it is either the saprophyticus or either the epidermidis. You can also does one test, which is the mannitol fermenting test. Okay, if the catalase positive organism is also a mannitol fermenter, that means it is a Staphylococcus aureus. They can ask you the facts about it. They will give you a media and they will tell you that media color will is turned from pink to yellow, and the organism was also catalase positive. Then you must know that it is the Staphylococcus aureus. Then to differentiate between the remaining Staphylococcus, you will do the novobiosine sensitivity test. Very important, novobiosine sensitivity test. And if the bacteria is sensitive, that means it is epidermidis. And if the bacteria is resistant, that means it is saprophyticus. And this is the same saprophyticus which is also urease positive, and it can cause the UTIs. Okay. Then comes the Streptococcus, which all of them are catalase negative and all of them are cocci in chains. You will see the chains of these bacteria, of these cocci, whenever you look in the microscope. And then they could be of three types, either the alpha hemolytic group or the beta hemolytic group and the gamma hemolytic group, depending upon the type of hemolysis they do. If they do a partial hemolysis, then the colonies they form would be kind of a green in the color. And that's how you know this is the alpha hemolytic group. And two type of root will be exist, either the Redans or the Streptococcus pneumoniae. So how you going to differentiate between these two bacteria? Well, this is done by the optogen test. If the bacteria is optogen sensitive, it means it is pneumoniae. If the bacteria is optogen resistant, that means it is Redans. But largely this test is not replaced with the bile solubility test. Nowadays you will do this bile solubility test, not the optogen test. And if the bacteria is bile soluble, it is this pneumoniae. And if the bacteria is not bile soluble, that means it is a Redans bacteria. Okay. Then comes the beta hemolytic group, and for the beta hemolytic group, you will do the bacitracin test. If the bacteria is bacitracin resistant, that means it is the group B bacteria, which is Streptococcus agalactiae. And if the bacteria is sensitive to the bacitracin, it is the thiogens. But largely this test again is replaced by the PYR status. And if the bacteria is PYR positive, that means it is this thiogens. And if it is PYR negative, that means it is agalactiae. Then comes the gamma hemolysis, which is no hemolysis at all. Okay. And you have two type of bacteria in it. One is the enterococci, either the Enterococcus faecalis, faecium, and or you will have this Streptococcus bovis. Okay, so you will do two type of tests, and you should know that all of them are bile soluble. They all can grow in the bile, just like the Streptococcus pneumoniae. They all can grow in the bile, and you will do the 6.5% NaCl test. You will put these bacteria in the 6.5% NaCl solution, and if they survive, that means these are the Enterococcus species. Okay, and you can also check the PYR status, and if they are PYR positive, that means they are the Enterococci, and if they are PYR negative, that means they are bovis. Same PYR test that you use for the Streptococcus pyogenes. Okay. So this is basically a flowchart that you must remember about different, the major properties of all the gram-positive organisms that helps differentiating between different type of bacteria. One by one, we're going to study every bacteria in the later pages. Okay. And again, this paragraph shows what test that you do for these bacteria. Okay. The novobiocin, the optogen, and the bacitracin. Then the different type of hemolysis, as I told you, alpha hemolysis is the partial hemolysis. You will have this green color of the colonies, and the beta hemolysis is the complete hemolysis. You will get this enhanced area of the hemolysis, as you can see here, very enhanced area. The two type of bacteria, the Redans and the Streptococcus pneumoniae. Okay, which one is bile soluble? In between these two, which one is bile soluble?
Pneumonia.
Pneumonia. Okay. Okay, so that's it. And which one is PYR positive among these three? PYR positive. Pyogens, yes. And can you tell me why the pyogens is beta hemolytic? Because of which toxin? Streptolysin O, remember? And that's why you do the ASO titers after the infection of pyogens is over, to diagnose the previous infectious cases of the pyogens. The ASO titer you uses, and this is the same enzyme that causes the hemolysis of the RBCs. And that's why the pyogens is beta hemolytic. Now we're going to study every bacteria one by one. And for the bacteria, I want to organize that, every data of the bacteria into some tables. And first is the name of the bacteria. Then you will study about the reservoir of the bacteria, where they stays in your body. Then you will study about the, the bacterial cultures, what type of colonies they show, what kind of agar they use. Okay. Then we will study about their virulence factors, what kind of enzymes they have, what kind of toxins they releases. Okay. Then we will study about the diseases that they will cause. And finally, the treatment of choice, the antibiotic that you can use for them. Okay. So first come is your Staphylococcus aureus. You should know that the Staphylococcus aureus is actually a reservoir in your skin. And the most common locations are your axilla and your nares, the nose and the axilla. Okay. And of course, your hands and anywhere in your skin, you will get the Staphylococcus aureus. And that's why the most common cause of post surgical infections is your Staphylococcus aureus. And then their bacterial culture, like I already told you, that they are the cocci in the clusters. They are arranged in the clusters. Okay, and because aureus secretes this pigment, the yellow pigment. Remember, their and that's why their colonies could be of yellow. Okay, and they belongs to this beta hemolysis group. Please remember the fact the only catalase positive organism which causes the hemolysis is the Staphylococcus aureus, and it belongs to the beta hemolytic group. And like I told you, they can also ferment the mannitol, remember, and they convert this pink media to yellow. Okay, this is the bacterial culture. Then we will talk about the virulence factors and the resistance of this Staphylococcus aureus. Okay, first of all, the enzymes, the different type of enzymes this Staphylococcus aureus has. Okay, and so these are basically the catalase, as you already know, and that's why these are catalase positive. Okay, so the catalase enzyme will be the first enzyme they have. The other enzymes includes the coagulase, and that's why they are coagulase positive, and other staphylococci are coagulase negative. They also have this hemolysis, and that's why they are beta hemolytic. Okay, they have this lipases, and they have this penicillinases, of course, which provide them the resistance against the penicillin drugs. Okay, so what enzymes they have? They have this coagulases, they have this catalases, and they have this beta lactamases. Okay, they have this hemolysis. 4 type of enzymes they have. Hemolysis that causes the beta hemolysis, catalase, coagulase, and that's why they are both positive. Okay, and yeah, that's it. And some kind of proteins that they have, which make them kind of very effective killers. And first is basically the protein A. Like I already told you about this protein A. The protein A is involved in binding of the Fc portion of the antibodies, so that the opsonization of these bacteria could be inhibited. And what you will get is the bacteremia. That's how the Staphylococcus aureus survives in your blood. Okay, antiphagocytic thing. And yeah, that's it. Then you have this different type of toxins that they have. First toxin is the toxic shock syndrome toxin, which causes this disease known as the staphylococcal toxic shock syndrome. We will study that later. Okay, the second type of toxin that they have is the enterotoxin B, which is a heat stable toxin. Like I already told you, E. coli heat stable toxin and Staphylococcus heat stable toxin. And this is a toxin which causes the food poisoning. Okay, please remember the fact that this heat stable toxin causes the food poisoning, and the only way to prevent the food poisoning from the Staphylococcus aureus is to store the food in the refrigerator. Heating the food cannot prevent the food poisoning by this Staphylococcus aureus. Then you have another toxin known as the exfoliative toxin, the same toxin which is responsible for the scalded skin syndrome of the Staphylococcus aureus. You have this sludging of the skin from the patient body, and this is a Nikolsky sign. Whenever you lay a hand on these patients, whenever you rub a hand over the skin of these patients, what you will get is a sludging off the skin, and this is a Nikolsky sign, and that you will see in the scalded skin syndrome caused by the exfoliative toxin. Okay, so yeah, the exfoliative toxin. And yeah, they also have one more toxin, which is a leukocidin. You can see here the leukocidin, and this toxin is especially found in the MRSA species only. Okay, leukocidin, as the name says, they causes the damage of the leukocytes. It destroys the leukocytes and involved in the tissue necrosis. Okay, like skin necrosis that you see, skin abscess that you see in the Staphylococcus aureus infection, it is due to the leukocidin only. I think that is a leukocidin. And you should know that this leukocidin is also bacteriophage coded. If I failed to mention that part, leukocidin is actually a bacteriophage coded. It causes the leukocyte damage and the necrosis. Organ abscess that you get, the liver abscess, the lung abscess in case of Staphylococcus aureus, the skin abscess in case of Staphylococcus aureus, you will see It is all due to the leukocidin toxin, and it is most commonly found in the MRSA. So you know the name of the organism, you know where the organism is found in your body, you know what kind of test you perform to diagnose the infection, and you know what kind of enzymes they have, different type of enzymes they have, what different type of toxins they have, and yeah, what different type of proteins they have. Okay, and now we will discuss the disease that are caused by these toxins and these proteins. Okay, so the most important disease that it causes are the skin infections. Okay, I'm sorry about that. They causes the skin infections. They causes the skin infection. They can cause the lung abscess. They can cause the liver abscess, and all is due to the leukocidin toxin. Okay, they can also cause the acute bacterial endocarditis, which you will study in the cardiology section. They causes the acute bacterial endocarditis, and especially in the IV drug abusers. Okay, acute bacterial endocarditis in the IV drug abusers. Okay, then you can get the pneumonia, and please remember that pneumonia is always the post-viral type of pneumonia. Okay, so whenever you get a case of any influenza virus, you know the symptoms of the influenza virus: the fever, chills, headache, fatigue, okay, running nose, cough. And it would be a case of the patient who generally got this influenza virus and was recovering from the influenza, and suddenly 4 or 5 days later he started developing the pneumonia, and they will ask you what could be the most common cause of this pneumonia in the patient, and you will answer the Staphylococcus aureus. They causes the post-influenza pneumonia. Okay, you will get the endocarditis, which is mainly in the IV drug abusers, because after injecting the drug in your veins, as you know that Staphylococcus aureus is present in the skin, you know, you will also inject the aureus in the blood, and as a result you will get the endocarditis, because I told you whenever a bacteria gains the access to your bloodstream, it can go anywhere. Okay, it can go to your brain, it can go to your bone, it can go to your heart, it can go anywhere, right? And so after gaining access to your blood, it can cause the endocarditis. Okay, similarly, after gaining access to the blood, it can go to your joints and can cause the septic arthritis, which will present as a very painful joint. Okay, painful knee, very red, swollen, you know, warmth over the area you can feel, and it is a very painful condition, acute condition. Then it can go to your bones and can cause the osteomyelitis. It will also, it also present as a fever and the bone pain. Okay, you have this normal passive movement of the joints, but have pain on getting some load over yourself. Okay, while walking or while lifting some weight, you will get the bone pain, but not just doing the random movements of your bone, you won't get the pain. Okay, then the diseases caused by these toxins, like I told you, the scalded skin syndrome caused by the exfoliative toxin. Okay, the food poisoning, which is caused by the enterotoxin. Okay, then comes the toxic shock syndrome, and the most important buzzword that you should remember, that it is always seen in the patients who are using the tampoons, vaginal tampoons, or the nasal packings, which used to control the bleeding. So it could be a patient who involved in some kind of a bar fight or fight anywhere, and then he uses the nasal packing to control the bleeding, and after 1 or 2 days he's presenting to your emergency department with the fever, shock, nausea, vomiting, hepatomegaly, high ALT, AST count, some kind of a skin rash. And you should remember the skin rash is very photosensitive. You will get the ulcerations, blistering over the skin whenever you expose them in the sunlight, and it could also resemble as a sunburn. Okay, so please remember these mnemonics, not the mnemonics, but the buzzwords: the vaginal tampons or the nasal packing. Patient will always present you with these two histories, and what you will get is the fever, hypotension, and organ failure. That could be a renal failure, could be a heart failure, erythematous rash, which is diffusely all over the body, and it is a photosensitive type of rash. Okay, and please note that because it is mediated by the toxin, not by the bacteria itself. So in the blood of the patient, you won't get the bacteremia. You won't get to isolate the bacteria in the blood, but just the bacteria will replicate in the nasal packings or in the vaginal tampons. Okay, the bacteria will replicate locally, and after replicating, it will secrete the toxins in the bloodstream, and that's how you get the toxic shock syndrome. Okay, and like I told you, the function of the toxic shock syndrome toxin, it binds outside the binding sites in the MHC2 and the T cell receptors, and that leads to the widespread release of the or the dramatic release of the cytokines. Then you should know about these MRSA, which causes a serious hospital infections. Okay, and you should know that they have these MAC-A genes. Okay, which provide the resistance against these penicillins. Okay, and this is the methicillins or the nafacillin, the oxacillins. Okay, they are the beta lactamases resistant antibiotics. Okay, but now you have this MAC-A gene which altered the penicillin binding proteins, and that's how you get a resistant against these antibiotics, the methicillin, the oxacillin, or the nafacillin. So these bacteria are called the MRSA, and only in these MRSA you find this leukocidin, very important. Okay, and yeah, on the skin you can get this skin abscess, or you can also get yeah, that's it. Any doubt on the Staphylococcus aureus? Any doubt? Any doubt, guys?
No.
And one more thing that you should remember is the time duration of this food poisoning. Once you ingest the food poisoning will happen on the same day within 2 to 6 hours. So whenever you encounter a patient who is having some kind of a dinner or a lunch party, and 4 or 5 hours later he start developing this vomiting, mainly because you know that this food poisoning is vomiting dominated. Okay, you won't get to see the diarrhea in case of the food poisoning caused by Staphylococcus aureus. You will get just the recurrent episodes of vomiting. Okay, and sometimes you can get a diarrhea also, which is watery diarrhea, but the vomiting is very important. Okay, then comes the Staphylococcus epidermidis. You should know the name already, and now you should know where you found these organisms. So you know that they are found everywhere on your skin, just like a Staphylococcus aureus. Okay, these are the natural skin flora. This is a very important thing. These are the natural skin flora. Okay, and yeah, they generally do not cause any infection inside your body. But once you once you enter any foreign body inside your body, like any prosthetic device, any valve, any bone replacement, any catheter, they can easily colonize this foreign body and can cause the infection then. Okay, not just like that only. You need to have a foreign body inside your body in order to cause the infection by these organisms. Okay, then comes there how you can identify these organisms. So just like the Staphylococcus aureus, these are the cocci in clusters, and like I told you, they are novobiosyn sensitive. Okay, and they do not ferment the mannitol because only Staphylococcus aureus can ferment the mannitol. And I already told you about one of the enzymes these bacteria help, and it is a urease enzyme. Okay, these are the urease positive. Okay, and yeah, that's thing about they have. Then you should also know one more fact about these bacteria, that they are the biofilm producers. They produces the biofilm, help help them colonizing any prosthetic device like a hip implant or either the heart valve or any other bypass surgery or maybe the IV catheters. Okay, they form the biofilms, they forms a colony on them, and they can cause the infection. You should know the fact, you already know the fact that they are the colonizers or they're the natural flora of your skin. So whenever you do a blood culture, they always contaminate the blood culture. It seems like the infection is caused by these organisms, but the fact that they are on the skin. So whenever you do a blood culture, they always found in it. They contaminate your blood culture. So in order to diagnose the infections caused by these organisms, you need to draw either at least 3 or 4 blood cultures. Okay, and in all these culture, if you find the epidermidis positive, then only you can conclude that the patient is having the epidermidis infections. Otherwise, it might be just a contaminant in the culture. Okay, very important. So they can rarely causes any infection in the healthy individual. The individual must have one of these, any foreign body inside it in order to cause the infections. And you please must know one fact about these organisms, that they are mostly MRSAs. They are mostly methicillin resistant. So whenever you want to initiate any drug against these bacteria, it always the vancomycin. So for the initiation therapy, you always use the vancomycin, considering these as the MRSAs, unless the proven otherwise. You will set the blood cultures, you will isolate the organism, you will test them for the resistant. And if they found sensitive to the oxacillin or the methicillin, then you can change the antibiotics. But mostly they are found resistant to these oxacillin or methicillin, and that's why the initial antibody, the initial antibiotic is always the vancomycin. Okay. And one more thing I forgot to mention, I was forgetting the name, and it is a cellulitis, the skin infection. One is the abscess, and second is the cellulitis caused by these Staphylococcus aureus. And cellulitis always present as fever, redness, swelling over an area of your skin. Okay, swelling, fever, redness, tenderness. Of course, the pain would be there, right? And it is mostly a purulent cellulitis, which is happened when the cellulitis when the abscess is present along with the cellulitis. This is known as a purulent cellulitis. It is very foul smelly type of cellulitis. It is very painful nodule. It has this center where the abscess is present, so it is a purulent cellulitis. Okay, so that's about epidermidis and Staph aureus. Any doubt? And yeah, one more thing that you should remember about this impetigo, that scalded skin syndrome, like I told you, is caused by the exfoliant toxin, but the impetigo is caused by the direct invasion of the Staph aureus in the skin. So it is caused by the direct invasion, and that means it is a pyogenic infection. Remember, I told you the pyogenic infections, which causes by the direct invasion of the bacterial cells. Okay. So yeah, the skin infection include the abscess, the cellulitis, and the impetigo. Okay, the toxin includes these scalded skin syndrome, the food poisoning, and the toxic shock syndrome. Okay, any doubt now?
Can you explain the cellulitis part again?
Okay, so how will a patient with cellulitis gonna present you? Okay, he will present you with fever, of course, because there is an inflammation, there is an infection inside your body. You will always get a fever. Along with the fever, you will get the pain in the skin where the cellulitis is present. That area will become very red, very hot. The tenderness would be there. Whenever you try to palpate the area, you will the patient will get the pain. Okay, and generally what happened along with the cellulitis, you will get the skin abscess too. A small part of area would become very abscissed. You will also get the abscess, and this is known as a purulent cellulitis, because in the abscess part there present very foul smelly abscess. Okay, and the abscess is very foul smelly. So what you will get is a purulent cellulitis. Okay, so cellulitis is basically the inflammation of your skin where you get this pain, the tenderness, the redness, and of course the fever. Okay, a painful nodule. You can imagine it like a painful nodule over your skin.
I can understand. Thank you, sir.
Many of us might actually have it. Remember, if you guys remember, many of you might have it actually, at some point of time. Then comes the Staphylococcus saprophyticus. You should know the reservoir, and it is your urinary tract, which is a natural reservoir of this organism. Okay, the female genital tract and as well as your perineum are the reservoir. Okay, and the natural flora. Okay, then how you could identify these organisms? Well, by the novobiosine test, like I told you, they are novobiosine resistant, and of course, unlike the Staph aureus, they are mannitol negative. Okay, and of course, they are also coagulase negative. Okay, but they are catalase positive, they are gram positive. Okay, and you should know that they causes the uncomplicated urinary tract infection. Okay, they are urease positive. They have this enzyme urease. They are urea positive. And one most important thing that you guys must remember, that every gram positive organism is nitrite negative. So whenever a question stem mention a case of urinary tract infection where the culture showing a bacterial cells who are nitrite negative, they are hinting you towards the gram positive organisms. Okay, and if they tell you that the organisms were nitrite positive, that means it must be the gram negative organisms, which is most commonly the E. coli. So please remember the fact that the gram negative are always the gram positive organisms, and nitrite positives are always the gram negative organisms. Okay, so they causes the uncomplicated urinary tract infection. What are the symptoms of the UTI? You will get urgency. You will get the frequency, urgency. You will get the pain with the micturition, burning pain with the micturition. These are some symptoms of the UTI, but you won't get the fever. Okay. If you get the fever, you are having the pyelonephritis, not the uncomplicated UTI. So any doubt against this, about this saprophyticus? No doubt. Please remember this fact, nitrites and urea is very important. Then comes the Streptococcus pneumoniae, and where they're generally found in your lung, not a natural reservoir, but they actually causes infections there. Okay, in your lungs or in your any mucosal tract, mainly your respiratory tract, of course. Okay, how you can identify these bacteria in the microscope? They are cocci in chains, like I told you. As you can see here, they are forming these chains. And one most important thing that you must know is they are the diplococci. As you can see, 1 and 2 bacteria, 1 and 2 bacteria, 1 and 2 bacteria, 1 and 2 bacteria, 1 and 2 bacteria. So they all are the diplococci. Okay, and yeah, that's how you can identify them. So the test that you perform to identify these organisms, first is your catalase test. They are catalase negative. Then the hemolysis test, they are alpha hemolytic. Then you can do the optogen test, they are optogen sensitive. Then you can do the PYR status, and they were PYR positive. And because they have the capsules, they are Q-lung reaction positive. You will get the capsular swelling in the Q-lung reaction, and it is specific for the Streptococcus pneumoniae. Okay, the different type of toxins or proteins they have. One of the most important one is the IgA proteases. Like I told you, they cleave the IgA antibodies and leads to the colonization of these bacteria in your respiratory tract. Without clearing the IgAs, you cannot colonize these organisms cannot colonize your respiratory tract. Okay, they have this capsule, the polysaccharide capsule, which is antiphagocytic. Okay, and yeah, the diseases that they cause, the one is the meningitis, because they can easily access your blood stream, and if they get access to your blood stream, they can easily go anywhere, and the most important location is your brain, and these are the most common cause of the meningitis. Okay, they are also the most common cause of otitis media in the children's. They are also the most common cause of sinusitis, and as well as the most common cause of pneumonia. Okay, remember the two type of vaccines available for this Streptococcus pneumoniae, the PPSV23 and PCV13. PCV13 is a conjugate vaccine, and PPSV is the polysaccharide vaccine. Okay, and because they are alpha hemolytic, what you will get is a rusty sputum because of the lysis of the RBCs. You will get a brownish, somewhat reddish, rusty sputum, in the pneumonia of these patients. Okay, and in the asplenic patients, like I told you, you require the IgG antibodies, and you require the complement fixation, opsonization by the complements in order to destroy these bacterial cells. But if you do not have the spleen, you won't get the complement fixations. Okay, and what you will get is the infection from these bacteria. So asplenic patients must require the vaccination against these bacteria. And like I told you already in the transduction part, that they have no virulence without the capsule, and they acquire their capsule gene by the transduction process. Okay, and one of the most important thing that you do while treating the meningitis case of the Streptococcus pneumoniae is to giving the patient dexamethasone, which is the glucocorticoid, to suppress the immunity, because when the cell lysis, they releases their content. Once you give the patient the drugs, what's going to happen? They will kill the cell, and as a result, the cell lysis will release the contents of the cell. And against these contents, what you will get is the immune response. You will get the inflammation in your brain, and that will further contribute the meningitis. It can further aggravate the symptoms. And so in order to control these symptoms, what you will give patient already the dexamethasone, so that the internal immunity of the patient could be suppressed and the drugs can easily work now. Okay, so any doubt in the Streptococcus pneumoniae? Any doubt?
No.
Then comes the Redans streptococci, which are Streptococcus redans, and there are two types: the Streptococcus mutans and Streptococcus sanguinis. Sorry, three types: Streptococcus mutans mitis and Streptococcus sanguinis. Okay, and it is the mutants and mitis that causes the dental caries, dental plaques and dental caries. Why dental plaques? Because they have the ability to form the biofilms, and it is the sanguinis which causes the endocarditis. Okay, please remember, endocarditis, subacute bacterial endocarditis is caused by the sanguinis, and dental caries are caused by the Streptococcus mutans. Okay, and you can easily identify them by the alpha hemolysis. Okay, the catalase negative, alpha hemolysis, optochin resistant, and PYR negative they have. Okay, and yeah, they have the ability to form the biofilms, and that's why they can easily colonize the exterior devices inside your body, any foreign bodies. Okay, very important. And they can easily colonize your teeth, can cause a dental caries, tooth pain you will feel. Okay, and you should also know that they can also cause the brain abscess, and you must know that the Streptococcus redans and Staphylococcus aureus are the most common cause of brain abscesses. Okay, very important. Then comes the Streptococcus pyogenes group A. Okay, so where do you found the Streptococcus pyogenes in your body? You can found them in your nares, okay, nose, and you can also found them in the nasopharynx only mostly. And you should know that the humans are the, I'm sorry about that. Yeah, you should know that the humans are the only colonizers of these organisms. No animal can colonize them. Only the humans are the only colonizers of these organisms. Okay. Then you should know how you can identify these organisms. Like I told you, they are catalase negative, they are beta hemolytic, okay, and they are bacitration sensitive, but PYR positive. Please remember these 3-4 facts about these bacterias. The other thing that you should know is what kind of toxins, what kind of enzymes, what kind of proteins they have. So first of all, the toxins, you have this, this erythrogenic toxin, which is the toxic shock syndrome like toxin. Okay, the first toxin they have, the toxic shock syndrome like toxin, like I already told you. Secondly, they have this streptolysin O, which degrades the RBCs, making them the beta hemolytic. Okay, so yeah, this is the toxic shock syndrome like toxin, and the ASO. This is the streptolysin O toxin. Okay, and then yeah, the enzymes they have the DNases, which destroy the DNA of the neutrophils, and as a result they have the potentials to causes the infections because they can destroy the neutrophils. Okay, and you can also diagnose the previous cases of the Streptococcus pyogenes by checking for the anti-DNase B antibodies. Okay, so these anti-DNase B antibodies actually destroy the DNA of your neutrophils, making them very potential organisms to cause the infections. Okay, then comes the proteins, and they have very important protein, which is the protein M. Remember that fact I told you about the protein M, that they are the antiphagocytic proteins, and these are the proteins which share the molecular mimicry with the cardiomyocytes, with the cardiac tissue, and as a result you will get the this rheumatic fever after the pyogenes infection, rheumatic fever after the pyogenes infections. And step 1 gonna ask you how you can prevent the rheumatic fever in the Streptococcus pyogenes. And this is the fact: you need to give the patient antibodies as soon as, antibiotics as soon as possible. Okay, to prevent the case of rheumatic fever, you need to give the patient penicillins or the antibiotics as soon as possible. Okay, once you diagnose that the patient is having this anti-ASO titer and the patient is having an anti-DNSB titer, and the patient is also having a history of this pharyngitis or the sore throat, you immediately need to give the patient antibiotics, otherwise he might gonna have this rheumatic fever. Okay, and please remember, only the strains that causes a rheumatic fever, only the strains that causes the pharyngitis can cause a rheumatic fever, and the strains that can cause the impetigo and the pharyngitis, they can cause the post-streptococcal glomerulonephritis. What kind of hypersensitivity reaction it is? PSGN. What kind of hypersensitivity?
Type 3.
Type 3 hypersensitivity. And what kind of hypersensitivity is a rheumatic fever?
Type 2.
Type 2. Okay, please remember these facts. And yeah, that's it. And you need to know about this scarlet fever, which happens after the pharyngitis happened by this Streptococcus pyogenes. So what's going to happen after the pharyngitis is caused by the Streptococcus pyogenes? The pyogenes which have the toxins of this, toxic shock syndrome like toxin, they causes this sandpaper like rash all over your body, which is a very small maculopapular type of rash, which is very blanching in the nature. So what they will give you is a case of a pharyngitis patient. The patient will have a history of pharyngitis, and now they're presenting to your emergency department with some kind of a sandpaper-like rash all over their body, or the blanching rash all over their body. When you look upon the tongue of these patients, what you get is a strawberry tongue, which is a tongue having these reddish dots. Okay, tongues with the reddish dots. And this is the scarlet fever that you get after the pharyngitis caused by the Streptococcus pyogenes. Okay. Then the direct invasion of these organisms. Okay, you will get these pyogenic infections, and first is your pharyngitis. Of course, like I told you, after the pharyngitis you can get the rheumatic fever or the PSGN. Then just like your Staphylococcus aureus, they can also cause the cellulitis, but they do not cause the abscess. Very important. They will cause the cellulitis, but they do not cause the abscess. So the cellulitis are caused by these organisms are non-purulent or non-fluctuating cellulitis. They will just get the very red nodule over the skin. You will get the fever, the reddish nodule, which is very painful, red and warmth, but no abscess. Okay. Just like the Staph aureus, after the invading your skin, you can get the impetigo, okay, which will present as the honey crested lesions. Okay. And please remember one fact: the bullous impetigo is only caused by the Staphylococcus aureus, while the non-bullous type of impetigo is caused by both the aureus as well as the pyogenes. Okay, in the bullous impetigo, you will have this orange or the yellowish colored bullas all over your skin. Okay, and then you will get the erysipelas. Erysipelas is a disease that involves your lymph nodes and the lymphatic pathways. It will cause the lymphedema, and a very localized lymphedema, I must say. You can easily localize the location, and it is it has very marked demarcation. Okay, marked demarcation you will have in the erysipelas. You will study that later in the dermatology section about the erysipeal disease, where you will get this kind of thing. Most oftenly you will get it near the ears. You will this is your skin, let us suppose, and you will get this kind of erysipeal, the raised area, and it is very properly demarcated. You can easily found the border of this erysipeal very easily. This is the border. So yeah, that's about the Streptococcus pyogenes. Every enzyme they have, every type of toxin they release. Okay, the different type of proteins they have. Okay, the enzyme I have listed, the DNases, the streptokinases. Okay, the toxins, the erythrogenic toxin, which is a toxic shock syndrome like toxin, the streptolysin O, the protein I told you about, the protein M. Okay, and yeah, that's it. The diseases that cause pharyngitis, tonsillitis, they can cause otitis media. In some amount, they can also cause erysipelas, skin infections, erysipelas, impetigo, cellulitis. Okay. Then toxic mediated diseases that includes a scarlet fever and staphylococcal like toxic shock syndrome. Okay. And the complications, which is the PSG and the rheumatic fever. Okay. So that's it about the Streptococcus pyogenes. And other very most important thing that step one might ask you, that how will you diagnose the acute case of the Streptococcus pyogenes? Like I told you, the previous case of the Streptococcus pyogenes can be diagnosed with the help of this ASO titer or the anti-DNase B antibody titer. But for the acute case of these Streptococcus pyogenes, you need to do the rapid antigen detecting test, RADT, or the group A antigen detection test, which is a gas antigen, group A antigen detection. Okay. Or you can set the cultures for the beta hemolysis. Please remember these three tests for the acute infection, either the RADT, either the group A antigen detection, or the cultures for the beta hemolysis. Okay. And please note that the ASO titers always takes 1 to 2 weeks to form after the infection is over. So you cannot diagnose the acute infection with this ASO titer and the anti-DNase antibody titer. Okay. And one more disease that I forgot to mention is a necrotizing fasciitis. Okay. In which you will have very muscle pain. It will affect the fascia of the muscles. So just like the myonecrosis, you will also get the muscle pain in this disorder. Okay. You will get the erythema, you will get the warmth, you will get a tenderness over the reddish area, you will get the fever. And apart from this fever, the symptoms of cellulitis, remember the fever, the warmth, the tenderness, the redness over an area. Along with the cellulitis symptoms, you will also get the shock. When the patient is having the shock along with the cellulitis, always think about the necrotizing fasciitis. Okay, shock along with the cellulitis. Always think about the necrotizing fasciitis. Any doubt? Any doubt?
No.
And which sample would you send to the lab for RADT? It would be a throat culture if the patient is having a pharyngitis. Okay, it would be a throat culture. Okay. Then comes the Streptococcus agalactiae. Let me clear these annotations. Okay, so the Streptococcus agalactiae, you need to know where they are found. So they are found in your GI tract and in your genital tract. Very important, they are found in your GI tract and the genital tract. They can colonize the vagina of the females, and that's why they causes most commonly the infections in the neonates, the newly born infants. They causes the infection, and they acquire the infection while passing through the infected vaginal canal during the delivery of the baby. Okay. Then you need to know how you can identify these organisms. So these are catalase negative, like I told you, and they are beta hemolytic. You can do the bacitracin test, and they are bacitracin negative or the resistant, and they're also PYR negative. But a special test is made for them, and this is a CAMP factor test. Okay, CAMP factor test. This CAMP is not the cyclic AMP, but the other name of the author which found this test. Okay, the CAMP test, very important. Okay, and what happens, because that these organisms are hemolytic, beta hemolytic, they have this complete hemolysis. So if you add the if you add the Staphylococcus aureus in the colony of these bacteria, what you will get is the enhanced area of hemolysis or enlarged area of hemolysis. So if you're having some kind of a the colony of a bacteria and you added the Staphylococcus aureus in them, and if you get a very enhanced area of hemolysis or increased area of hemolysis, that means you can be sure that they are the Staphylococcus agalactiae. So very important, the CAMP factor. And of course, the Hippurate test you can do to diagnose these bacteria. So PYR negative, Hippurate positive, CAMP positive, and the bacitracin sensitive. Bacitracin resistant these organisms are. Then you need to know what kind of diseases they can do. So every disease that they can do, they will always infect the neonates, which are the newly born babies. Okay, and the newly born babies always acquire the infection of the Staphylococcus agalactiae by passing through the infected vaginal canal. Okay, and that's why you always have to do the screening of the patients, of the female pregnant patients, at 35 or 37 weeks of the gestations, to make sure the patient is not having this bacteria in the vagina. And if the patient is found to be colonizing the bacteria, what you will give is the patient in the intrapartum penicillin or the ampicillin. You will give the patient penicillin or the ampicillin during the delivery. Okay, please note this fact. You will give the intrapartum antibiotics. You won't give the antibiotics 2 to 3 weeks before if you diagnose this condition. Why? Because if you give the antibiotics 2 to 3 weeks before the delivery, what you will see is the loss of effect of the antibiotics. Once you give the antibiotics, you will clear the infection, but again after some time, when the drug is metabolized completely, you will see again these bacteria will colonize your vagina, and you will get the infection. So you do not give the antibiotics 2 to 3 weeks before the delivery, but at the time of delivery. Intrapartum is very important. Okay, yeah, that's it. And the disease that they can cause is the bacteremia in the neonates. And like I told you, after the bacteremia, the bacteria can go anywhere. And here in this case, they can go to the lungs, and they can go to the brain. So these are the most common cause of meningitis in the neonates, and as well as a pneumonia in the neonates. Very important. So whenever the step one will describe your case of a newly born baby, and the baby is found to have bacteria in the blood cultures, they're most probably talking about this Streptococcus agalactiae. Blood culture is very important. You will find the bacteria in the blood culture, and that's how you know that is a bacteremia. A way to tell that. Okay, then comes a Streptococcus bovis, and it is a natural reservoir of your GI tract, your gut. Okay, and you should know about how you can identify these organisms. So they are gamma hemolytic. They do not do any hemolysis at all. Okay, they are biosoluble, but they are 6.5% NaCl negative, and as well as the PYR negative. Okay, and the only thing that you should know about these bacteria is that they can cause a subacute bacterial endocarditis in case of the colon cancer. Because what's going to happen in the colon cancer, when the cancer grows, they will destroy your mucosal barriers in the GI tract. Okay, as the cancer grows, it will destroy the mucosal barriers in the GI tract. And what's going to happen when the mucosal barrier broken down, these bacteria can easily enter your bloodstream. And when the bacteria enter the bloodstream, they will go to your heart and can cause the endocarditis there. So please remember, the subacute bacterial endocarditis in case of colon cancer is caused by the Streptococcus bovis. Okay. Then the Enterococci, which includes Enterococcus faecalis and Enterococcus faecium. Okay. And how you can identify these organisms? By the same test, you will get the gamma hemolysis or no hemolysis at all. You will have this 6.5% NaCl positive. You have this PYR status positive, and you also have this biosolubility test positive. Okay. You should know they also colonize your colon. They are the natural flora of your GI tract. Okay. And in case of any manipulation of your GI tract or your urinary tract, for example, while doing the endoscopy, if you do the endoscopy in the patient, okay, and then what happened during the endoscopy, they can easily leak inside the blood, and they can cause a urinary tract infection in case of endoscopy of the urinary tract. You can get the bile tract diseases, or you can get the subacute endocarditis. So a classical case could be a patient who is undergoing any GI tract or the GU tract procedure. Might be cystoscopy, might be the colonoscopy, might be any endoscopy, and shortly after the endoscopy, they develop the endocarditis, subacute bacterial endocarditis, only in the patient that are having a previously damaged heart valves, not in the normal patients, but only in the patients that are having the previously damaged heart wall. So it would be a patient having a history of mitral valve prolapse, or might be a history of any damage to the heart valves. And now the patient is undergoing any cystoscopy or the endoscopy, and the patient then develops the endocarditis. Okay, a classical case could be presented like this only. So this is enterococci, and you please remember that remember the fact that they are VRE, vancomycin resistant species. Okay, they are VRE positive. They even resistant to the vancomycin, and that's why they are very important cause of the nosocomial urinary tract infections. They are the most common cause of hospital acquired UTIs. Very important. Hospital acquired UTIs, most important cause because they are VRE, vancomycin resistant. Any doubt? Any doubt? Please respond, guys.
No, sir.
No.
Okay, then comes the Bacillus anthracis. How you can identify the Bacillus anthracis? Well, of course, they are gram positive, but they are not coccis. Okay, they are not coccis, they are bacilli, and that's why the name Bacillus. Okay, and they're anaerobic or they're aerobic. They are aerobic, of course. Okay, and they have a special ability. They are spore forming. Okay, and like I told you, these bacillus are also have the capsules. Okay, but unlike the other bacteria which have this polysaccharide capsules, they have this polypeptide capsule. A very important fact about these organisms, these bacteria, that they do not have the polysaccharide capsule, but they have this polypeptide capsules, which is made up of polydiglutamate polypeptide capsules. Okay, okay, and they do not found naturally inside your body. Most important, they are the zoonotic organisms. Okay, they found in the animals like sheep. Okay, and with the sheep, it can acquired inside your body with the help of these spores, because they are the spore forming bacteria. You can easily ingest the spore of these bacteria by the sheep, or they can also use as bioweapons sometimes. Okay, and let's talk about the toxin that they have. They have this anthrax toxin, which consists of this protective antigen, which mediates the entry of this toxin inside the macrophages or the cells. Okay, so the protective antigen. Then comes a lethal factor, which is actually a zinc metalloprotease. Okay, and remember the function of metalloprotease, they destroy your collagen. Okay, and after destroying the collagen, that can cause the cell death. And the collagen is also found in your skin. So in the skin, they will destroy the collagen and they will cause the black scar formation. As you can see, this is a black scar. Okay, and it is caused by this lethal factor, which is a zinc metalloprotease. And then you have this edematous factor. Like I told you, it is an exotoxin that increases the cyclic AMP amount. And whenever you have this increased cyclic AMP, water will follow, and what you will get are the edematous borders. As you can see here, the borders are kind of raised up along around this scar, and these are the edematous borders caused by this edema factor. Okay, and a very special thing about their colonies, and you have to remember this buzzword, they have this medusa head appearance. Their colonies have a medusa head appearance. Very important. Okay, so two type of diseases, the cutaneous anthrax and the pulmonary anthrax. And of course you will also get the different type of anthracis. I will talk about later. Bacillus series, they will get the diarrhea. Okay, so two type of anthrax, which is a cutaneous anthrax and the pulmonary anthrax. In the cutaneous anthrax, what you will get is this scar formation, but before the scar there were these vesicles, papules and vesicles. Finally the vesicles will rupture and it will become this blackish scar. Okay, and the scars will be lined up by the edematous borders. It can rarely cause the death. Okay, don't worry, it won't cause a death normally. Then comes the pulmonary anthrax. What happens whenever you ingest the spores of this Bacillus anthracis species in your lungs? The spores will enter the macrophages using this antigen, the protective antigen, and inside the macrophages they will replicate. Macrophages will take them to the mediastinal lymph nodes or the hilar lymph nodes, both the mediastinal lymph nodes as well as the hilar lymph nodes. And inside these lymph nodes, the bacteria will replicate completely. Okay, because they have the spores, macrophages cannot destroy them, and after the spore germination, what you will see is the replication of these bacteria, and inside the lymph nodes, what you will get is the lymphadenopathy. Finally, the lymph nodes will rupture and you will get a dissemination of these bacteria. Okay. So what you will get is the hemorrhagic mediastinitis that will seen as the widened mediastinum in the chest X-ray. Very important, hemorrhagic mediastinitis, and that can lead to the shock and death. That can lead to the shock and death because you're losing your blood, right? And if you're using your blood, you will get the shock. Then before the full-blown symptoms, you will get this flu-like symptoms, which is the fever, headache, mild fatigue. And then finally, you are starting having these respiratory symptoms. You will have this chest pain, very severe chest pain. And on the X-ray, you will get this widened mediastinum. And because of the rupture of the blood vessels, what you will see is the shock. Okay. And please you remember two facts that it is mainly found in the sheeps. So the patient could be a man who is involved in some kind of wooling industry or somewhat related to the sheeps, or it could be a mailman, and it could be a patient who just receives a mail, opens it, and after receiving the mail, he got this pulmonary anthrax. Okay, two, three things: a potential bioweapon, mainly as a mailman. Okay, and second is the sheep. Please remember these two things. Any doubt?
No, sir.
Yeah. Then comes the Bacillus series, which causes the enteritis. Okay. Bacillus series is belong to same group, the Bacillus. They are spore-forming bacteria, of course. Okay, these are gram-positive rods, and they causes the food poisoning. But unlike the food poisoning caused by the Staphylococcus aureus, which is vomiting dominated, their food poisoning is diarrheal dominated. Okay, and you will get this reheated right syndrome, in which you just mildly warms your rice, which is mostly seen in the marriages, the bucket system, where you just mildly heat the rice, and you can acquire this Bacillus series through it. Okay, so two type of disease can happen, either the emetic type or the diarrheal type. If the disease is happening within the 5 hours after the ingesting, you will get the vomiting only, no diarrhea, just the vomiting. And because it is happening so rapidly, it is the toxin mediated, preformed toxins you will see. Okay, and then comes the diarrheal type, which causes the watery non-bloody diarrhea, and of course the GI pain, and it happens after the 8 to 18 hours because of ingestion of the spores. So please remember, when you ingest the rice, what happened in the in the kind of warm conditions, you will see the germination of the spores, you will see the replication of the bacteria, and finally the bacteria enters your body, and after 8 to 18 hours, they will release the toxins, you will get the diarrheal type disease. And after ingesting the preformed toxins, that you will ingest the toxin, not the bacteria, you will get this vomiting. Okay, and management would be supportive only because it is self-limiting disease. After some time, the effect of the toxins would be over and the symptoms will be gone. Okay. Any doubt?
No, sir.
Then comes the Clostridia, and the fact that you should know about the Clostridia species is that they are all the anaerobic organisms, and they are all the spore-forming organisms. So they are obligate anaerobes, and they are spore-forming gram-positive organisms. Okay, so first we'll talk about the Clostridium tetani. How you can identify it? It is basically bacilli, a gram-positive bacilli. Okay, and it is not naturally found in your body. Okay, you acquired this infection after encountering some kind of a wound. Okay, and just wait for a second. Yeah, Okay, so we are back again. We were talking about the Clostridium tetani, and you guys should know it is not naturally found in your body, but you can find it anywhere in the soils, of course. And you will acquire this infection after getting any wound, contaminated wound. Okay, and yeah, of course, these are the rods, and these are gram positive. They are spore forming, and they are anaerobes. Okay, now two type of the type of toxin they have is a tetanus toxin or the tetanospasmin. How does this toxin work? I've already told you that you have these snare proteins which lead to the release of neurotransmitters in the cleft of the synapse. Okay, and you have these Rancho cells which are found in your spinal cord, and they are involved in the inhibition of the reflexes or your muscle contractions. Okay, you will study about these Rancho cells later in the musculoskeletal pathway when we talk about this Golgi tendon reflexes. Whenever you have a too much of tensions, these Rancho cells will activate and will inhibit your muscle contractions. So now what's going to happen, because you're inhibiting the snare proteins, because you're cleaving the snare proteins, you won't get to release the GABA and the glycines, which are the inhibited neurotransmitters released from these Rancho cells. And as a result, what's going to happen? You will get the sustained contractions. You will get the contractions of a group of muscles. So what you will get is a torticollis. You will get the contraction of the neck. You will get the contraction of our spines. You will get the high arch back. You will get the clench fits. Okay, and you will get the lock jaw, which is the open jaw. You will get the raised eyebrows. And the spasms of the spinal extensors. Like I told you, high arch back. Okay, and yeah, ultimately what's going to happen if you do not treat this condition, your respiratory muscles would be affected, and what you will get is a spasm of the respiratory tract. You will get the paralysis, spastic paralysis. Okay, very important. How you can treat once you get the infection of this bacteria? How you can treat it? By giving the patient antitoxin. Remember, you do not give the antibiotic first. You need to give the antitoxins first, because it is a toxin that is causing all these symptoms, not the bacteria itself. Although you need to give the patient antibiotics to control the replication of the bacteria replicate locally inside the wound, and they will release their toxin in the nerve endings, nerve that are supplying your skins. Okay, and finally these nerve will go to your the spinal cord, where they inhibit the Rancho cells. Very important thing. And yeah, if the patient is not vaccinated, after giving the patient antitoxin, you will give him the vaccine booster, and this is a condition where you will get to see both the active as well as the passive immunity. The passive immunity we're giving by giving the patient antitoxin, which is an antibody against this toxin, and you're giving the active immunity by giving the patient vaccine boosters. Okay, and of course, for the immediate control of the muscle spasm, you can also give the patient diazepams. Okay, and you can also give the oxygen therapy to the wound. As I told you, these are the obligate anaerobes. So if you get a high oxygen therapy to your wounds, you can also destroy these organisms, one of the treatment. And yeah, the one thing that you must know, that you cannot give the vaccine to a newly born baby. Okay, you cannot give a vaccine to a newly born baby, because their immune system is so weak that even if you give the vaccine to that newborn, it will lead to the vaccination failure. Okay, so how you can protect the this tetanus in the newborns? First is the hygienic delivery. A most important thing is the hygienic delivery. Second most important thing is vaccinating the pregnant woman. Okay, so two things: vaccinating the pregnant woman, and second is the hygienic delivery. These are the two things that you can do to prevent a neonatal tetanus. Okay, and so step one can give you a case scenario of the neonatal tetanus by giving you the scenario like it would be a baby who is delivered at home in some kind of a tribe where they have this culture of putting the dung over the umbilicus, and they do not have any post pregnancy workups, no vaccination, no diagnosis. And then the mother is in your emergency department with the history of these spasms. The patient cannot cry. He had this high arched back. He had this clenched fits. He has this open jaw. And the patient will have very pain whenever you try to move the muscle group against the contraction. You will have this pain. Okay, a very important thing. So please remember the case scenario. it would be unhygienic delivery in some kind of a tribe. Okay, and they will ask you what kind of this intervention can prevented this condition from happening. So it would be the vaccinating the patient in the pregnancy, and second thing is the hygienic delivery. Very important. You cannot give the vaccine to the newborn patient because they do not have this well developed immunity, so it will lead to the vaccine failure. And please remember the fact that it is a clinical diagnosis only. There is no test developed, and you do not need to do any kind of test to diagnose this condition. Just the symptoms are enough to diagnose it. Okay, just the symptoms are enough. Then comes the botulinum, and just like your other clostridiums, these are also spore-forming organisms. They are also this gram-positive and obligate anaerobes. Okay, they have this heat labile toxins, okay, which actually inhibit, which cleaves the snare proteins and inhibit the release of acetylcholine in the neuromuscular junction, and as a result your muscles cannot be stimulated, so you won't get any muscle contraction. So what you will have is the paralysis, the hypotonia you will see, because you're not having any contractions. In this scenario, what you will have in the tetna, you will have this spastic paralysis, you will have the hyperreflexia. But in case of botulinum, what you will have is the hyporeflexia or the hypotonia. Okay, and please remember, in case of adults, they will ingest the preformed toxins, not the spores, but the preformed toxins. But in case of babies, you have this preformed spores. Okay, for the babies, preformed spores, and for the adults, it is a preformed toxins. Okay, how baby can acquire this disease? It is by the honey. Okay, so it could be a case where the patient would be a 1 or 2 year old child, and the mother was giving him the honey. Okay, and suddenly he develops this hypotonia. He's very, he become very sleepy. He all the muscle groups are very kind of non-contracting. Okay, the floppy baby syndrome you call it. Okay, ultimately what gonna happen, the respiratory muscles will be involved and the patient will die of the respiratory failure. Very important thing. Okay, and please remember the acetylcholine affects both your nicotinic as well as the muscarinic receptors. Remember, ACH for both muscarinic as well as the nicotinic receptors. So what you will get are the muscarinic symptoms as well as the nicotinic symptoms. So what you will get is a muscle paralysis because of the nicotinic receptors, and because of the muscarinic receptors, you won't get any sweating, you won't get any saliva. So what you will get is the dysphagia, you will get the diplopia because of this nicotinic symptoms. All the symptoms like that of myasthenia gravis, like diplopia, dysarthria, you will get the dyspnea. Because of the respiratory involvement, you will get a dysphagia. You won't get the sweating, you won't get the tear formation, you won't get the saliva formation, dry mouth. Okay, very important. And that's how you can differentiate between the myasthenia gravis and the clostridium botulinum infection. In both the scenarios, you will get the hypotonia and the muscle paralysis or the muscle weakness. But only in the in the clostridium botulinum, you will get the dry eyes, dry mouth, and no sweating, the muscarinic symptoms. Okay, very important thing to remember. And so how you can prevent this disease? Keep the honey out of the reach of children's. Okay, and adults can get this disease through the canned foods. Okay, like fruit juices. So yeah, please remove the fruit juices or the canned foods. Okay, and you also need to remember the fact that this Botox injection we have made, which is used to remove the wrinkles. You use them for the cosmetic implantations. You use them to remove the wrinkles, and also a disease known as a torticollis. Like in case of tetna, you will also get a torticollis in other scenarios also, where you get a contraction of one group of the muscles. Okay, and the patient will be in the pain. He will he will have the persistent cry because of the pain, and his mouth will be diverted at one side only. And this is a torticollis. So in the torticollis, what you give the patient is a Botox injection. And remember the disease, this uh, what is known as this, the esophageal spasms, achalasia cardia. Remember the disease achalasia cardia, where you get this esophageal sphincter contraction. So you will get the dysphagia and dilation of the esophagus. You give the patient Botox injection to treat this condition also. Okay, and to treat the hyperhidrosis, which is excessive sweating, you will give the patient this Botox injection, like I told you, they are also the muscarinic inhibitors. Because if no ACH, then you won't have any muscarinic receptor stimulations. Okay. Any doubt in botulinum toxin?
No.
Remember these three facts: the torticollis, the blepharospasm, the achalasia cardia, and the cosmetic areas. Also, you use this Botox injection. Okay. And remember the nicotinic and the muscarinic symptoms. Nicotinic symptoms include the muscle paralysis. Muscarinic symptoms include the loss of secretions. And please remember how the baby is acquired by the honey, and it is the spores, and how this adult acquired by the preformed toxins, and it is a canned foods like fruit juice. Then comes the Clostridium perfringens, and just like other Clostridiums, they are also spore forming, and they are also anaerobic bacteria, and they have a special type of toxin which is a cell lysis toxin, also known as a lecithinase or the alpha toxin, and it is a phospholipase. That means it is a toxin that destroy your cell membranes, causing the cell lysis. And where will they destroy the cell membrane? They will destroy the cell membrane of your muscles and on your RBCs. So what you will get is a myonecrosis and the hemolysis. And because they feed on the on the carbohydrates of your body, they will release the CO2 and other gases, and that causes the gas gangrene. As you can see here in the photo, this is the gas gangrene. Okay, so what you will get is the these gases in your lungs. Oh, sorry, in your skin. And so how they will describe these gases in your skin, they will tell you that on the auscultation, the patient was having this crepitus noise. These crepitus are, are the diagnostic for the gases. So what you will get are the crepitus beneath the skin. Okay, you can also see the gases forming these bubbles. Okay, and you can also do the X-ray of the arm or the limb which is affected, and you will see the hollow areas or the bubbles there. So that's how they will tell you that it is a myonecrosis with a gas gangrene. And tissue crepitus, very important. Hemolysis you will have. How you will get this disease? Of course, after having any kind of wound trauma, of course, wound contamination. And second thing, they also have a toxin which is the enterotoxins. They also have this enterotoxin which can cause the food poisoning. Okay, and how you will get the food poisoning? By consuming the spore contaminated food. If you left the food at less than 60 degrees centigrade temperature, what you will get is the spore germination of these bacteria. Finally, you will ingest the bacteria. Very important, you will ingest the bacteria. And after entering your GI tract, these bacteria will release the toxin, which causing this diarrheal symptoms. So, because it is a very longer process, you need to first ingest the bacteria. The bacteria will replicate, then they will form these toxins. The toxin will do their effects. So this process is going to take about 10 to 12 hours. Okay, and just like any other food poisoning, it is also self-resolving. After 24 hours, you will resolve your symptoms. So the shortest duration of the time will be seen in the Staphylococcus aureus, which is taking less than 5 hours, and it is vomiting dominated. Okay. Similarly, the Bacillus series, you will get this around 8 to 18 hours of time. Okay, and 1 to 5 hours for the vomiting. And then this Clostridium perfringens food poisoning, you will get this 10 to 12 hours of time. Okay, so please remember two diseases for the perfringens: the gas gangrene and the and this food poisoning. Okay, then comes the Clostridium difficile. Okay, you need to know about that toxin, which is a toxin A and toxin B. Okay, the function of toxin A is to recruit the neutrophils and causing the inflammation. Okay, how you will get the inflammation? By releasing the cytokines. Okay, and second is the toxin B, which causes the actin polymerization. Actin, remember your microfilaments. It will hack the microfilaments and use the microfilaments to go from one cell to another. And destroying the cell, they will cause the necrosis of the cell. They will destroy every cytoskeleton inside the cell, the actins, and causing the cell death. Then using the actin polymerization, they will move from one cell to another, destroying that same cell again, and that's how they will cause the necrosis. So in case of Clostridium difficile infection, what you will get is a necrosis and the inflammation. Inflammation due to toxin A, necrosis due to toxin B. Okay. And after, because the infects mainly your GI tract, what you will get is the abdominal pain and a watery diarrhea. And on the endoscopy, what you will see is a pseudomembrane. What is a pseudomembrane? how they will describe you a case of pseudomembrane. They will tell you that it is some kind of a X28 found on your GI tract in the endoscopy. You know, X28 was kind of very yellowish and whitish. So how they will show you the case of pseudomembrane? It is a yellowish whitish plaque in your GI tract that is seen in the colonoscopy or the endoscopy. Okay. And on the biopsy of the pseudomembrane, what you will see is the necrotic cells, the necrotic debris, inflammatory cells because of this toxin A, of course. And what you will get is the fibrin deposits. So fibrin, inflammatory cells, and the necrotic debris of the epithelium you will see in the pseudomembranes, of course. Okay. And how you will get the infection of the Clostridium difficile? By ingesting the antibiotics, especially the clindamycin and the ampicillin, because they are very high spectrum antibiotics. They will kill a large flora of your GI tract, and as a result, these this Clostridium these bacteria will replicate undoubtedly. Okay, because all of the flora is gone, they have this space for the replication. They will replicate, they will divide, and they will cause the infection. Similarly, the proton pump inhibitors, because the stomach acid is also required to control the growth of these bacteria. They will destroy by the acids. So if you take the patient PPIs, if you give the patient PPIs, you will not have the gastric pH. You will have very high gastric pH, you will not have the gastric acid, and as a result you will get the Clostridium difficile infection. Please remember these two drugs, the antibiotics and the PPIs, that can cause the difficile infection. How you can diagnose this condition after doing the colonoscopy or the bioscopy? The other thing that you can do is the NAT, which is a nucleic acid amplification test. It is the most important or the most sensitive test you can do. Okay, it is done by the PCR. You will take the DNA of the bacteria, you will multiply it using the PCR, and this is the NAT, nucleic acid amplification test. Okay, most important. And the treatment that you can do is to give the patient vancomycin, because they are gram positive organisms, and vancomycin cover every gram positive. You will give the patient oral vancomycin, because vancomycin is very poorly absorbed in your GI tract. Other conditions, whenever you have a bloodstream infection or any other infection caused by the gram positive organism, you will give the IV vancomycin. Okay, in case of this infection, will give the patient oral vancomycin, or you give the patient metronidazole and the fidaxomicin. Remember the drug name fidaxomicin? I told you about it in the biochemistry, I think, when I was talking about the RNA polymerase inhibitors. Remember, the fidaxomicin is one of those drugs, RNA polymerase inhibitors. Okay, and of course you can do the fecal microbiota transplant. There are some these probiotic things exist. You take the probiotics, you will replace the gut flora, and all is done. So it could be a patient who is having a recent history of hospital admission. It could be a patient who gone somewhere outside the country, and they will get this pneumonia or any other disease, and they will get this hospital admission, and after some time they are in your emergency department with this abdominal pain and watery diarrhea and abdominal tenderness. So step one can ask you what kind of a history patient will present. So it would be a history of any antibiotics use or a history of hospital admission. Okay, so that would say that the patient might be taking some antibiotics. And please remember that toxin B can cause damage to your cytoskeleton. That is the cause of the cell necrosis. And toxin A is responsible for the neutrophil chemotaxis and the inflammations. Okay. Any doubt? And yeah, one of the complications of this difficult infection is a toxic megacolon. What you will get is a massive dilation of the colon, and ultimately the perforation of the colon can happen. And when the colon is perforated, what you will get is the release of every microbe in the GI tract, and most importantly, the anaerobic bacteria. So what you will get is the abdominal abscess, and the abdominal and plus the peritonitis. And one of the symptom of the peritonitis is the rebound guarding. Whenever you palpate them and release your fingers, they will have this abdominal pain, very severe type of abdominal pain, and that is a sign that the patient might be having the peritonitis. And that could happen when your colon will be ruptured because of this difficult infections. Any doubt? I want responses. Any doubt?
No.
Okay, so we will take a short break and we will start then this diphtheria infections. Okay.
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 Thank you.
Short break for 10 to 15 minutes, okay? Okay, so now we're going to study about this Corynebacterium diphtheriae, which is a gram-positive rod, and it is basically our aerobic rod, not an anaerobic rod. Okay, and how do you transfer this organism from one human to another via respiratory droplets? Okay, it's a droplet infection that you must know, and it has a exotoxin. Like I told you already, it is a protein inhibitor exotoxin. It causes a ADP ribosylation of the elongation factor 2, and as a result, the protein synthesis is inhibited. As a result, the cell death and the necrosis will happen. And just like the Clostridium difficile, you will also get a pseudomembrane in diphtheria disease. And just like the difficult, they will describe this pseudomembrane as the whitish plaque in the pharynx or over the tonsils. Whitish plaque or whitish exudate over the tonsils or the uh, pharynx. Okay, and what would you see in the biopsy would be the what would you see? Is my screen is not visible?
The screen is not visible.
Oh, just wait for a second. I'm just a second. I forgot to start the screen sharing. Is it visible now?
Yes.
Yes.
Okay, so I told you, what would you find in the histology of the pseudomembrane? You will find the, all these necrotic debris would be found. Okay, the inflammatory cells would be found. You will find the organisms. You will find the fibrin. You will find the necrotic debris. Okay, then ultimately, what's going to happen that this toxin will go further into the systemic circulation, and from the systemic circulation, it can reach to your heart. Okay, it can reach to your CNS, where it can cause the paralysis. After damaging your nerves, you can get a local paralysis, the paralysis of your pharynx. Okay, and the pseudomembranous pharyngitis, a grayish whitish membrane, they will say. You will get the lymphadenopathy, which causes the neck swelling, and the patient will get this bull's-eye lymphadenopathy. It would be a swelling in the center of your neck, and what you will get is a bull's-eye lymphadenopathy. Toxin dissemination will occur, and what you will get is a myocarditis. If it goes to the the heart, you will get the arrhythmias in the heart, in the neuropathies because of the CNS dissemination of the toxin. You will get the paralysis in multiple the areas of your body, and most commonly it would be a local paralysis, would be the paralysis of this pharynx. So you will get the this uvula deviation also. You will get this dysphonia thing. Okay, or dysphagia also. Okay, and one of the important thing that you should know about these organisms, that they have this metachromatic granules, which are kind of a bluish or these reddish granules, and you stain these granules for the with the methylene blue dye or the aniline dye. Both are the same thing. Aniline dye or the methylene blue dye, you stain these metachromatic granules with. And there is this ALEC test you should remember. Okay, where you have this perpendicular line form in the toxigenic species and no perpendicular line form in the non-toxigenic species. For more details, you can Google it. But the ALEC test is for the Corynebacterium diphtheriae. Okay. Then how would you prevent the disease? How would you prevent the symptoms? How will you treat the disease when the disease once occurred? It would be to give the patient antitoxins, just like the tetanus. You will give the patient antitoxin in this case also. Okay. And of course, you will give the patient vaccine then. Okay, so the diphtheria case will only be seen in those patients who do not have any history of vaccinations. Okay, or would be a patient who do not have a history of vaccine boosters. Okay, it would be a patient who do not have any postpartum these postpartum trips to the doctor, or it would be a patient who do not have a history of vaccine booster. A old patient who do not have any history of vaccine booster, or nobody visit for a long time, for like years. Okay, so you can these might be the age groups or the patients. Okay, and yeah, that's it. And please remember that telluride agar, you will form the black colonies on this telluride agar, and you will have this Loeffler's media, very important, the Loeffler's media and the telluride agar for their culture. Okay. And what antibiotics you will use? You will use the penicillins or maybe the erythromycin to kill the bacteria, and you will use the antitoxins to destroy the toxin. And of course, you will vaccinate the patient then. Okay. So any doubt? Risk factors, you can see those who do not receive any childhood vaccine or those who do not receive a vaccine booster in every 10 years. So it would be a patient who do not have any history of OPD visits for like 10, 20 or 30 years even. So they were likely to get this diphtheria infections. Okay. So any doubt? No? Okay, so then comes the listeria, which is a gram-positive facultative intracellular organism, which means it can live inside the cell or even the outside the cell. And please note that this has a protein which is known as the, just a second, I'm forgetting the name of the protein. Listerolysin O. Okay, they have the protein known as the listerolysin O, which makes the pore in the endosomes of the macrophagic cells, and as a result, they can easily escape from the lysosomal destruction, and they can easily replicate inside the cytoplasm of the cell. Okay, so what happens once the macrophages ingested these organisms for the MHC2 representation? They will escape the endosomes and enter the cytoplasm of the macrophages, and as a result, they will replicate in the cytoplasm. And once they replicate inside the cytoplasm, what's going to happen? Instead of MHC2, they will represent on the MHC1. And now the CD8 immunity will happen instead of the CD4. So sometimes you will get the CD4 when they do not have the listerolysin O. But if they do have the listerolysin O, what you will get is the CD8 immunity. Very important part. Okay. And where do you acquire these organisms? By ingesting the unpasteurized dairy products for like milk, curd, or the cheese, or the cold deli meats. Okay, unpasteurized dairy products. And you must know that their organisms shows a cold enrichment, which means they can easily withstand very low temperatures, the refrigerator temperatures. Okay, so therefore, even if you put the food in the refrigerator, you will still get the listeria. Okay, and they also shows this actin polymerization. Remember the bacteria which also shows this actin polymerization? We have studied it previously.
Clostridium difficile.
Exactly. Clostridium difficile also shows this actin polymerization. What happens is when they enters the cell, they will hack the actin proteins, the actin microfilaments, and using these actin microfilaments, they will move from one cell to another, destroying them and then moving to other cellular cell. They will show the intracellular movement, and as a result, they can easily escape the antibody killing because they are inside the cell, and antibody will only destroy the extracellular organisms, not the intracellular. Okay, so for the extracellular organisms, you have the antibodies. For the intracellular organisms, you have this cell-mediated immunity. And if the organism is within the endosome and it will present it on the MHC2, it would be a CD4 immunity. If the organism is in the cytoplasm, this must be the CD8 immunity. Okay, they also shows this tumbling motility in the growth. Okay, very important. At the low temperature, they shows this tumbling motility. And this would not seen at the room temperature. Sorry, this would seen as a room temperature, but not at the human body temperature. Very important. This motility will only seen in the low temperatures. Okay. Then what they can cause? They can cause the infection of the amniotic fluid in the pregnancy. Amnionitis they can cause. They can cause the bacteremia in the pregnant females and as well as the children's. The neonates and the old age patients. Those patients who have these weaker immunity, like the old age patients or the patients on the glucocorticoid therapy or the immunosuppressive therapy, the pregnant females and the neonates, they can have this bacteremia, which can lead to the sepsis and shock and even the death. So how would they gonna present you? They will gonna present you the hypotension, the respiratory symptoms would be there, and fever would be there because of course the bacteria is in your body, in your blood, so you will get the fever. So fever, shock, and respiratory distress would be a symptom of a septicemia. You will either get the spontaneous abortion if you get, if the pregnant woman get this infection, or they can get something known as a granulomatosis infantiseptica, which is a widespread granulomas found in the infants. Okay, if the infection happened during the pregnancy, what they will get is a multiple widespread granulomas throughout the body of the infants, known as a granulomatosis infantiseptica. I know most of you might have missed it, so you can write it down somewhere. Most important thing. Then you can also get the meningitis in the immunocompromised patient, like the age groups I told you already, the old age patients or the patients on the immunosuppressive therapy or the glucocorticoid therapy, and even the children's, listeria can cause the meningitis in the children's. I think it's the third most common cause of meningitis in the children, in the neonates and the children's, okay? And they can also get the self-limiting gastroenteritis. So whenever you encounter a patient in the step 1 examination who is having the diarrhea and then the bacteremia, please listen, whenever you encounter a case of diarrhea and then a bacteremia, this is always going to be a case of your listeria. You can write this down. Whenever you have the diarrhea with the bacteremia or the sepsis shock, you will get you are most probably having this case of listeria in the exam. Okay. And please remember, it cannot be transferred by the air droplets. It can only be acquired by the dairy products or the cold lime meats. Okay. Remember these 2-3 things. I think that's all I have mentioned here also. Foodborne outbreak only can cross the placenta and test the fetus. They have this listeriolysin O, which can make spore in the phagosome so that they can easily escape the killing, and they will replicate in the cytoplasm so that the CD8 mediated immunity could be happen. They will hack the actin proteins, actin microfilaments. Using them, they will get this actin polymerization, moving one cell to another, escaping the antibodies. By invading the mucosa of the intestine, you will get the gastroenteritis, you will get the fever and the diarrhea, fever, vomiting, diarrhea, and then you will get the bacteremia also. Sepsis, meningitis can happen in the pregnant woman and in the immunocompromised patients. In the neonatal listeriosis, it will happen due to the transplacental transmission, or so what you will get is the respiratory distress, which could be present with the shortness of the breath, the trachypnea, high breathing rate would be there, the grunting sounds would be there. There would be a high temperature because of bacteremia. You will get this fever thing, you will have this hypotension. And yeah, that's it. And if the infection happened early in the pregnancy, what you will get is the granulomatosis infantiseptica. You will have this widespread granulomas throughout the body. Findings: if the blood, if they get the bacteremia, you will find the blood cultures positive for this organism. If they have the gastroenteritis, what you will get is the stool cultures positive for the bacteria. If they have the meningitis, you will get the CSF cultures positive for the bacteria. Okay, and please remember, E. coli is the second most common cause of meningitis in the neonates, and the third most common cause of neonatal meningitis is your listeria. And whenever you encounter a case of diarrhea with the bacteremia, it's most probably going to be a case of your listeria. Then one more thing I forgot to mention is about the Clostridium septicicum. It is one of the Clostridium organism, okay, Clostridium bacteria. Just like the other Clostridium bacteria, it is also spore-forming, gram-negative, and anaerobic bacteria. Now, just like your Streptococcus bovis, you get this endocarditis if you get this colonic infection, this colonic tumors, remember? And if you get a colon tumor, in case of this, if you get a colon tumor, in case of this Clostridium septicicum, what you will get is the myonecrosis, the gas gangrene. Okay, so if you get a patient who is having a history of gas gangrene presenting to your ER with the history of this pain and this bulla formations and this crepitus, this fever, the myonecrosis, and he will tell you no history of wound or any, any injury. Like, in case of perfringes, there must be a history of injury present, right? Only then you will get the history and you will get this perfringes infection. But in this case scenario, there won't be any history of wound. There won't be any history of injury because it is all intrinsic. If you have the cancer in the colon, what can happen during the breakdown of this colonic mucosa? All the bacteria will be leaked out, just like your Streptococcus bovis. You will also get the leakage out of septicicum. And after that, the septicicum can cause the myonecrosis. So it is all intrinsic. No history of injury would be there, but in case of perfringes, you will get the history. So whenever you get a case of this myonecrosis without any history of injury, you will always think about the septicicum. They can ask you, and what should be the next thing you will do. So you will diagnose them for the colonic cancers. Okay, very important. And yeah, that's it. Any doubt so far?
No, sir.
Excuse me.
Yeah.
What is the condition like if there is a CA colon and this scenario? Can you correlate? Because mostly it won't happen. There could be there should be some.
Could you please speak more loudly? I'm not able to hear you.
Yeah, I mean to say like, could you please explain how this occurs, like when there is a CA colon and these infections, like a typical scenario? Could you please explain it?
What you wanna ask you? Sorry, I didn't understand. If you can repeat it again, please.
Yeah, here is a colonic malignancy, right? CA
Yeah.
colon, and
Okay.
this infections, this gangrene. So this not always happen. So
Yeah.
could you please explain that what conditions, like what will be the scenario, typical scenario where this will occur?
Yeah, I have described already. It would be a patient who comes to emergency department with the symptoms of this hemorrhagic bulla formations. This myonecrosis thing. He will comes to emergency department with the muscle pain. With the fever, with the tissue edema, with this crepitus sound. And this hemorrhagic bullas. And he won't give you any history of any kind of injury, because for the streptococcus because for the clostridium perfringens you need to have a history of injury, right, in order to inoculate the bacteria in your body. But in this case, because this clostridium septicemum found in your GI tract, so patient won't present you with any kind of history of the injury. Okay, it is all intrinsic. And if they get the cancer will destroy the mucosal cells, mucosal barrier. And as a result, these bacteria will leak out from the GI tract. And they causes this, myonecrosis. So if the patient comes to emergency department with a history of this myonecrosis and they won't give you any kind of history of injury, you're always going to think about this colon cancer. Okay. And if they give you a history of this endocarditis and you found the bovis in it, so what you will think about is colon cancer again. Okay.
Okay, thank you.
It's just all intrinsic. No history of injury would be there. And if they give you a history, it must be the perfringes. And they will also tell you that the bloodstream, in the blood culture, they found this bacteria, the Clostridium septicemum. They will tell you this also. I remember they've mentioned it, that in the bloodstream they have found this bacteria. So whenever you get a septicemum, they will ask you what could be the next step that you will do. It would be your this colonic malignancy. And of course, immunosuppression plays a very important role. And just like in case of colonic malignancy, in case of inflammatory bowel disease, you are also damaging your mucosal tracts, right? You're damaging your mucosal barrier. So you can also get the Clostridium septicemum in this case also. But the most important one is the colonic malignancy to remember.
So we have to think about any the colonic endothelial breeze, like mucosal breeze.
Yeah, exactly. Anything which damages your mucosal barrier can lead to this disease. Okay.
Okay, good. Thank you.
Then comes your nocardia and actinomyces. Like I already mentioned, some 2-3 facts about nocardia, that it has this urease enzyme. It is obligate aerobe. It is an acid fast bacilli, just like your mycobacteria. Okay, but it is kind of a weak acid fast, not very high, but it is a weak acid fast. And both of these bacteria have this long branching filaments that resemble like the fungi, as you can see here in the diagram also. This is the acid fast staining, the bluish background and the pinkish bacteria, as you can see, acid fast staining. And as you can see, all these blanching thing, the branchings here. So these are the nocardia, and this is your actinomyces. Nocardia is aerobic bacteria and actinomyces is an anaerobic bacteria. And nocardia is acid fast, as I told you, and actinomyces is not acid fast. So where do you find the nocardia? It is found in your soil, and generally it do not cause infections in the immunocompetent patients. It causes just mild abscess in your skin if you're immunocompetent. But you become immunocompromised, then you're gonna have this pulmonary infections. You can get the symptoms like the TB. You can get this granuloma formation. You can get this TB symptoms, and you will have this acid fast staining positive. So you will think that it might be a case of TB, but then you have this filamentous things which are not found on the mycobacteria, and that's how you know this must be the case of nocardia, not the mycobacterium tuberculosis. You can also get the meningitis and the brain abscess in case of immunocompromised status if you have. Very important thing, brain abscess they can cause if you are immunocompromised. So pulmonary infections and brain infections, and of course if you have this brain abscess you can have the seizures as a symptom. Okay, how would you treat the nocardia infection? It would be the trimethoprim and sulfamethoxazole combination, TMP-SMX sulfonamides. Okay, then comes the actinomyces. Like I told you, they are the anaerobes which are found in your oral cavity, so they will cause the infections or the abscesses of your oral cavity. And once you have this aspiration of the oral contents in the lungs, what you will get is a aspirational pneumonia. And one of the extracted bacteria in the aspirational pneumonia is your actinomyces. Okay, so what you will get is the oral or facial abscess. Okay, and these oral or the facial abscess either drain to the sinus tract, or what happens, you will get some kind of a nodule formation over the angle of the jaw. You will get a non-painful, please remember the fact, it is always non-painful, very slowly progressive type of nodule you will see on the angle of the jaw. And what happens, this nodule will finally burst and it will release these yellowish pigments which are known as the sulfur granules. Like I told you, the aureus and the actinomyces has these yellow pigments. Okay, so what you will get, after the rupture of this nodule, you will see this yellow sulfur granules. Okay, and yeah, if do not rupture, what you will see is a drainage of this yellowish granules, sulfur granules from the sinus tract inside your oral cavity. Okay, and generally it happens after some kind of a dental process. It could be due to the dental caries extraction. Okay, what happens when you remove a tooth, they will inoculate there and they will go deep down until there is no oxygen available. And when there is no oxygen available, they can easily replicate, they can grow, and they can cause the infections. Okay, and of course they're involved in the pulmonary abscess also, very important. Okay, and so in the pulmonary actinomyces, what you will get on the biopsy or on the staining of the sputum is these pinkish areas. Okay, and this filamentous gram-positive organisms. Okay, how would you treat the condition? With the help of penicillins, very important. Okay, so for the nocardia, they do not cause any kind of infection in the immunocompetent patients. They cause infections only in the immunocompromised ones. They can cause the pulmonary infections that can mimic the TB, or they can cause the brain abscess. They will treat with the TMP-SMX, trimethoprim sulfamethoxazole, or in the actinomyces, they can cause either the oral abscess after the tooth extraction, or they can cause the pulmonary abscess or the aspirational pneumonia if you ingest the oral contents in the lungs. Any doubt? Then comes the mycobacteria, and all of the mycobacteria are your gram-positive, and these are acid-fast bacilli. They have this special type of cell wall that I already told you about, which are rich in the mycolic acids, and it is the mycolic acid which actually retains the this acid-fast stain, or the acid-fast stain. Okay, and there are multiple type of bacteria are there, like Mycobacterium avium intercellulare, or the Mycobacterium avium complex, Mycobacterium marinum, Mycobacterium sclerophilinium, and Mycobacterium tuberculosis, which you all are aware of. And because Mycobacterium, when they get phagocytosed by the macrophages, what's gonna happen? They have this something known as serpentine codes, or this code factor. It will inhibit the fusion of the phagosome and the lysosome. This serpentine code is also known as a trehalose demicolate. Remember the name? Trehalose demicolate, which is responsible for the inhibition of the fusion of phagosome and the lysosome. And as a result, what you will get is the unchecked proliferation of the mycobacteria. And what happens after some time, these macrophages somehow able to destroy some of the mycobacteria, and after that they will take these mycobacteria presented on the MHC2 to the lymph nodes in the hilar regions. Okay, they will present this MHC2 to the CD4 cells, and then after the activation of the CD4 cells, they will release the interferon gamma, and finally what happens is it will become the granuloma. Very important. Okay, And that's why you get a granuloma formation in the Mycobacterium tuberculosis infections. So what are symptoms of Mycobacterium tuberculosis? You will get the fever, the night sweats, the weight loss, cough, a cough which is more than kind of 2 weeks. Cough more than 2 weeks you will get, and it would be a productive cough, or sometimes a non-productive also. Sometimes you will get the a blood with the cough, which is a hemoptysis. Okay, very important, and that's how you diagnose the condition. You will do the PPD skin test, as you already know. PPD skin test, you will inoculate some antigen of the mycobacterium in your body, and if the nodule formation occurs within the 72 hours, you will say it is a positive PPD test. And if the nodule formation does not occur, it could be either of the two reasons. Either you do not have the immunity to develop it, you do not have the CD4 count to develop it, or okay, or there is no infection at all, of course, or there might be a chance that immunity has not developed till now, because it would take around a month after the bacteria enters your body. It would take around a month to develop the immunity against the bacteria. Okay, so it's only after 1 month when you get this PPD positive. So 3 reasons could be there. Either there is no infection. If there is infection, so that means there is no immunity developed till now. Either you are immunodeficient, or there is less than 1 month of the inoculation or the incubation period. Okay. And if you get the PPD positive, it could be due to the 2 reasons. First, you do have the infection, and second, you get the PPD positive in the one of the vaccines. Can you tell me the name of the vaccine, guys?
Glyvatin.
BCG.
BCG vaccines, yes. So this is a one way to diagnose the tuberculosis. And the second way is, of course, the sputum analysis. You will take the sputum of the patient, you will stain them for the mycobacterium. What you will get is the acid-fast bacilli. Third thing is to take a biopsy of your lungs. Okay, you will take the biopsy of the lungs and you will check them for the granuloma formations. This is a multinucleate giant cell that you can see, and this is your granuloma. It is a very characteristic feature of your granuloma. This is what you see. In the center of this granuloma, what you will see is the caseous necrosis also. Central necrosis, okay? And the fourth thing is the interferon gamma release assay. If you already develop the immunity against this tuberculosis, so what happens? You will take the blood sample of the patient and you will take the lymphocytes from it. You will inoculate the the bacterial antigen with the lymphocytes in the petri dish, and what you will see is the increased release of interferon gamma. Right? If you have developed the CD4 cells against the mycobacterium tuberculosis, what you will see is the increased release of interferon gamma, and that's how you know the patient is already exposed to the mycobacterium tuberculosis. Okay, very important. And then who forms the granulomas? Which interleukin or interferon form this granuloma? Which cytokine forms the granuloma? Interferon
Gamma.
gamma. And which cytokine maintains the granuloma?
Tumor necrosis factor alpha.
Alpha. Yeah, great. Okay. So remember the names, the Trehalose demicolate, and a bit check, okay? And then the Mycobacterium avium intercellare, they only cause a disease in the AIDS patient when the CD4 count drops to less than 50 cells. Okay, they will cause a widespread infection in the GI tract. You will see the diarrhea. You will get the fever, the night sweats, the weight loss, of course, just like any other mycobacterium infection. And you will get the lymphadenopathy in multiple areas of your body because it is a widespread infection. What you will get are multiple areas of lymphadenopathy. You will get the diarrhea, you will get the fever, weight loss, and night sweats. And it is happen in the AIDS when the CD4 cell count drops to 50 cells. Very important, okay? Then Mycobacterium scopholaceum, you will get this cervical lymphadenitis. You will get a lymphadenopathy in the cervical regions. And in the marinum, you need to know it must be a patient who is involved in some kind of fishing business. It might be a sailor, it might be a fisher, and they will acquire this infection after contacting with this water, which have this Mycobacterium marinum. You will get the hand infection, you will get the skin infections, okay? Very important. Just give me a second, guys. I'm pausing the video. It's an urgent call, actually. I need to accept it. see you in the meeting again. Okay, so we have discussed this Mycobacterium tuberculosis and this Myriam and everything about it. Okay, so please note the fact that these granulomas actually can never be eliminate the Mycobacterium from your body. They just enclose the Mycobacterium in it so that it won't get disseminate in your body. Okay, they just seal off the Mycobacterium. They can never destroy them completely from your body. Okay, so let's talk about every scenario that happens during the infection process. Okay, so once you get this Mycobacterium enters your alveoli, they will get phagocytosed by the macrophages. Okay, like I told you, and because they have this trehalose endemicolase, they will inhibit the phagosome lysosome fusion, and as a result, they can easily replicate inside the macrophages phagosome unchecked. And after 1 or 2 weeks, not just a one, after 1 or 2 weeks, what's going to happen is macrophages will take the bacteria to the hilar lymph nodes. Remember, I told you lungs will supply to the hilar lymph nodes, and trachea and esophagus will supply to the mediastinal lymph nodes. Okay, so macrophages will take the bacteria to the hilar lymph nodes, where some of the bacteria might be killed by the somehow by the macrophages, and they will be displayed on the MHC2 to the CD4 cells, T helper cells. Okay, then T helper cells get activated, releasing that interleukin by the interleukin 12, and in response, they will release the interferon gamma and interleukin 2, which activates the macrophages to form the granuloma. Now, those macrophages will become activated, will kill all the intracellular pathogens inside them. When the macrophages become activated, they will kill all the pathogens, all these mycobacteria inside the macrophages, and will seal off the extracellular organisms. Okay, so all those mycobacteria which are intracellular, they will get killed by the macrophages, and all the extracellular mycobacteria will be sealed off in the granuloma. Okay, and the formation is driven by the interferon gamma, and this maintenance is done by the interferon alpha. And note that fact that granuloma can never fully eliminate the mycobacteria from your body. It just kind of limits their proliferation. Okay, and yeah, the cavity that you see in case of this tuberculosis is not due to the bacteria itself, but due to the inflammation caused by this granuloma. You will study that later into the granuloma section of the general pathology. You will see that these holes you will see, these pores you will see in case of this tuberculosis. This is due to the inflammation caused by the granuloma itself, because of the cytokines or the inflammatory factors that it releases. Okay, they make this cavity lesion inside your lungs. Okay, very important. Please remember some risk factors that can lead to the TB activation in your body. That will be your immunosuppression, of course. If you suppress immunity, if you give the patient TNF-alpha inhibitor, or if you get the HIV, or if you get this glucocorticoid therapies, you will have this risk of activation of the tuberculosis. If you get the chronic diseases, for example, your diabetes mellitus, the renal diseases, the malignancies, you can get the risk of activation of the tuberculosis. If you have this malnutrition, and especially this vitamin D deficiency, you can note this vitamin D deficiency can cause the increased risk of tuberculosis. Asian populations have this high risk of tuberculosis. Okay, and yeah, that would be everything about the tuberculosis. So you have this primary tuberculosis and you have the secondary tuberculosis. Once when the bacteria enters your lungs, they will go to the lower lobe of your right side of the lung, because you know that this the angle of the trachea is very much low here, right? And so that the bacteria directly enters here. Let me zoom it. Bacteria will go to the lower lobe of the right lung. You will study that later in the respiratory section. Okay, and it will form a Ghon's focus here. Very important, it will form a Ghon's focus here. And once the macrophages has taken the bacteria to the lymph nodes, to the hilar lymph nodes, the involvement of the hilar lymph nodes now make it to the Ghon's complex. Okay, so 90% times the granuloma formation occurs and the bacteria would be sealed off in the granuloma. Okay, and the healing will be occur, the fibrosis will be occur, and then suddenly when the compromisation occurs, like in case of the old age patients, or might be the patient on these drug therapies, or might be the patient with the vitamin D deficiency, or might be the patient with the chronic diseases, it will have the reactivation of the Mycobacterium tuberculosis, and it usually occurs in the upper lobe, because upper lobe has very high concentration of oxygen as related to the blood, a very high, a very low VQ mismatch. Okay. And that's why you will, these bacteria will get very high oxygen concentration in the upper lobe of the lung. That's why the reactivation always occur in the upper lobe. So you will get a cavity lesion in the upper lobe, which is a marker for the activation of the tuberculosis that you can easily locate in the X-ray. And this cavity lesion is due to the granuloma itself, not due to the bacteria, but due to this granuloma, actually, right? And sometimes what's going to happen if you become immunodeficient again, you will have this bacteremia. Bacteria will enter in your blood, and like I already told you, after entering the blood vessels, bacteria can go anywhere. If it go to your blood brain, it can cause a meningitis. If it goes to your spine, it can cause a vertebral disease, which is a Pott's disease. You will study that later. If they go to your bones, it can cause the osteomyelitis. It can cause septic arthritis. They can cause a liver disease. They can cause a spleen disease. They can cause the multiple areas of lymphadenopathy, widespread granulomas, widespread calcification you will see in your body, and you will get this adrenal gland thing also involvement, right? So any doubt? Tuberculosis is very important to understand. Any doubt?
No, sir.
No.
Any doubt, guys?
No.
No? Okay. Then comes this leprosy disease, which is caused by the Mycobacterium larvae, which is again like just like other mycobacterias. This is also an acid-fast bacteria. Okay, and note the fact that it likes the cool temperatures, and these cool temperatures are found in your earlobes and in the periphery of your body, like your hands. And that's why the initial symptoms will occur only in the hands first. Okay, you will get the and in your ankles, of course, in your legs. So what you will get is a glove and stocking loss of sensations, because these are the colder regions in your body, right? Glove and stocking loss of sensations because of the damage to your nerves, or your cutaneous nerves. Okay. And how you can diagnose this condition? By the skin biopsy. You will take the biopsy, you will check for the bacteria there, and you can do the tissue PCR. You will detect the DNA of the bacteria, you will amplify it, you know that there is this bacteria present. Okay. Note the reservoirs in the United States. This is armadillos. Okay, you have the two forms of the diseases, actually two extreme form of the disease. Actually, the real disease is formed between these two. Okay, so the two extreme forms are lepromatous leprosy and the tuberculoid leprosy. Okay, lepromatous leprosy, as you guys know, for the immunity against the mycobacteria, you need the cell-mediated immunity, not the humoral immunity. Okay, in case of lepromatous leprosy, there is this defective type of immunity is present, which means instead of the cell-mediated immunity, what you get is the humoral response. Very important. You get the humoral response, not the cell-mediated immunity. And because of the fact that you require the CMI to fight the infections against these mycobacteria, you won't get the case here. You will have these antibodies which are, which are doing nothing. And so you will get this widespread replication of the bacterias, widespread dissemination of the bacteria. What you will get is this lion-like faces. Okay, you will get these granulomas. Everything is filled with the granulomas here. Okay, you will get the loss of skin sensations. You will get this, hair loss would be there. Plaque formation would be there. Okay, and it is of course lethal because you're not having any CMI to fight the infection. Okay, so disseminated or diffuse plaque would be there. Diffuse hyperpigmentation would be there. Okay, loss of digits could be there. Okay, loss of sensations would be there. A loss of hairs would be there. Then second type of leprosy is kind of a good sign because it is a tuberculoid leprosy, and now you have the cell-mediated immunity to fight the infection. And as a result, it is kind of a milder form. Okay, you have very low bacterial load because cells are there to destroy them. And everything you see, every symptom you see in this disease is due to the type 1 hypersensitivity immune response. Okay. the loss of sensations is still would be there. Hypopigmented areas would be there, but these are kind of patchy areas of hypopigmentation, and at the hypopigmented areas you will lose the sensations. Only patchy areas. Okay, and it is all due to the inflammation itself because of these immune cells, not due to the bacteria but due to the immune cells. And in case of this lepromatous leprosy, you are getting this loss of sensations, and it is because of the bacterial replication. Okay, it is due to the bacteria, not due to the immunity. Okay, and yeah, that would be about the leprosy. And yeah, one more thing is the lepromin test, just like the PPD test. If we have the cell mediated immunity, because lepromin test is also an example of type 4 hypersensitivity reaction. So for the lepromin test to be positive, you need the cell mediated immunity, and you do not have any cell mediated immunity in case of lepromatous leprosy. So what you will get in this lepromatous leprosy is a negative lepromin test, but you get a positive lepromin test in the tuberculoid leprosy. Very important, the positive lepromin test in the tuberculoid leprosy, and negative lepromin test in the lepromatous leprosy, of course. Okay. Any doubt so far? We have finished the gram-positive organisms completely, and now we are gonna go for the gram-negative organisms. Any doubt so far, guys?
No, no.
No,
No, we're good. Thank you.
I'm not able to hear anything. Okay, no.
No doubt, no doubt.
So now moving forward for the gram-negative lab algorithm. Okay, so just like the gram-positive organisms, they have these rods, they have these cocci, they have these branching organisms. You also have same thing in gram-negatives also. You have these cocci, which could be either the diplococci, which exist in pairs, or they could be the cocobacilli. For the diplococci, you need to know just one name, which is a Neisseria species. It could be a Neisseria gonorrhea. It could be a Neisseria meningitidis. And how you will diagnose it? It will diagnose by the maltose acid detection test. Very important, maltose acid detection. Remember the Staphylococcus aureus? Which sugar would you use?
Maltose.
Mannose, remember? Mannose for the Staphylococcus aureus and maltose for the Neisseria species. Okay. So if the maltose acid detection test is negative, this means it is the gonorrhea. If it is positive, this means it is the meningitis. Please remember the fact that both of them can ferment on the glucose, but only meningitis can ferment on the maltose. Okay. Then comes the Coccobacilli, which is the Haemophilus influenza, the Bordetella pertussis, the Pasteurella, the Brucella, the Francisella, and the Acinetobacter baumannii. Okay. Then comes the enteric rods. All of these organisms are your enteric organisms. Okay. And all of them are the facultative organisms. Either they are facultative anaerobes. Okay. All of them. And yes, let's talk about them. In order to we differentiate between these two type of organisms, you will do this lactose fermenting test. Okay, and you which agar would you use for this test?
McConkie.
Anyone, which agar would you use for this test? EMB, sorry, the McConkie agar. Okay, and if the lactose fermenting test is positive, which means if the McConkie agar shows up pink colonies, it is a positive test. And if the McConkie agar shows these no pink colonies, that means it is a negative lactose fermenting test. Okay, lactose fermenting organisms you can easily identify by the mnemonic SEEK. Okay, Citrobacter, Enterobacter, E. coli, and Klebsiella. Citrobacter, Enterobacter, E. coli, and Klebsiella. Okay, all these triple E and K are the fast fermenters, and this Citrobacter C is the slow fermenter. Okay, so E. coli, Klebsiella, and Enterobacter are the fast fermenters, and this Citrobacter is a slow fermenter. So for the negative lactose fermentase test, you will again do the oxidase test. If the oxidase is positive, that means it must be the Pseudomonas. Okay. If the oxidase is negative, then you again do the H2S production test. on the TSI agar. And if the H2S is produced, if the gas is produced, that means it is a Salmonella and the Proteus. And if the gas is not produced, that means it is a Shigella and the Yersinia. And you can note one more fact also, that these both organisms, the Salmonella and the Proteus, they are motile, versus these Shigella and the Yersinia, they are non-motile. So H2S production test as well as a motility test. If the motility test and H2S is positive, it means the Proteus and the Salmonella. And if the mobility test is negative and this H2S release test is negative, that means it is a Shigella and the Yersinia. Okay, then comes the curve rods. And all of the curve rods are the oxidase positive. Okay, and of course, they all have some special things to differentiate. Like if they grows in the 42 degrees centigrade temperature, if the curve rods grows in the 42 degrees centigrade temperature, this must be your Campylobacter jejuni. If the rods grows in the alkaline media, it must be your Vibrio cholerae. Okay, and if the rods grow in, if the rods have this urease enzyme, remember the Helicobacter pylori it is. Okay, get it out? I think no. And you can note one more point is that you will use the ceftriaxone and the fluoroquinolones mostly for the gram-negative rods. Okay, you will see that when you study about the the treatment of these of these organisms, you will see that most of them are resistant to the penicillins and the vancomycin, and that's why you use the ceftriaxone and fluoroquinolones mostly for the treatment of gram-negative rods infections. Okay, so I think that's it on this page. Then we will study every organism one by one. Now we will study with we will start with this Diplococci, and the first one is the Neisseria. Okay, you should know the reservoir for the Neisseria, and this is your nasopharynx where they resides. Okay, and you should know that the humans are the only hosts. Okay, and the most important scenario that they will give you for this Neisseria is basically a dorm student or a college student or a military recruits, because mostly the people who lives in a very close spaces, they can get this Neisseria infection. I'm talking about the meningococci. Okay, and you guys can also know that both of these organisms have this IgA proteases. Like I told you, if in order to colonize your mucosal tracts, you need these IgA proteases, right? And you have this lipo-oligosaccharide. Remember, every endotoxin, every gram-negative bacteria that has the endotoxin, they have this lipopolysaccharide thing. But Neisseria species are kind of some different because they have this lipo-oligosaccharide. Can you guys remember the organism, the bacteria that had this polypeptide capsule?
Bacillus.
Bacillus. Okay, and similarly in the Neisseria, you have this lipo-oligosaccharides instead of lipopolysaccharides. Okay, and yeah, they have this outer membrane, where in this outer membrane they have these proteins known as the outer membrane proteins. And like I told you, these outer membrane proteins are used in the conjugate vaccines as a conjugate. Okay, and step one can ask you how they will attach to the mucosal surfaces. So you will give the answer pili. Like I told you, the pili or the fimbriae are responsible for the attachment of the bacteria from the mucosal surfaces. And if they ask you how will the bacteria colonize, you will give the answer IgA proteases. Okay, so pili for the attachment, IgA proteases for the colonization. Okay, and if they ask you how will they enter the bloodstream, how will they survive the phagocytic damage in the bloodstream, you will give the answer the capsular polysaccharides, because they are anti-phagocytic. And if the step one asks you how will they cause the sepsis and the shock, you will give the answer lipo-oligosaccharides. Okay, so every protein, every capsule, everything has a different role in the Neisseria species. Okay.
So
and now we're
can
going
you
to discuss
repeat
about
that?
this gonorrhea and the meningococci. We will start with the meningococci.
Sir?
They have this polysaccharide capsules. They are diplococcus. Okay, they are aerobic bacteria, and the Thayer Martin agar is used for the culture of these bacteria. Okay, and you can also note a point that both the Neisseria species, the gonococci and the meningococci, they both can ferment the glucose. Okay, but only the meningococci can ferment the maltose. Very important, and that's why the maltose test is positive for the meningococci, not for the gonococci. Okay. Then the valence factor, they have this IgA proteases, they have this capsular polysaccharides, like I told you, they have this lipoligosaccharides, they have this pili, everything perform their roles. Okay. Then the diseases is basically the meningitis, okay, the Waterhouse-Friderichsen syndrome, and the meningococcemia, which means they will, once they will colonize your nasopharynx, what happen? They will replicate that locally in the nasopharynx, and then they will, peer through your nasopharynx, enter your blood vessels, and from the blood vessels, they will reach to your brain. And in the brain, they can cause this meningitis, very important. And because the organisms are in your bloodstream, they can cause the sepsis and the shock. And you will get the DIC. And due to this DIC, you will get the leaking of the blood from your blood vessels. Okay, because there is no clotting gonna happen. What you will get is the leaking of the blood. You will get the hemorrhages, and you will get a petechial rash. Very important. Whenever the step 1 gives you a scenario of a patient that is having a meningitis, and they will tell you the patient is having some kind of a rash on their body, reddish rash or the petechial rash, they are referring to you the Neisseria meningococci. Okay. And there is one more thing, which is the Waterhouse-Friderichsen syndrome. What's going to happen after entering the blood vessel? They can also go to your adrenal glands, and they can cause the hemorrhage of the adrenal glands. Very important. Hemorrhage of the adrenal gland. And what you'll see, the bilateral hemorrhage, most importantly. Yes, you will get the bilateral hemorrhage, and what you will get is the adrenal insufficiency, and this is the cause of death in the patients. So a classical scenario would be a college patient or a dorm student who comes to our emergency department with the acute onset of headache, fever, nausea, vomiting, and suddenly the patient is starting having these rashes all over the body, and the patient also developed this hypotension, and on the on the CT or MRI, you will notice this bilateral adrenal hemorrhages, and the patient might die even if you do not give him the glucocorticoids. Okay, any doubt?
Can you mention again the on top of the page, the 4 points we need to know?
Okay, so you need to know about the different proteins that are found in the Neisseria species. One is the pili. Like I told you in the earliest of this microbiology section, I told you about this pili thing, which help in the attachment of the bacteria from the mucosal surfaces. Okay, so if the step 1 asks you what what help in the attachment of the bacteria to the mucosal surfaces, it is the pili. If the step 1 asks you what helps the bacteria in colonizing the mucosal surfaces, it would be your IgA proteases, because without the IgA proteases, you cannot destroy the IgA antibodies. And like I told you, the IgA antibodies are involved in the mucosal immunity. It will protect your mucosal tracts, right? So by the IgA proteases, you will damage your IgA antibodies, and so that the bacteria can easily colonize. Then comes the capsular polysaccharides. If the step 1 asks you what protects the bacteria in the bloodstream, you will answer the capsular polysaccharide, the capsule, because the capsule is an antiphagocytic capsule, and that's how the Neisseria gains entry to your blood. Then if they ask you what is mediating the shock, the DIC, and this inflammation in the blood, this would be your lipo-oligosaccharides, which has this endotoxin. And remember the lipid A of the endotoxins, which causes a shock. So these are the 4 points that you must remember about the Neisseria meningococci, okay? And what does it causes? It will cause the meningitis first. Then you will notice the petechial rash all over the body. And finally, you can have this bilateral adrenal gland hemorrhage, which is the Waterhouse-Friderichsen syndrome. And you can die of it, okay? So what is the treatment? First of all, you will diagnose the disease either by the blood culture, of course, or you can do the PCR test, okay? And once a disease is diagnosed, you will give the patient ceftriaxone, very important for the meningitis. For the treatment, you will give the patient ceftriaxone. And for the prophylaxis, those who were in the contact with the patient, because it is a droplet infections, so those who were in the contact must given the prophylaxis, okay? And for the prophylaxis, you will give the patient rifampin, most importantly, and the most commonly used drug is the rifampin. You can also give the patient ciprofloxacin, but it's not used in the children because of a side effect. It can cause a damage to your connective tissues, like your ligaments, okay? And that's why you do not use mostly this ciprofloxacin as a prophylaxis in the children's. You can also give the ceftriaxone as a prophylaxis, but you need to know that ceftriaxone is available only in the IV form, and its injection is kind of painful. You know, this ceftriaxone is not available in the oral form, and that's why it is also not very much preferred. So the preferred drug is basically your rifampin, okay? And for the treatment, you will give the patient ceftriaxone, okay? And you can vaccinate the patient before the infection occurred. Okay, you can vaccinate the patient before the infection has occurred, but you cannot vaccinate the patient after the infection, because vaccination cannot cannot do any role after the infection has occurred. It can only prevent the infection from happening in the first place, okay? But once the infection has occurred, the only thing that you can do is to give the patient antibiotics. So the step one asks you about Okay, I'm sorry about that. I just lost my connection again. Am I audible to everyone now?
Yes, sir. Now you are audible.
Okay, so we were at the Neisseria meningococci. We have discussed it completely. Please do not answer the vaccine as an answer if the infection has already occurred. If they ask you how could you have prevented this infection at first place, it could be the vaccination. But once the infection is occurred, if they ask you the treatment, you will give the antibiotics, not the vaccine. Okay. Then comes a gonorrhea, which is Neisseria gonococci, and it do not have any polysaccharide capsule like the meningococci. Okay, first thing, and it can ferment the glucose but not the maltose, okay? And the pillars of this Neisseria gonococci has very has this RNA thing, not a Am I audible now?
Yes.
Yes.
I don't know what's happening. I just keep on losing my internet connection again and again. Okay, so yeah, we were talking about the pillars of the gonococci. Okay, and I've told you that these pillars shows a very highly antigenic variations among different Neisseria gonococci. Okay, so if you get infected from one kind of gonococci, okay, it has one type of pillars. Okay, and somehow you can you got recovered from the infection of the gonococci, and then you again get the infection from the gonococci. And you guys understanding what I'm trying to say? you keep on getting the reinfections from the gonococci because the pili shows the antigenic variations, and that is the reason we are not able to develop the vaccines against the gonococci. Because there are like millions of different type of gonococci exist right now, and you just cannot make vaccines for every this gonococci. Okay, and that is the reason why once you have this gonococci, you cannot develop the immunity against it. Okay, you get infection from. Am I audible again? Okay, so am I audible again, guys?
Yes, sir.
So much interruptions. I'm sorry about that. Okay, so reinfections from the gonococci are very likely. Why? Because they have this pili, and pili shows a very high antigenic variations among different gonococci. Okay, so if the staff ask you that there is a patient who got the gonococci before, he completed the course of antibiotics, and now again 2-3 months later he's presented to the emergency department with same gonococci. Why the reinfection has occurred? You will give the answer because of this pili, because they have this antigenic variations. And if they ask you why the vaccines are not able to develop till now, why? Because they have these antigenic variations. Okay, you should know that this is a sexually transmitted disease, while the meningococci is a respiratory transmitted disease. Okay, and once you get this this okay, so can you listen me, guys?
Yes, sir.
Yes, sir.
Okay, I'll shut down my phone. Okay, so now where were we? Yeah, so if the step one asks you about this vaccine thing, you can answer the pili. If they ask you why the patient keep on getting the reinfections again and again, even after he has completed the course of the antibiotics, what you will answer is the pili. Okay, and it is a STD, of course. And the signs and symptoms of STD includes a discharge from the urethra. Okay, the first thing. Second thing, you will get this UTI symptoms, which is a dysuria, increase in the urinary frequency, burning pain on the micturition, and most important is the discharge from the urethra. This is the STD. Okay, and this is the gonorrhea. Okay, this bacteria can also gain access to the bloodstream, and once it gain access to the bloodstream, it will go to your joints and can cause a septic arthritis. And you should know that the septic arthritis are of two types. One is the gonococcal and one is the non-gonococcal. So it has a special category of the septic arthritis. Okay, most of the septic arthritis are caused by this gonococci. Okay, it can also cause the neonatal conjunctivitis when the baby travels through the infected vaginal canal. He can get the neonatal conjunctivitis, and as a result, for every birth, you have to give the patient erythromycin eye ointment to prevent the neonatal blindness. Very important. You have to give baby neonates erythromycin ointment, eye ointment to prevent the neonatal blindness. Okay, and you can also get the pelvic inflammatory disease. Once you get this STD, it will travel upward into the vagina, into the uterus, and to the fallopian tube, and to the ovaries. You can get this pelvic inflammatory disease. It can affect your liver, the capsule of the liver especially, and what you will get is the Fitz-Curtis syndrome. It affects the capsule of your liver. So what you get is the right upper quadrant pain. Hepatomegaly would be there, right? And this is a Gleason's capsule, if you remember. Okay. How will you diagnose the gonorrhea? It will be diagnosed by the nucleic acid amplification test. And yeah, one more thing I forgot to mention, if you get a disseminated neisseria, you will get these rashes all over the body. You will get the joint pain, like the septic arthritis. You will get the fever. You will get the fatigue. Okay. And yeah, you will get this rash also. Okay. Not this rash, but different type of rash. Yeah, these pustules would be there all over the body. No. So if they mention you a case of disseminated gonorrhea, they will tell you the fever, the patient is having a fever, joint pain, fatigue, and most importantly, is pustules. Very important all over the body. Okay. And complications include this PIDs, the Fitz-Curtis syndrome. Very important. So how will you treat the disease? Again, by giving the patient ceftriaxone, okay, or the azithromycin. And why you give the patient azithromycin? Because there are very high chances that you will get the chlamydia infections along with the gonococci infections. It is found that most of the gonococci infections has chlamydia also, and most of the chlamydia infections has this gonococci infections also. So whenever you want to treat a condition of the gonococci, you have to give the patient azithromycin or the doxycycline also in order to treat the chlamydia co-infection. So if the step one ask you about this about this STD thing, and they will give you a scenario where the patient receives only the ceftriaxone or the azithromycin, not the combination, and the patient then again came to the emergency department with the continuation of the symptoms. They will ask you why the symptoms still persist after giving the patient antibiotics. So you will give the answer because of inappropriate therapy or incomplete therapy. Okay. Very much important. You have to give patient both ceftriaxone as well as the azithromycin or doxycycline. Any doubt?
No.
Then comes the Haemophilus influenza, which is a gram-negative rod. Okay, and just a second. Yeah, Haemophilus influenza, which is a gram-negative rod, is a reservoir in your nasopharynx. Okay, and the transmission generally occurs in the aerosol way. Okay, from the droplets or from the air. Okay, what kind of blood culture you use for the Haemophilus influenza? We have talked about it. The the chocolate agar. Remember, it requires the factor 5 and factor 10, the NAD and the hematine, and which generate after the lysis of the RBCs. So you have to heat the blood agar in order to form the chocolate agar, which is required for the culture of this Haemophilus influenza. Okay. And yeah, one of the very important thing that you need to remember is the fact that these Haemophilus influenza generally grows along with the Staphylococcus aureus. You will see a very increased growth of this Haemophilus influenza near the colonies of the Staphylococcus aureus, because these Staphylococcus aureus can cause the lysis of the RBCs. Remember, they can cause the lysis of the RBCs, which provides the factor 5, which is a factor NAD to the Haemophilus influenza. It's very important, and this is known as a satellite phenomena. So satellite phenomena for the Haemophilus influenza. Okay. Then you need to know about their virulence factors. They had this IgA proteases, which help them colonizing the respiratory tract. Okay, they have this capsular polysaccharide. They have this capsule which help them invading the bloodstream so that they can go anywhere. They can cause the meningitis. They can cause this pneumonia. Okay, they can cause this otitis media also. Okay, and yeah, two type of bacteria exist. One which have the capsule and one which do not have the capsules. Okay, one which have the capsules can cause some more severe infections, and those that do not have the capsule can cause some mild infections. And only the bacteria that have the capsule can be typeable. Okay, so you can type them in type A, type B, type C, type D. Okay, so non-typeable bacteria are encapsulated and typeable bacteria are capsulated. Very important. Okay, so non-typeable bacteria can cause some milder diseases like bronchitis, sinusitis, or otitis media, versus the capsulated bacteria or the typeable bacteria can cause more invasive diseases that includes the pneumonia, the meningitis, or the epiglottitis. Okay, we'll discuss the epiglottitis later now. Okay, so now we will discuss
about their capsule also. Yeah, one more thing I want to mention about their capsule is their capsule is made up of this PYR phosphate, okay, polyribitol ribosyl, sorry, polyribosyl ribitol phosphate pathway capsule, okay, very important PYR capsule they have. And their capsule also contains this factor H. If you guys remember, we have talked about the factor H, which is secreted from your liver, and it is hacked by these capsulated organisms so that they can inhibit the complements. If you guys remember, okay, so you need the antibodies against this PYR capsule. Very important. You need the antibodies against the PYR capsule, and that is what you can take by the vaccines. So step one can ask you why you use the vaccines against the Haemophilus influenza to get the antibodies against this PYR capsules. And you should know their vaccines are the conjugated vaccines. Okay. And yeah, let's discuss the diseases caused by the Haemophilus influenza. And this is your otitis media. You will have this ear pain, ear discharge. In the conjunctivitis, you have this reddish eye. Okay. In the epiglottitis, very important. It is a swelling of an epiglottis. And when you have the swelling of the epiglottis, you can even compromise the respiratory tract. Okay. And plus, this epiglottis will also bulge through your esophagus. As you can see, this is the endoscopy of the esophagus, and this is the epiglottis. So what you will get is a thumbprint appearance in the X-ray. In the later view of the X-ray, you are having this thumbprint appearance, and because epiglottis actually covers your respiratory tract, you will get the respiratory compromise. You will get the inspiratory stridor. Most important thing, you will get the inspiratory stridor, and there's a special positions these patients have, and it is known as tripod positioning. Very important. You will have this tripod positioning in the Haemophilus influenza epiglottitis. The patient will sit, with their neck extended and hands on the thighs. Okay, patient will sit with hands on the thighs and neck extended and mouth open in order to gasp for the air. Okay, and when they try to inspire, what they will get is the inspiratory stridor. And because there's a respiratory compromise, you have to use your extra respiratory muscles in order to respire, right? So what you will get is the use of accessory muscles that will seen as the suprasternal retraction or subclavicular retractions. Suprasternal, subclavicular retractions you will see while the patient is inspiring it. Okay, and on the endoscopy of the esophagus, what you will see is the cherry red spot thing. Okay, and this can also lead to the dysphagia. So whenever a patient comes to emergency department with this kind of a positioning, your neck extended, sitting with hands on the thighs, and breathing from the mouth, and inspiratory stridor, and this use of accessory muscles, and the dysphagia, you will always think about the epiglottitis. They will ask you what organism causes it. It will be the typable strains, not the non-typable strains, and the vaccines are directed against the typable strains only. Okay, because non-typable strains do not have the polysaccharide capsules. Okay, and they only cause these milder symptoms of the the otitis media, the sinusitis, and the bronchitis. Okay, and similarly, the typable strains can reach to your blood and then to the brain. They can cause the meningitis. Okay. So, any doubt?
So if the patient got epiglottitis, it's because of type B Haemophilus?
Yeah, exactly. Because only the type B capsular type Haemophilus can cause the most severe infections, more invasive infections that include your epiglottitis, meningitis, and the pneumonia. Okay, although they can also cause some minor symptoms also, the minor diseases like otitis media, sinusitis, bronchitis, but they can also cause the severe diseases. Okay, and the non-typable strains which do not have the capsule, they cannot invade your blood vessels, right? So they can only cause these milder diseases like a bronchitis, sinusitis, or otitis media. Okay, and because also you cannot swallow your saliva because of this epiglottitis, what you will have is a drooling. You will have this excessive saliva coming out of your mouth, the drooling. Dysphagia, drooling, inspiratory stridor, coughing, and the tripod positioning is very important that you will see in them. Okay.
Sir, can you please show the thumbprint sign?
What?
Thumbprint sign.
Oh, this is a thumbprint sign. You can see. Let me zoom it again. This is a thumbprint sign. And this is your hand and this is your thumb, like that. And this is an inflamed epiglottis. Generally, it would be very, very small, like it's just this much only. But in this case, it reached to like, there also this much big in case of epiglottitis, and the normal one would be like this much only, very small. So the thumbprint sign is very important. Please remember it, okay? Then comes your body pertussis, which is a gram-negative organism, and of course obligate aerobic it is. Okay, it basically colonizes your respiratory tract, but it won't reach to your lungs. Very important, it will never reach to your lung. It just remain in your tracheal tract only. Okay, very important. So gram-negative aerobic bacillus, and it has this virulence factors which include this pertussis toxin. Remember, the role of pertussis toxin is to disable the GI so that you get the hyperactivation of the cyclic AMP, and the cyclic AMP leads to the inhibition of the phagocytosis. So you won't get any immune response against the pertussis. Then you have the tracheal cytotoxin. Okay, and yeah, please remember this pertussis toxin is not responsible for the whooping cough that you see in the Bordella pertussis. Okay, what happens then? The next toxin is your tracheal cytotoxin. Okay, and the tracheal cytotoxin actually destroys the epithelium in your trachea. The respiratory epithelium is being destroyed by the tracheal cytotoxin that leads to the loss of the cilias. So what you will see in the patient are the loss of the cilias, and that's why every particle can reach to your lungs. Every bacteria, every organism can reach to your lungs directly, because it requires a cilia to trap them there, right? And that's why you get this cough, because of this tracheal cytotoxin. Okay, and they have one more protein which is known as the pertractin protein, which help them attaching the respiratory mucosa. So 3 proteins are very important: the pertractin protein, the tracheal cytotoxin, and this pertussis toxin. Okay, so first of all, you will get this very flu-like symptoms like fever, headache, some mild cough, and fatigue. Okay, and after some times, this cough keep on increasing and becoming very severe. And what you will get is a very long episode of the cough. You keep on coughing, and following by the inspiration, and during the inspiration, you will get a whooping sound, like okay, and this is a whooping cough. You keep on coughing, and during the inspiration, you will get this whooping sound. This is a whooping cough. And sometimes what happens, this cough becomes so much severe that you even end up vomiting. Okay, so what you will get is a post-cough vomiting or the post-tussive vomiting. Very important. Whenever the question is to mention a case where the patient is having this cough and the vomiting, the cough and the vomiting, they're always going to talk about the pertussis. Okay, and finally the regeneration of everything will happen, the recovery will happen, and you will get this quiescent state. Okay, and then the vaccine time. What vaccine will you give? It is a DTAP vaccine, and the AP part is for the pertussis. What kind of vaccine is AP? Acellular pertussis vaccine. What kind of a vaccine it is?
Combination vaccine.
Combination?
Conjugate.
Conjugate, yeah. The conjugate vaccine. And the DT vaccines? Toxoids.
Toxoids.
The toxoids with the conjugate vaccine. You must remember this fact, okay? So yeah, that would be it. And for the antibiotics, you will give the patient macrolides or the trimethoprim sulfamethoxazole. And please note the fact that chest X-ray is always going to be normal in case of pertussis, because it is not affecting your lungs, but the respiratory tract only. Okay, so you won't get any consolidation, you won't get any crepitus sound, you won't get any edema in your lungs. Okay. Versus if you get a cough due to the Haemophilus influenza or any other pneumonia case, what you will see is the chest X-ray having this consolidation thing. Okay, and thus you will get the cough which is a productive type. Okay, very important points. X-ray would be absolutely normal. Auscultation of the chest would be absolutely normal in case of pertussis. Okay, and you will encounter the case only when they say that the patient do not have any history of vaccines. Okay, do not have any postpartum management history or something like that. If they mention, then you will refer to the case of this pertussis. Then comes the brucella, which is a gram-negative Coccobacillus again, and it is a zoonotic organism. Okay, it basically found in the unpasteurized milk. So it is always going to be a case of a worker working in a milk factory. Okay, or it could be a basically community spread. It could be an outbreak that happens through the milk, which was delivering into the same localities. Okay, they will get this high fever, the night sweats, and the joint pains. Okay, and please note the fact that these granulomas are also found in the brucella. Non-quercetin type granulomas are found in the brucella infections. Okay, these are intracellular organisms, and that's why they replicate within the macrophages. And that's why the CD4 immunity will takes place, and CD4 immunity will leads to the creation of these granulomas. So unpasteurized milk, the milk factory is very important thing. Workers, okay. Then the Legionella pneumophila, very important. It is an intracellular organism, and that's why you generally don't see any gram staining of these organisms. In the gram staining, if you do the if you take the sputum of the patient infected with this Legionella pneumophila, you won't see any organism in it. Okay, you would just see the lots and lots of neutrophils, which are suggesting of the inflammation, but you won't see any organism because these are the intracellular organisms. So what stain would you use? You will use the Giemsa staining, not the gram staining. You will use the Giemsa staining. Okay. Oh, sorry, the silver staining, sorry, not the Giemsa staining. Although you can use a Giemsa staining also for the intracellular organisms, but you use a silver staining. Okay. And these are the gram negative rods, and the agar that they required is the CYE agar. If I told you, charcoal yeast extract agar, and they requires this iron and the cysteine additionally for their growth. And how you can detect these organisms? First is by the sputum analysis. Like I told you, you need to do the silver staining to check for these bacteria. And second thing, you can detect the antigen in the urine. Very important. You will do the antigen detection test in the urine. Third thing, these patients will have the hyponatremia. Very important. These patients will develop the hyponatremia. So labs will show the hyponatremia. Whenever you encounter a case of a pneumonia and the lab reports are showing hyponatremia, you will always think about the Legionella pneumophila. And because they are intracellular organisms, they will replicate within the cells, and so that they will be processed by the cell-mediated immunity, not the antibody immunity. Okay, and please remember their transmission very important. They only transmit through the waters, either through the AC, either through the hot water tanks which are found in the hotels or might be in the hospitals. So it would be an outbreak in the hotel, it would be an outbreak in the hospital, or it might be a case of a single patient having this air conditioning problems. Okay, no person to person transmission has been occurred. Okay, generally outbreaks are happening in the hotels and the nursing homes. Okay, so what symptoms would you expect in this Legionella pneumophila? It would be the diarrhea along with the pneumonia. Okay, first the patient will get the diarrhea, he will get the abdominal pain, the watery diarrhea, and then he started having these respiratory symptoms, which includes the dyspnea, this cough, this orthopnea, this crackle sounds. The X-ray will show the consolidations. So whenever you encounter a patient with diarrhea and the pneumonia, always think about the Legionella pneumophila. And most probably they will give you a case of a smoker and an old age patient. So a old age patient, smoker, diarrhea, and pneumonia. Always think about the Legionella pneumophila, okay? And labs will show the hyponatremia. How you will diagnose it? By the urine detection of, by the urine antigen detection. Of what agar would you use is a CYE agar. What stain would you use is the silver stain. Okay. Yes, that would be all about the Legionella pneumophila. Please remember the cell-mediated immunity, not the antibody immunity. Okay, and yeah, in the labs, you will have these high levels of lymphocytes, which suggest that the pathogen must be the intracellular pathogen. Okay, so any doubt? Any doubt, guys?
No.
No, sir.
Then comes the Pseudomonas. The facts that you must remember about the Pseudomonas is that they are all aerobic organisms. They are motile, like I told you. Pseudomonas and the Proteus, the Salmonella, they are all motile. They are catalase positive. Okay, they are gram negative, of course. They are non-lactose fermenting. We have shown that already in the table. They are oxidase positive. Okay, and you need to know that they're frequently found in the water. Okay, and they have this grape-like odor. Very important. They have this grape-like odor, and they're found in the water. So you can get the infection by swimming in the swimming pools. Okay, very important. And you know the fact that in the burn units, you're not allowed to take the flowers or the bouquets there because of the risk of the Pseudomonas aeruginosa infections. Okay, because they're found in the water. So you're not allowed to take the bouquets or the flower in the burn units because of this Pseudomonas. Okay, so now the time for the infections. And so what you will get is a pneumonia. Pneumonia could be associated with the in the cystic fibrosis patients, or it could be a ventilator associated pneumonia because of the biofilm formation. Very important, because of the biofilm formation, you get this pneumonia in the cystic fibrosis patient and the pneumonia in the ventilator patient. Okay, you will get the sepsis because it has this capsule, so that they can easily enter your bloodstream and they can cause a sepsis. You have this disease of the acthyma gangrenosum. We will study that later. And you have this urinary tract infections caused by the Pseudomonas, and not in the normal patients, but only in the hospitalized patients. You will see the UTIs. You will get the diabetic foot infection. So it would be a patient who is having a long history of diabetes or uncontrolled diabetes, and now he's having the infection of the foot. So diabetic foot infection is seen in the Pseudomonas. Then because it can easily access the blood, through the IV drugs. In the IV drug abusers, because they will inoculate this bacteria, sometimes you will get the osteomyelitis. Although it is very rare, but you can still get the osteomyelitis. And how will osteomyelitis present you? It will present you with the fever and the bone pain. And patients, cannot bear any load on their leg or on their hand in which the bones is involved, but their joint movement is absolutely normal. Okay. Then you have this otitis externa, which could be a malignant and non-malignant. Malignant mainly seen in the old patients, where you have this, extreme type of pain in the patient, and you have this ear discharge coming out of the external ear. You have this reddish inflammation in the ear canal also. Okay, and finally, what happens? It will destroy the skin, and it will try to invade your skin, and ultimately will cause the osteomyelitis at the base of the skull. Very important, can lead to osteomyelitis at the base of the skull, and they can also enter in your brain. After damaging the layers, it will enter your brain, can cause the CNS damage also. Very important. This is the otitis externa malignant type. In non-malignant type, you will just get the otitis externa, which do not have these complications. Okay, and generally occur after swimming in the swimming pools. It also known as a swimmer's ear. Okay, then you get the nosocomial infections that might be related to the catheters, might be related to the ventilators, of course. In the addicts, in the drug abusers, you will see this osteomyelitis. You can also see the endocarditis. Okay, although very rare, and they can cause the skin infections. And first is a hot tub folliculitis, which would be happen after you swimming in the swimming pool. It might be a couples on the vacation, and they got this rash all over their body, this pustular rash. Very important, their rash have this pus inside them. So it is a papulopustular rash all over their body, and this is the hot tub folliculitis, and it is a very pruritic rash. Okay, so patient have a history of swimming in the hot tubs, and they develop a rash which is very pruritic, and of course papulopustular type. Okay, they have this polysaccharide capsule which contribute they secrete the polysaccharides, mucoid polysaccharides, which is the biofilm, and which is the reason why they cause infections in the cystic fibrosis. Okay, and why they cause the pneumonia in the ventilated patients, and why they causes the eye infections in the contact lens patients. Okay, because of this biofilm productions. Okay, they have this phospholipase C, which can degrade the cell membrane, can cause a cell lysis. And just like the Corynebacterium diphtheria, they have this toxin known as the exotoxin A, which activates the elongation factor 2 by the ADP ribosylation, so that the protein synthesis could be stopped and yeah, cell death will occur. They have this endotoxin just like any other gram-negative organism, so that the fever shock could be happen, sepsis can happen. And they have this pigment known as the pyocyanin and the pyoverdin, okay, and which gives them the green color. Okay, and they also generate the reactive oxygen species. Very important, they generate the reactive oxygen species to kill other bacteria, and they got the diabetic foot in the diabetes patients. Then you can have the corneal ulcers or the keratitis in the contact lens wearers because of this biofilm production. And you can have a disease known as ecthyma granulosa, which is basically multiple necrotic lesions, as you can see here, will happen on the skin if you have become immunocompromised. So a classical case would be a patient who is either a burden patient or maybe a patient on the immunosuppressive therapies, or might be a HIV patient, or might be a patient on the glucocorticoid therapies. So immunocompromised status is must, and this immunocompromised patient develop the necrotic lesions all over their skins. So this is would be the case of your ecthyma granulosa. Okay, very important. Then the treatment and the classes of drugs that you will use. It is kind of very hard to remember what drugs are actually anti-pseudomonal drugs. So let's categorize them according to drug classes. Just wait for a second. Okay, so first the penicillins, which can act against the pseudomonas. These are the piperacillin and ticarcillin. Then comes the cephalosporins. That could be a ceftazidime, which is a class 4 agent, and cefepime, which is a class 5 agent. Okay, and then comes the monobactams like aztreonam. Then comes the carbapinams, which includes the imipenem, meropenem. Then comes the aminoglycosides like amikacin, gentamicin. And then comes the fluoroquinolones like ciprofloxacin and levofloxacin. So these are some drugs which could be useful against the pseudomonas. And if every therapy failed, if the carbapinum failed, aminoglycosides fails, monobactams fails, everything is failed, then you use a drug known as the polymyxins, which includes the polymyxin B and colistin. So in the multiple drug resistance cases, you will use these polymyxin drugs. Okay. Just categorize the drug classes and then learn the name of the drug. It would be easier to learn that way. Okay. So any doubt?
No.
Okay, then we will discuss about this Salmonella and Shigella. Both of them are the gram-negative organisms. Both of them invade our GI tract, our enterocytes. Okay, both of them causes the diarrhea, the nausea, the vomiting, the GI symptoms. And both of them invade these M cells of the hair patches, and these M cells are basically responsible for the antigen presentation in your GI tract. So every bacteria to which our bodies in our GI tract is developing the immunity is due to these M cells. They present the antigen to the hair patches where the lymphocytes are present, and finally the immunity could be made against these bacteria. So now we'll discuss the difference between these three type of organisms, which are Salmonella typhi VI, which has this capsule. Okay, then the Salmonella species except the Salmonella typhi. Okay, and then the Shigella. So reservoirs for the Salmonella, only the human reservoirs exist. Okay, for the Salmonella species, they are the zoonotic species. They can be transferred from the animals. And for the Shigella, only humans are the reservoirs. For the spread, they can reach to the blood vessels because they have this capsule, remember? And if they have the capsule, they can easily go to the blood. They can also go to the blood, but not always. Very rarely they can go to the blood, but they can for sure. And for the Shigella, they never go to the blood. They always remain within the enterocytes. Then the estuary production, as we learned in the flow chart, we have studied that Salmonella actually produces the H2S and they are motile. And versus Shigella, they do not produce the H2S and they are non-motile because they do not have the flagella. For the virulence factors, they have the VI capsule, and Salmonella typhi have this capsule. the VI capsule and the endotoxins, versus the normal salmonella species, except the typhi, they do not have any endotoxins. Shigella, sorry, they have just the endotoxins, and the Shigella do not have any capsule, just the endotoxin and the Shigatoxin. But you guys must remember, this is not the cause of their virulency. It is the invasion to the M cells they do that causes the Shigella disease, the Shigellosis or the dysentery. Okay. Then the infectious dose, very important. A very high inoculum is required to cause the infection by the salmonella, but a very low inoculum is required by the Shigella. Please note the fact, very low Shigella bacteria are required to cause the infections because they are acid stable. Then the effects of antibiotics on the fecal excretion. If you give the patient, salmonella patient, antibiotics, it will prolong the duration of the disease. Okay, but if you give the antibiotics to a Shigella patient, it will decrease the disease. Then comes the immune response. The immune response against the typhi, because they have this capsule and they can and they gains the entry in the bloodstream, they will be treated by the fighted by the monocytes. Okay, but the salmonella species who do not have the capsule, the neutrophils can destroy them. Similarly, the Shigella do not have the capsule, neutrophils can destroy them. Then the GI manifestations for the salmonella typhoid. What you will see first is the constipation followed by the diarrhea. Very important, constipation followed by the diarrhea, and of course the fever would be present there. In case of and please note that a diarrhea will always be the watery diarrhea. So if the question stem mentions a bloody diarrhea, it can never be typhoid. Okay. And the second thing, if the diarrhea happened in the salmonella species except the type, it would be a diarrhea, most probably the bloody diarrhea. Similarly, in case of Shigella, it would be a bloody diarrhea known as a dysentery. Okay, you will have this crampy abdominal pain and the bloody diarrhea. Very important. Then comes the vaccines. There exists a vaccine for the typhoid. Actually, two types of vaccines are there. Like I told you, the live attenuated vaccines, natural route would be followed, and this is the oral route. For the killed vaccines, you have this vaccine against the VI capsular polysaccharide, and this is the intramuscular vaccine. Okay. For others, you do not have any vaccine. Okay. Then comes the unique properties of every one of them. First is basically your typhoid, which causes the fever. Of course, the first symptom would be fever, then followed by the constipation. Then you get the diarrhea. You get the roth spots, which are very fine, spots over your abdomen. Okay, and later you can also get the GI ulcers. You can get the hemorrhage. You will get the hepatomegaly because they can access to your blood, right? So they can go to the liver, can cause the hepatomegaly, and they become dormant in the gallbladder. Please remember the carrier state is in the gallbladder, and reactivation of these bacteria can occur via gallbladder. Okay, GI bleeding and perforations are their complications. Very important. So step one, gonna ask you how would the how the immunity against this typhoid would be developed, and it is due to the monocytes. In the stools, you will get the monocytes. Okay, in the bloodstream, you will get this high monocyte count. And you can even found the bacteria inside the bloodstream. So bacteria can happen. Okay. Then you should some facts that you know about these other salmonellas. It's the fact that they can be transmitted by the animals like chickens, and especially your turtles, which are reptiles, turtles, snakes. Okay, eggs, hens. They can transfer these organisms. Okay, and yeah, gastroenteritis would be there, and which is very bloody diarrhea you will see. And the important fact is, in case of sickle cell anemia, these are the most common cause of osteomyelitis. Salmonella species are the most common cause of osteomyelitis in case of sickle cell anemia, and normally Staph aureus is the most common cause. Okay. Then some facts about the Shigella species, that they will enter in your lumen. Okay, and when they enters in your lumen in the GI tract, they will be taken up by the M cells. Okay, and M cells, they will form this phagosome or the endosome. Okay, but what happens is when they try to present the endosome to the CD4 cells, ultimately what happens, they will cause the lysis of these endosomes. Okay, And after escaping the endosomes, they will use this actin polymerization thing again. They will use this actin polymerization. They will hack the actin microfilaments of these M cells and will go to the adjacent enterocyte. Okay, let us suppose, let me draw a diagram. This is your GI lumen, okay? And this is the epithelium. This is the GI lumen, this is the epithelium, the enterocytes. In between the enterocyte, there found some specialized type of cells, which are the antigen presenting cells. These are known as the M cells. Okay. And the function of these M cells is to present the antigen to the pair patches. It's the lymphocytes present in the pair patches. Now, what happens when the Shigella enters your lumen? It will be taken up by the M cells. Okay. In the M cell, there forms the endosome formation. Okay. What happens now is this Shigella actually escapes the endosome by destroying it. And using the actins of these M cells, they do the actin polymerization and can transfer to the other cell, which is the enterocyte. They will destroy the cytoskeleton of this enterocyte, causes the necrosis of the cells, and that's how you get the inflammation. Whenever the necrosis happens, there always be the neutrophils present. Okay, neutrophils वहाँ पे आएंगी, you will get the neutrophils. There would be the inflammation, and that leads to the enteritis, inflammation of the GI tract, and you will get the diarrhea. So you understand the complete pathogenetic process of the Shigella. Any doubt in it?
No, we're good.
Okay, and so that's why I said that this Shigella toxin is not the key to their pathogenesis. It actually the M cells. Invading the M cells is the key to pathogenesis of the Shigella species. It has been found that the Shigella species who do not have the Shigella toxin, they are also capable of the infections, the same dysentery. Okay, so you always get the bloody diarrhea because of the necrosis. So in the stool findings, what will you get? The leukocytosis, the erythrocytosis. Okay, in the stool analysis of this salmonella, the typhoid, what you will get is the only leukocytosis, and especially the monocytosis. I must say, in the stools you will get the monocytosis, but no erythrocytosis because there is no blood. Okay, they can ask you what will be the stool findings. So if you are getting the blood, it would be the RBCs present in the stools. Okay, so that's the same thing I've written here that I explained you. Then comes the Yersinia enterocolitica, which mimics the appendicitis pain. Okay, and it is also known as a pseudoappendicitis because what happens is you will get the extreme abdominal pain at the appendix locations. But while doing the endoscopy or while doing the X-ray or the CT and everything, what you will see is there are the appendix is absolutely normal. So once the appendix is normal, but you're having symptoms just like the appendicitis, this means the patient is having a Yersinia enterocolitica. Okay, and it also causes acute bloody diarrhea, pseudoappendicitis, like I told you already, because of the inflammation of the terminal ileum. And you should know that the location of the appendix and the ileum is very close to each other, right? So once you get the inflammation of the terminal ileum, also in terminal ileitis, it can mimic the appendicitis pain. Then we will study the lactose fermenting enteric bacteria. I think we should stop here for now. What do you guys think? I think it's enough for today.
Yeah.
Yes, yes.
Yeah.
Can
We'll continue later tomorrow. Okay. I think we should wind up here now. Okay.
Yeah, sure.
Okay. Thank you so much, guys.
Thank you.
Thank you so much. Thank you.